The Royal Commission into Defence and Veterans Suicide is in session. Please be seated.
Yes, good morning, Mr. Ubagotti.
Good morning, Commissioners. Commissioners, in the witness box we have Ms Leanne Cameron and Ms Leonie Nolan. Ms Leanne Cameron is the First Assistant Secretary, Mental Health and Wellbeing Services in the Department of Veterans Affairs, which position she has held since April 2021. Prior to this, Ms Cameron has held a range of policy, service delivery and project management roles in the department, including the position of First Assistant Secretary of Client Engagement and Support Services Division from August 2019 to December 2020, and prior to that, various Deputy Commissioner and Director roles. Ms Cameron holds a Bachelor of Arts in Business Administration from the University of Canberra and a Graduate Diploma in Management Psychology from Charles Sturt University. Ms Cameron has previously given evidence to this Royal Commission, and that occurred on 15 March 2022. Ms Leonie Nolan is the National Manager of Open Arms, Veterans and Families Counselling, which position she has held since July 2022. As the National Manager, Ms Nolan is an ex officio member of and provides secretariat to the Minister's Independent National Advisory Committee for Open Arms. Prior to her present position as National Manager from November 2018 to July 2022, Ms Nolan was the Assistant Secretary for Coordinated Client Support Branch within the Mental Health and Wellbeing Services Division in the Department of Veterans Affairs. Also in 2018, Ms Nolan was the Deputy Commissioner for the Victorian region in the Department of Veterans Affairs. Ms Nolan holds a Bachelor of Arts at the University of Adelaide and a Bachelor of Social Work from South Australian Institute of Technology. Ms Nolan has previously given evidence to this Royal Commission, and that occurred on 12 April 2022. Open Arms is a mental health counselling and wellbeing support provider within the Department of Veterans Affairs. It is part of the Department's Mental Health and Wellbeing Services Division. With Ms Cameron and Ms Nolan, we will explore Open Arms' governance structure, the implementation of governance and risk management through policy making, Open Arms' clinical incident review procedure, which is just one process implementation of policy, but is a fundamental one insofar as it relates to Open Arms' response to suicide attempts, suicidality and suicide. And we'll also explore the effectiveness of Open Arms policies, procedures, and explore the systemic risks connected with suicide and attempted suicide and suicidality. I'll call the witnesses, and if the oath and affirmation could be administered.
Leanne Cameron, do you solemnly declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth?
I do.
Leonie Nolan, do you solemnly declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth?
Thank you.
Thank you. Commissioners, there are in fact three tender bundles, and operator, might I ask you please to display the tender bundle list first for Ms Cameron. Thank you, and I tender those documents.
Thank you. They'll be accepted and allocated the next lot of consecutive numbers.
Separately, there is a tender bundle list for Ms Nolan, if that could be displayed. And I tender those documents.
So that's 3 items. Yep.
And then there's one further tender bundle list, and that is the Open Arms Department of Veteran Affairs tender bundle. And I tender those documents.
Okay, thank you. They're all accepted then, allocated the next lot of consecutive numbers.
Thank you, Commissioners. Ms Cameron and Ms Nolan. As you would be aware, the Royal Commission issued 3 notices to give to Open Arms, to which Open Arms has responded. So on the 25th of October 2021, Open Arms responded to NTGOPA.001. On 6 September 2022, Open Arms responded to NTG.OPA.002. And on the 4th of October 2022, Open Arms responded to NTG.OPA.003. we will call those the first, second and third notices. Ms Cameron, on 12 October 2022, you provided a statement to this Royal Commission in which you indicated the matters in the second and third responses to which you can speak. Is that correct?
That's correct.
Operator, if you could please display document EXP.9999.0025.0001. DVA, I think we have that there, DVA. We have that there. Ms Cameron, is that the statement you provided?
It is.
Operator, if you could just move through the pages, I would be grateful. And you affirm that the contents of that statement are true and correct?
It is.
Thank you. And Ms Nolan, on 12 October 2022 also, you provided a statement to this Royal Commission in which you indicated the matters in the second and third responses to which you can speak. Is that correct?
Yes, correct.
Thank you. And if I can display that document, it should be DVA. And we have that there. And operator, if you could just move through the pages. And Ms Nolan, if you could confirm that the contents of that document are true and correct.
Yes, I can confirm.
Thank you. Commissioners, those two statements were supplemented by a letter dated 20 October 2022 by which the Commission was apprised in further detail of the matters to which the witnesses can respond, and in particular in respect of the first response to the first notice. So those housekeeping matters having been attended to, I might ask in the first instance Ms Cameron just to take us briefly to the history of Open Arms. Now this is addressed in the first response dated 25 October 2021. And if I can ask the operator to draw that up, it's OPA.0000.0001.0001. Now that history is indicated there, but for the benefit of the Commissioners and in particular the public, I would be grateful if you could briefly address the history of Open Arms.
Thank you, Ms Rubigotti. Open Arms was established in 1982. The service itself commenced prior to that, run by the Vietnam Veterans Association of Australia. It was originally a peer program and then moved into counselling. In 1982, after lobbying from VVAA, the Commonwealth Government agreed to fund and run the Open Arms service. Open Arms since that time has been a part of Department of Veterans Affairs and has grown considerably from a time when it was a handful of counsellors in each state and territory capital through today, 37 locations, nearly 500 staff.
Thank you. And did access change or expand over that period of time?
Access has changed and expanded. It was originally Vietnam veterans and their families. It expanded to all serving members who have been deployed. I believe that was about 2005 or around then. And then in 2018, the eligibility expanded quite considerably in line with the introduction of non-liability healthcare for mental health conditions to everybody who has served with 1 day of continuous full-time service, some other reservists who have seen hazardous service, as well as their families and in some circumstances extended families.
Thank you. And are there any restrictions on access to services by families?
So non-liability healthcare as such does not extend to families. It is only access to Open Arms, but the restrictions to those who have eligibility, they are eligible for all Open Arms services.
Thank you. And Ms Nolan, if you could describe briefly the purpose of and the services offered by Open Arms, what those services are.
Thank you, Ms Rubigotti. Open Arms provides a range of services to support veterans and families, including 24-hour-a-day counselling assistance, telephonically delivered. We also provide resources on our website. We have individual, family and relationship counselling, which includes couple counselling. We also provide group mental and social health programs. We have a peer support program, and just thinking, I think that might be about it actually.
Thank you. And Tommy, you've mentioned resources on the website. Do you have any means by which you can monitor the extent to which those resources are accessed by members of the public?
For some of those web-based resources we do, and that's through our strategic communications team who monitor that.
Thank you. Ms Cameron, I'd be grateful if you could now describe the governance structure of Open Arms. So that includes the governance processes, the frameworks and the reporting lines.
Okay, so Open Arms is a branch within my division, the Mental Health and Wellbeing Services Division. Ms Nolan is the National Manager of Open Arms, and she reports directly to me. I then report up through the Deputy Secretary of Veteran and Family Services. The Deputy Secretary reports directly to the Secretary of the Department. In addition to those organisational governance arrangements, we have a National Advisory Committee, which is a committee chaired independently, made up of experts and lived experience, defence representation and ex officio representation from the department. They oversee particularly major changes within the service, provide advice on policy changes and directions. And then under that, we have a range of regional advisory forums. They are run at the regional level by directors in each of our states and territories, 2 in Queensland. We have a North and South regional director. They are also comprised of stakeholders who help ensure that the connection to services, the embedding in the community, and any issues or barriers to care are addressed and at a local level by working cooperatively with other members of the mental health sector and defence.
Thank you. And you've mentioned there the Mental Health and Wellbeing Services Division. Was that established in 2020?
It was in April 2020.
And I appreciate it was before your time.
Sorry, April 2021.
April 2021.
Right?
Yes.
Yes. Sorry, I just went.
So you are in fact the first
I am.
in the position. Are you able to give any indication to the commissioners on the reasons for the restructure and what was behind it?
Of course. In late 2019, in discussion with the Deputy Secretary and the Secretary asked me to take on responsibility for Open Arms to look at whether in the short term I could glean if there would be any benefits to actually combining Open Arms and particularly coordinated client support. Both branches work very closely with our more vulnerable, our at-risk clients. We have had feedback over the years that the connection between some areas in the department is not as our veteran community would like it to be. They have to retell their story, etc. And starting with the most vulnerable seemed a logical place to start. Following a due diligence sort of period, I guess, in April 2021, the Secretary agreed that there was benefit to be had in bringing those divisions together. And in fact, we advised that not only bringing those branches together, but looking at whether or not there wasn't the opportunity to create a mental health programs branch, which we subsequently did. The benefit of that being that the learnings, the experience, the positive outcomes that we were achieving through both branches could then be vested in programs that reach far more broadly than just that vulnerable group.
Thank you very much. Now, if I might just take you to, no, I'll just find the relevant document number. Yes, DVA.503.0001.613 at .0619. I might read that out again. DVA.5023, yes, this is the governance policy, at 0619. So you can see there, I hope you can see there, I must say, some lines of accountability. Perhaps you could explore those a little bit further for the commissioners, to the extent you've not already covered. Would you like to do that, Ms. Cameron?
I think Ms Nolan
Ms.
would be
Nolan,
better
yes,
placed to do
certainly.
that.
So in relation to the to open arms, and I'm sorry, Ms Ribigotti, could you repeat the question because I'm not quite clear?
Yes, certainly. Might you explain the lines of accountability to the commissioners, and just to explain the relationship between the various parts, and so consultation and advice you see there, and then you see also the line from the minister going down to the director.
Sorry, I will take that, Ms Ribigotti.
certainly.
The original one was a bit lower level.
Oh, certainly.
Yep. So in terms of, so your question is then about at what level has what responsibilities?
Yes.
Okay. So if we start on the left-hand side with the Minister Secretary, that flow there, obviously the Minister sets the direction of the government of the day, and we respond to the Minister's requirements in terms of government policy, election commitments, budget announcements, etc. The Secretary has responsibility for implementing that and is ultimately responsible for the whole of the Department of Veterans Affairs, its performance, outcomes and delivery. There is a step in between the Secretary and First Assistant Secretary, which is the Deputy Secretary, as I mentioned before, Veterans and Family Services. That's occupied by Ms Vicky Rundle, that position. Ms Rundle is responsible for all of service delivery across the department, which includes the Mental Health and Wellbeing Services Division. And my role there is representing my branches, including Open Arms, on the governance committees that are off to the left, the Executive Management Board, Service Performance Committee, etc., and ensuring that Open Arms has a voice at all of those committees. Thank you very much. My role is also to make sure that we are connected across the rest of the department through policy, that our enabling services are in place and correctly supporting what we need. Ms Nolan, as the National Manager for Open Arms Branch, is responsible for the day-to-day operations, the delivery of services on the ground.
Thank you. And you see there's a reference to the National Advisory Committee, and I might direct this to Ms Nolan, given her role in that regard. And you have mentioned that briefly, Ms Cameron. Ms Nolan, might you explain the purpose and function of the National Advisory Committee for Open Arms and say something about your role?
At a state level, we have regional advisory fora, and they are run by the regional director in each of the states, and they enable us to consult with our local stakeholders, which includes ex-service organisations such as the War Widows, Partners of Veterans, local health services and so forth. Then at a national level, the National Advisory Council is a bit of a peak body, as it were, in terms of informing us at a national level as to what the needs of the community are and to provide advice to us and to the Minister and the Secretary in terms of things that may need to be addressed or program settings that may need to be changed in Open Arms.
Thank you. And tell me, when was the National Advisory Committee established? Are you able to indicate?
I'm not able to answer that. I might defer to my colleague.
The National Advisory Committee was not called that, but it was established in 1982 when VVCS, the Vietnam Veterans Counselling Service, was established.
Okay, thank you. And Commissioners, we have heard earlier in this session, these sessions from Dr. Brad Murphy. He is a member of that National Advisory Committee, as I understand it, and has given evidence in that regard. Thank you very much. Now, as to those lines of reporting, Ms Cameron, I might direct these questions to you. We wish to explore any challenges or opportunities that can arise by reference to those lines. And you can see that there are, in fact, dual lines of reporting. And might you be in a position to elaborate on those matters? So do you see, for example, any tensions in the arrangement, say relating to feedback, accountability to the Secretary, Commissions and the Minister? Can you comment?
Can I just clarify what you mean by dual lines of reporting?
Well, I mean in respect of going from the Minister to the Minister from Open Arms via the National Advisory Committee and then also the Secretary.
Okay. So the Advisory Committee is that. It is an advisory committee. It's not a decision-making board. So I think that needs to be on the record. The tensions for Open Arms and DVA are that Open Arms is, to the best of my knowledge, the only direct healthcare service within the Commonwealth. So it's in a very unusual position. It is not something that is experienced by any other department. Most departments that have a role in healthcare are as either policymakers or funders. DVA's role in healthcare for the rest of the department, apart from Open Arms, is very much as a funder. So the role is quite different and requires different clinical governance. We are we work very closely with the Chief Health Officer in the department, who provides oversight of clinical governance for the department as a whole. And we are in fact going through discussions with her at the moment about an overarching clinical governance framework under which Open Arms could nest. It having obviously different requirements to other areas, but it would still then be within a departmental framework.
And sorry, I don't mean to interrupt, but just as to those discussions, are you able to indicate what stage they're up at?
Early stages. Early stages. We have a framework within the division, which we have in draft form, and we're going through consultation with our staff at the moment, which is our divisional clinical framework. Open Arms would then sit within that again. So trying to make sure that Open Arms has a really clear home within the department as a whole. Some of the tensions prior to it becoming part of this division was that it did not have a voice on E&B. So it was, whilst everybody obviously had its best interests at heart, it did not have a formal place in some of our governance structures. So this has corrected that.
Yes, and just to clarify, it did not have a voice on...
Executive Management Board.
Thank you.
Yep. So this has corrected that by creating this division and having Open Arms reporting in it. We are very careful with the duty of care and the requirements placed on health professionals, their registration requirements, their practice requirements, and making sure that they are respected. That's why we need the frameworks over everything, but also making sure that we have a logical stop point at which client confidentiality ceases. And that ceases with, that's a really bad way of putting it, but I'll explain that, sorry. It ceases with Ms. Nolan. And by way of explaining that with an example, the case management system that Open Arms uses, Vera, I do not have access to it. I do not have access to client records from Open Arms. I do not need it to conduct my business and my role. And nobody that I report to has that either. That ceases with Ms. Nolan. So we're very careful about, whilst it's nested within DVA and the governance frameworks, the supporting architecture that's required to run a service like this, it still retains autonomy in that client-counsellor sense.
Thank you. And tell me, Ms. Cameron, do you see any tensions that arise from budgeting matters, as between, so for example, the Secretary having conflicting priorities or budgeting priorities? Is that an issue that arises?
It's not for Open Arms because Open Arms has its own special appropriation.
I see, thank you. And Ms. Nolan, do you have anything to add to that?
No, I do actually. Sorry, I said no, but yes, actually I do. Only to emphasise that one of the advantages of the establishment of the new division was to ensure that we were able to support clients across their journey, both in terms of their accessing of entitlements through DVA, but also then to provide that clinical support in Open Arms. And one of the risks for us prior to the division being established and Open Arms coming into that division was that a client may benefit from access to coordinated client support branch, which I used to run, but not necessarily have easy access to Open Arms or vice versa. So we were able to, with client consent, join up the support that we could provide to ensure that we could provide both that clinical support to the client through Open Arms, but to also provide that trauma-informed support from a case management perspective to the client through CCSB, Coordinated Client Support Branch, to ensure that they could access all of their entitlements, not just through DVA, but from a whole of government perspective.
Thank you. And that works in a practical perspective by reason of the coordinated client support. Do they facilitate that?
So Coordinated Client Support Branch assists veterans and families to access their entitlements through DVA and through other government departments. Open Arms is clinical and doesn't necessarily have the requisite expertise or knowledge to navigate the DVA departmental systems. So by joining up in the same division, we are able to work as a team to support vulnerable veterans and their families.
And does coordinated client support act as the interface, as it were, between both? Or it's a node point for both of those things, both the access to support, financial support, but then also the access to healthcare supports, and in particular mental health care support. Is that right?
Coordinated client support does have a role in assisting people to access mental health support across the states and territories if we're looking at interacting with the public health system, for example, but also in the private sector. But Open Arms has specific expertise in that in relation to our clinical care coordinators, whose specific role it is to assist veterans and families, but veterans to access that mental health care consistent with a stepped care model. May I elaborate?
Yes, of course you may.
Open Arms is a counselling service that provides psychological treatment, but we do not seek to replicate services that are available in the community, nor can we. So we are not technically a subacute facility. We are a community-based mental health service for veterans and families, but we need to contextualise the work that we do in relation to the broader mental health system. We can't provide everything to everybody, but what we can do is ensure that we have the appropriate clinical pathways for veterans and families to access the supports that they need at the time that they need it, but to also then be available to support them post-discharge, for example, if they do require an admission. So we work very much in concert with the Coordinated Client Support Branch through referral pathways, again with client consent, to ensure that we can pick up on the clinical aspect whilst the coordinated client support case managers can pick up on the entitlement aspects through DVA and from a whole of government perspective, as I mentioned.
Thank you very much, Ms Nolan. Might I turn to the regional advisory forums? And I wonder, is it Ms Cameron, are you best placed to speak to those, or Ms Nolan?
Both.
We could both.
Oh, both? Well, let me pose the question, or questions. I understand that there is a regional advisory forum and that meets twice a year, and that's guided by the National Advisory Committee, is that right?
I wouldn't say guided, but the regional advisory forums do report up to the National Advisory Committee so that they have visibility of any issues or opportunities on the ground.
And yes,
May I add in?
Yes, of course.
So the frequency of the forums at the state base are really informed largely by the regional directors. And for example, we do tend to run them twice a year, but we may run them more frequently depending upon the level of interest in the community. They are very much a sort of consumer and stakeholder-driven forum for people to raise issues or concerns, but also to receive updates. So we also link in with the regional forums that are run by the Deputy Commissioners, so they have a broader forum as well, so we link into those, and the Deputy Commissioners actually have a role at our Open Arms regional fora as well.
Thank you. And if I might display OPA.0000.0001.0001 at 20. I understand that feedback has been sought in relation to some forums, and you can see there the response to the first notice to produce, this response provided on the 25th of October 2021. You can see at 7.7 and 7.8 there's a description of the function and the operation of the forums, and you would agree with that outline there, I take it?
7.8, I would agree that is the focus of the forums. The 7.7 actually refers to a series of specific forums that were undertaken.
I see, that they're separate from...
Same forum, but with a really specific focus on peers.
I understand. And if I may turn now to page 0030 and take the witnesses to 11.4. You will see there that there is a reference to the type of feedback that has been received from the forum. And that is feedback given by the community. The community, as I understand, of veterans and ESOs and peers and stakeholders. And there are some key issues that have been identified there. And I draw your attention in particular, for example, to F, develop solutions to provide services to parents and siblings of serving members and veterans. And then also at G, very important topic of homelessness and housing instability.
Sorry, could you pop F and G back up? I read too slowly. Thank you.
And then also at H, there's the question of access, breaking down barriers to access and outreach. And then at I, you'll see there's a reference to certain gaps in service, in particular with quite a strong emphasis on families and children of veterans, as well as older veterans. You'll see also that at 11.5 it refers to an interim report that has been finalised or is in the process of being finalised. Now this response was given on the 25th of October 2021. Do you know if that report has now been finalised?
A report certainly came out of the forums that were referred to in 7.7, where a lot of this feedback was received. Look, I wouldn't call it a formal report as such, but certainly a summary of the issues that were raised, etc. That has been discussed. A lot of these issues have been discussed across DVA generally, particularly with our Veterans and Family Policy colleagues, and feed into their development of different initiatives, one of which went live just recently, which is the Acute Family Support Package. So these issues are live issues within the department.
Thank you. And are you able to give any indication to the commissioners, to the extent that it's referred to as an interim report or whatever report it be, whether particular recommendations have been identified, and if so, what they are?
I would need to take that on notice and have a look at the report.
Certainly, and that report is in any event something that can be provided to the Commission. Thank you. And do you know that whether there, to the extent that it's described here as being interim, whether any further reporting or analysis is being proposed in relation to the findings identified therein?
As I said, it feeds into certainly our policy considerations, but also our program considerations. Some of the recommendations are things which can only be addressed by government through budget processes. So we would feed into that process.
And Ms. Nolan, did you have something to add?
Yes, if I may comment.
Yes, certainly.
One of the ways in which we are addressing some of those recommendations is in developing a model of care to pick up on some of those cohorts that are identified at I in relation to children of veterans, including teenagers, female veterans, families experiencing bereavement and grief. And if I may comment, in relation to families experiencing bereavement and grief, one of the things that we are doing in conjunction with the Coordinated Client Support Branch and mental and social health programs is looking specifically at what postvention support we can provide following suicide to families. And in fact, I was speaking to the mother of a veteran a couple of weeks ago who felt that we weren't doing enough for the parents of veterans. And so I'm seeking to explore what we can do specifically for that group, which is consistent with the recommendations made.
Thank you. And are there any specific documents or analyses that have been undertaken in respect of those projects that you have indicated?
So we are in the process of developing the model of care with attention to those cohorts at the moment. So that is a work in progress.
Thank you. Are you able to give any indication as to when it might be developed?
So we're hoping to have the first draft available for community consultation in late January.
Thank you. And you'll see there that at G also mentioned is homelessness and housing instability. Is that a topic that Open Arms is looking at, and if so, what is it doing?
Indeed it is. The issue of veteran homelessness is one which is being addressed across the department through our colleagues in Veterans and Family Policy, and work has been undertaken to work with the social housing sector, in particular the Community Housing Industry Association, to develop a toolkit for social housing providers to alert them to what packages of care, as it were, veterans are entitled to. And in line with that, in Open Arms, we have been running a pilot with the Andrew Russell Veterans Living Centre in South Australia, which is run by RSL Care, to deliver an assertive in-reach program comprising community mental health nursing and peer support. That particular social housing provider has approximately 10 units which provide support to veterans who are released from incarceration or who are at otherwise risk of homelessness. And one of the things that we've identified in that homelessness space is one of the risks of homelessness is not just about housing, it is about the other supports that can be brought to bear to assist veterans specifically, but of course all people who are at risk of homelessness. In particular, support in relation to mental health concerns, drug and alcohol addiction, as well as other psychosocial factors which may lead the individual to become homeless. So the purpose of that particular pilot is for us to partner with an ex-service organisation, RSL Care, to deliver those services on an assertive in-reach basis so that the individuals don't have to seek that service. We have a referral pathway so that we can in-reach to that, and also ensure that we are then linking those veterans into established organisations such as Community Mental Health in South Australia, as well as other ESOs, to make their transitional accommodation as sustainable and successful as possible so that they then can go on to hopefully access longer-term social housing.
Thank you. And you've mentioned there a toolkit and a pilot program. Are you able to indicate to the Commissioners at what point that they have reached in their stage of development?
If I could take that on notice, because that's run by our policy branch,
Certainly.
but it's actually a great initiative.
Thank you. And tell me, do you know, Ms Nolan, how many homeless veterans there are? Has research been undertaken into this topic?
There has been quite comprehensive research undertaken, both by AHURI, which is the Australian Housing and Urban Research Institute, but also the AAHW, the Australian Australian Institute of Health and Welfare. Thank you. There are differing numbers, but I have to say any number is not a good number in terms of homelessness. And one of the opportunities for Open Arms is ensuring that we ask that question, which we do as part of our intake assessment, as to whether or not homelessness is a risk factor for that individual, and then to see what we can do through our referral pathways to support the veteran to access social housing.
Thank you.
And it might be worth mentioning in relation to homeless as well, Ms Veach did mention yesterday, but we also have a crisis accommodation program which Open Arms counsellors are able to access to help support short-term accommodation for someone who is experiencing something like homelessness or possibly domestic violence, to make sure that the client is safe and can engage with counselling.
Are you able to comment on the ease of accessibility to that program?
I'm sorry, I didn't quite
Are you
hear.
able to comment on the ease of accessibility to that program?
Yes, so it is accessed usually through people calling us through a Client Assist, which is our 24/7 telephone service, and identifying that they are at risk of homelessness, or it can be through the counsellor. We do try to ensure that where we are providing that support, that it is in the context of a package of care, so that we are not drip feeding and unwittingly producing a problem in and of itself through providing short-term housing, which doesn't actually resolve the longer-term issue of homelessness. And in fact, I had a call last night from a veteran advocate seeking assistance to homelessness for one of his colleagues. So it's something which is relatively well known. We have information about it on our website, but as I mentioned, short-term crisis accommodation does not resolve the problem of homelessness.
Thank you. And tell me, does the DVA or Open Arms actively look to identify the homeless?
Not as such, but only through people coming into our service. We always ask the question as to whether or not homelessness is an issue, as they do in Coordinated Client Support branch as well.
Thank you. And tell me, as to the access to the crisis accommodation, is there a wait list in respect of that, or can that be accessed immediately?
No, we don't actually have, there is no wait list because we do not own housing stock. We use the private sector, so largely hotel accommodation.
I see, thank you.
Sorry, Ms Rubigotti, can I clarify? It's not an entitlement as such. It's a tool for counsellors to use to assist, as Ms Nolan said, in a package of care.
Thank you. I might now return to structure, but more to the point, each of your roles within your division and the department, within Open Arms. I'll start, please, with Ms Cameron. Ms Cameron, if I could address your roles and responsibilities as First Assistant Secretary of the Mental Health and Wellbeing Services Division, and in that connection, could DVA.999.0025.0001 be displayed? That's your statement there. And then in your statement, you describe your current role in the terms indicated in paragraphs 5 and 6. If they could be focused upon, we would be grateful. And it goes over then to the next page. Ms Cameron, you state there that you're responsible for 4 branches, and we've just addressed Open Arms. Might you tell the Commissioners, please, what the other branches are responsible for, what they deliver?
So Open Arms, our coordinated client support, which Ms Nolan has referred to earlier, coordinated client support covers our triage and connect function, so the initial gateway into additional services and supports to help people navigate our services, external services, service coordination, which supports the families when they are bereaved and a veteran has died, also supporting families where a veteran has received a terminal illness diagnosis. We have case managers who provide generalist support to DVA processes, experts in how DVA works, how our processes work, what team does what across the department, as well as people with health professional backgrounds who bring expertise in the actual case management function. We have a team that focuses on under 30s transitioning veterans, so that vulnerable group, particularly identified through the AIHW report, those who are under 30 in the transitioning space, they are all referred through for case coordination. And we have our veteran support officers who are staff on base who are working from ab initio training through to the transition process with both serving members and chain of command in supporting all of those members. In addition to Open Arms and CCS, I have the Mental and Social Health Programs branch. It's a bit of a hodgepodge of a branch. It has a range of individual programs that we support: psychiatric assistance dogs, men's health peer education. We support Veterans Health Week, trauma recovery centres, or trauma recovery programs rather, run out of contracted facilities. Their role is to provide the backstage support to our service delivery, mental health service delivery teams, to make sure that they have the supports that they require, to make sure that the policies, procedures, etc. are clear, to make sure that what we need to actually deliver and measure our services is provided. And I also have our external communications branch, external communications focusing mostly, as the name suggests, externally, but also in support to the Minister's office.
Thank you, Ms. Cameron. Ms Nolan, if I could turn to you, please, and display document DVA.9999.0025.0004. This is your statement, and you'll see there you describe your current role in the terms shown in paragraphs 3 and 4. Now, in overseeing the delivery of these services, what does your role entail, Ms Nolan, on a day-to-day basis, and your responsibilities with specificity, please?
The regional directors and other directors in Open Arms report to me, and my role is to support the work that they do in delivering services in the regions, as well as having that strategic oversight of Open Arms and ensuring that we operate within that context of the broader mental health services and systems.
Thank you. And we have mentioned that you're an ex officio member of the National Advisory Committee. That's correct, isn't it?
Correct, yes.
Yes, and you provide secretariat to that through the executive officer. Is that correct?
Correct. The National Advisory Council hasn't met since I've been in this role, and we are in the process of revising the terms of reference for that to ensure that we have greater representation of lived experience in that group.
Thank you. And when will those terms of reference be finalised?
They're being worked through at the moment. I'm able to give a date, but we can get back to you in relation to that.
Thank you. Might I turn now to explore the topics of the philosophy of governance with you, some key tenets in corporate governance and clinical governance. We will put a series of propositions to you, and we would like you to indicate whether or not you agree with them, and later explore how they fit in with the structure of governance at Open Arms. So Ms Cameron, I might start with you. Is it correct to say that governance refers to a set of relationships and responsibilities that are established by an organisation among its executive, its workforce and its stakeholders, and they include its clients?
I would agree with that.
And you would agree with that, Ms Nolan?
Yes.
And then it incorporates within that a set of policies or procedures and customs that affect the way the organisation is directed. Would you each agree with that?
Yes.
And governance provides the structure through which the organisation's corporate objectives are set and the means by which those objectives are achieved. Would you agree with that?
Yes.
Thank you. And Ms Cameron, the arrangements also specify mechanisms for monitoring performance. Would you agree with that?
Yes.
And Ms Nolan?
Yes.
And you would agree that it's a fundamental aspect of governance that performance be monitored. And in the case of a healthcare organisation, you have, of course, corporate governance, but then there's also the concept of clinical governance. Is that correct? And might you explain the notion of clinical governance, perhaps, Ms Nolan? That's a question for you.
Clinical governance refers to the overarching structures which we have to ensure that we are delivering quality services at the right time to people who need it, as well as to ensure that our clinicians are supported in their decision-making and have appropriate escalation pathways to the relevant expertise to inform their clinical judgment and the delivery of clinical services.
Thank you. So in that case, you'd accept then that the organisation's governance system is fundamental to safeguarding and improving quality of care.
Correct.
And I think you have, at various times, you have each nodded in answer to those questions. If I could just ask you to say yes, I'd be grateful.
Yes.
I think it's accurate to say that you've each agreed with each of those propositions.
I have.
Yeah, thank you. And Ms Nolan, you
Yes.
certainly, thank you. And then the notion of effective governance, that involves providing a clear statement of individual accountabilities with the organisation, is that correct? And aligning roles?
Yes.
Thank you. And that is to achieve the organisation's objectives, isn't it?
Yes.
Yes. And that involves also the setting of direction and making policy and overseeing and monitoring, as we have indicated.
Yes.
And then might we then explore the topic of risk management? That's an aspect, of course, of governance. And that involves, does it not, the identification, assessment and prioritisation of risk, and thereafter the systematic application of resources to minimise and control that risk. Would you each agree with that proposition?
Yes.
Thank you. And that's an essential component of corporate governance, would you agree, and clinical governance?
Yes.
Yes.
And the objectives, again, are to maintain a safe environment for patients, the workforce and visitors. Would you agree with that?
Yes.
Thank you. And fundamental to those topics are the policies that the organisation puts in place. Would you accept that?
Yes.
Yes.
Thank you. And up-to-date and comprehensive policies are fundamental to effective governance. Would you each accept that?
Yes.
And that includes clinical governance.
Yes.
Thank you. And again, I think you're nodding, I'm told. So
Oh, sorry, I was saying yes. I might not be loud enough. Yes.
thank you. And we assume, but you might wish to confirm, this Open Arms, of course, subscribes to these tenets, does it not?
Yes.
And it is reflected in the various policies and governance policies that it has in place. Is that right?
Yes.
Thank you. And we might now consider some of those policies that you have established, keeping those main ideas in mind. And if I might ask the operator, please, to display DVA.5023.0001. Thank you very much. Now, Ms Cameron, you can see there this is the 100 governance policy. Would you please explain to the Commissioners its purpose at a fundamental level? What does it serve in the administration and conduct of the services offered by Open Arms?
Its intent is to do exactly what you have described in the lead up to this question.
Thank you. So we see there at point 2.1, it's drafted in connection with the vision to improve the quality of life of veterans. Is that correct?
Sorry, could you repeat that?
It's drafted in connection with the vision to improve the quality of life of all veterans.
Correct.
And it's connected then at 3.1, you'll see there's a reference to the purpose, and that is Open Arms' purpose in providing mental health counselling and wellbeing support services. Is that correct?
Correct.
Thank you. And I think one of the key principles, if we go to 4.2, is an accountability to the veteran community that is identified there. And you can see that.
Yes.
And that accountability, I take it, is identified and reflected in all aspects of Open Arms activities, including its policies that it puts in place to guide processes and service delivery. Is that correct?
That's the intent.
Thank you. And you'll see at 5.7 of this policy, it identifies each of your roles, so both the role of National Manager and the role of First Assistant Secretary. 5.17.
Mm-hmm.
And am I correct in understanding that this policy works in combination with other policies, a suite of policies, including the Open Arms Clinical Governance Policy, the Organisational Risk Management Policy and the Continuous Quality Improvement Policy, to identify potential problems and implement corrective actions and the like in the delivery of Open Arms services? Is that right?
Again, that's the intent.
Thank you. And the idea is to minimise errors and enhance efficiency and improve care. Is that correct?
Correct.
Thank you. Now, if I might turn to another of those policies, and that is the 102 Continuous Quality Improvement Policy. Now, that can be found at exp.007.0010.0299. Thank you. Now, Ms Nolan, might I ask you on this occasion to explain to the Commissioners the purpose at a fundamental level that this policy serves in the administration and conduct of Open Arms business?
Thank you, Mr Rigotti. This policy reflects the intent of Open Arms to undertake continuous quality improvement in relation to the delivery of clinical services as well as our wellbeing services.
Thank you. And you'll see at 1.1 the scope and 1.2 the scope is there identified, and it's to identify circumstances and opportunities for improvement in the delivery of the service offerings and the business support processes and clinical practices. Is that right?
Yes, correct.
And again, would you each agree that this is a fundamental document in Open Arms governance framework?
Yes.
Thank you. Might I ask you to, operator, to go to the last page, and that's EXP, it's page 0305. And you can see there, Ms Cameron and Ms Nolan, the document's been through 3 iterations, as I take it as indicated in the authorisation there. So
changes have been made on. Yep.
Certainly. I mean, the inception was 1 July 2020, and it's been updated. Changes have been made, but it's been in place for nearly 2.5 years.
Correct.
Thank you. And if I go now to 303, you'll see there's a reference to implementation and the National Manager. So you're called out here, Ms Nolan, and you're key to the implementation of these practices.
Correct.
And policies. Thank you very much. And I take it that you're familiar with this document and have familiarised yourself with the processes.
Yes, correct.
Thank you. And would you describe your role as crucial in its implementation?
Yes, from a leadership perspective.
Yes, thank you. Now, I want to explore the topic of monitoring and evaluation. If I can take you, please, to page 0302 of that document, and it goes over the page to 0303. You'll see there's a reference there to monitoring and evaluation. I'd be grateful if you could explain to the Commissioners what it entails and why it is important.
Mr. Ribogotti, if I may point out that the monitoring and evaluation component is under development, as it were, as identified in the document itself. One of the challenges for Open Arms is the history, which was predicated very much on what I would call a private practice model, where we operated almost as a federation of individual services with a state-based approach from a governance perspective. This policy represented the intent to undertake a more national and systemic approach to how we monitored and evaluated our services. We are hampered in that in relation to our case management system, our ICT system, which is again predicated more on a private practice type model rather than as a mental health service. So in line with the accreditation of Open Arms as a mental health service, there are many opportunities for us to improve on how we actually measure the impact of what we do and how we can report that impact, therefore to undertake a continuous quality improvement approach. It's not possible to do continuous quality improvement without a firm database, which provides baseline data and then opportunities to measure improvement and assess the impact of those improvements to lead to further improvement. One of the issues for us is that we don't have a system which enables us to report at a population level. The information is contained in a way that assists the individual clinician manage their caseload and their clients, not for me as a national manager with that strategic oversight to actually undertake a population-based approach in terms of our client population to measure the impact of quality improvement or to identify opportunities of quality improvement.
And tell me, Ms. Nolan, what are the barriers to that?
It's largely in relation to how the data is stored and collected. As I mentioned, it's a case management system principally rather than a mental health population-based system, which means that in order to identify things like level of risk attendant upon the client population, we need to go into each and every service file for the individual and then to do that manually. We had 40,000 clients last year, and that's not been something which has been feasible. One of the things I'm keen to explore is how we may alter our data collection to enable us to have that national oversight so I can report through to our First Assistant Secretary as to what the risks are for the population and what we can then do about it and to measure the impact of what we do. At the moment, we're not in a position to do that.
Thank you. And I note that the monitoring and evaluation has been under development since at least the first iteration of this this policy. And if you wish, I can take you to the document, but you're probably aware of that. Can you indicate what has happened in the past 2.5 years?
So in relation to the document at 5.8.05, we do have certain key performance indicators that we can report against. So some changes have been made consistent with the intent of this document. So we can describe the percentage of clients allocated to an Open Arms clinician. We can describe and report against the percentage of clients who actually see a clinician within certain identified time periods, as well as data in relation to things like waiting times. We also can collect data in relation to client satisfaction, which we're required to do as part of our reporting further through our governance structure for the department. So some changes have been made, and that's been very helpful, but further changes need to be made.
May I add to that, Ms. Ribogotti?
Certainly.
We did receive funding also in the 2021 budget to develop an outcomes monitoring framework, and we approached the market to contract somebody to develop that for us. The Australian National University has been working on that for us for a period of time. They expected to deliver a draft framework in the next couple of months. We will then go through a consultation process and a testing phase, and we are on track to receive a final framework at the end of the financial year. That framework will do partly what Ms Nolan was talking about there, enabling us to have a population-based look at outcomes, but also enable us to be benchmarked against other organisations who provide like services.
Thank you. And do you have any interim indications of what that framework will look like, or any recommendations that are coming out of that analysis?
So the analysis is, as I said, quite close actually to providing us an interim report. So we do have regular discussions with the ANU, but we are awaiting that interim report.
Thank you. And Ms Nolan, I think you mentioned wait times a moment ago, and that changes have been made in that respect. Might you expand on that and comment, please, on the nature of wait times through Open Arms?
So in the last financial year, we were able to measure the impact of some changes that we had made in terms of managing wait lists, for example. That change has been trialled in several of our regions, and we are seeking to roll that out consistently across the country. Those changes require us to adopt a triage approach, which we do consistently through the initial intake, which occurs through Client Assist, which is our national telephonic intake service, through to the work that we do at the regional level. The changes that we are seeking to introduce comprise a proactive approach to contacting people who are on the wait list to assess whether or not there has been any change in their acuity or the urgency of their need to see a clinician. And the wait list itself, the figures actually tell part of the story, but one of the factors influencing the time taken to allocate are clients' own preferences. So sometimes a client may wish to see the counsellor whom they saw previously if they're a returning client, or they may have certain needs which require a certain clinical intervention or assessment which is of scarce availability in the general community in terms of our referral pathways. In terms of our allocations for the last financial year, 57% of our clients were allocated and seen by a clinician within 14 days of coming into our service. The average duration of the wait time was 16 days and the median was 13 days, which means that there's 50% above and 50% below. If we look at the number of sessions or requests for services that we received in the last financial year, that was 11,787, and of those we were able to allocate 11,300, which means that nationally we had a wait list of 500. I'm sorry, that wasn't the last financial year, that's this current financial year. So we currently have a wait list across the country of 500 clients, thereabouts, and we're in the process of proactively working with those clients to identify what their preferences are, what the level of acuity is. Due to the scarcity of mental health availability in the general community, we're subject to that same scarcity. And I think in terms of our ability to ensure that people get access to the right service at the right time, we also look at what other modalities could be brought to bear, including telehealth, as Ms Veach described yesterday, as well as telephone-based counselling, perhaps people's willingness to see a different type of counsellor, but also bearing in mind that 50% of the services we deliver are in relation to couple and relationship and family counselling. That is where there is a distinct dearth at the moment, I think, affected by factors such as COVID in the general community.
Thank you. And might you indicate, Ms Nolan, the longest wait times of those who've had to wait well beyond 16 days, 14 days?
I'm unable to identify that at this point, but we can provide that if I can take that on notice, please.
Certainly. And you've indicated that you have 500 clients presently on the wait list. How does that? How are those clients spread geographically?
Again, I'd have to take that on notice.
Thank you. And who is doing the triage to bring down the wait list?
We have a role in each of the teams identified to do that. So it's usually the Assistant Director for Clinical Operations or a member of their team who will contact all the clients, usually on a weekly basis.
Thank you. And are you able to indicate whether there is a difference in the type of services and support that are required or that are sought by clients and differences in wait lists? So you've mentioned, for example, couple support. Might you comment on the other services provided in the wait list?
Access to psychiatry is in short supply, and certain specialisations, including things like services for children. So paediatric psychologists and psychiatrists, again, are in very short supply, and there are extensive waiting lists in the community. Services for assessing disability, specifically ADHD, that is also in very short supply. There are a number of different specialisations where there are not sufficient clinicians to deliver the services to meet the demand, and what we attempt to do is to support the client whilst we're waiting for them to be able to access those services in the community, but also to see what other services could be brought to bear to perhaps alleviate distress. And if I could just comment, I think this is where the peer program has such an amazing impact, because not everybody needs to see a clinician to alleviate their distress. And sometimes working alongside a peer, whether that be a peer with lived experience of mental illness and military exposure, or whether that be a peer from a carer perspective or family perspective, that can often be quite an important part of our staged care approach to ensuring that we can deliver services as much as possible to alleviate distress.
Thank you. And tell me, are there wait lists associated with peer support programs?
To my knowledge, we don't have a wait list associated with the peer support programs at the moment.
And what is generally the relevant waiting time, as it were? How long does it take to get access?
I'd have to take that on notice, but I suspect it varies very much across the regions.
Thank you, thank you. Now, Ms. Nolan, you indicated a little while earlier, and further work needs to be done. Might you, or further changes, let me quote you correctly, further changes need to be made in connection with the monitoring and evaluation process. Might you elaborate on that, and what changes do you see need to be undertaken?
If I may provide some context to my answer, from my background in running mental health services, there are key indicators that are used to measure the quality of the interventions provided, which usually include things like the duration of an episode of care or length of stay if it relates to an admission in hospital. There are also measurements in relation to readmission rates, so how frequently the individual may require support following the closure of an episode of care. And what I'm seeking to do is to align the measurements that we implement in Open Arms with some of those measures that are used in the mental health system from a states and territories perspective. Also looking at the client feedback mechanism that we have to ensure that we are able to get more granular and qualitative feedback to understand the impact of the services that we deliver. And at the moment we use a Likert scale, as it were, so a scale of 1 to 7, I think it might be, but I can take that on notice and my colleague might be able to comment. No, it's not a Likert scale. Okay, I'm wrong. So I'll defer to my colleague. Oh, you don't know? Okay, we'll take that on notice. But I think client satisfaction doesn't really tell you the whole story. And if I looked at the recent tranche of data that we have and an analysis conducted, we received as many compliments as we did complaints. And I think people are often motivated to give feedback for various reasons, and I'd be keen to have more of a consumer focus to how we actually obtain feedback from our clients who've used the service in relation to not just whether or not they were happy with their counsellor, but other feedback in relation to whether or not we actually made a difference. And this is where the outcomes monitoring framework that the ANU is developing for us comes in to assist us to understand truly the impact of what we're delivering in relation to both alleviating distress, but also in relation to treating mental health conditions.
Thank you. And Ms. Nolan, you mentioned earlier the notion of triage and wait list. Might I ask, who is on the team who's undertaking that wait list triage? Is there a medical practitioner on the team? How do they assess competing priorities amongst clients?
So, if I may provide some context, we're not a medical service. We are ostensibly a psychological treatment and counselling service. We don't employ doctors per se. We have recently engaged a psychiatrist to assist us in our clinical governance, as well as to assist us in our quality improvement strategies. However, the triage approach is undertaken by a clinician at that regional level, and it's usually overseen by the Assistant Director for Clinical Operations in each of the regions, who will then oversee and make judgments about the acuity of the individual. But we would also, we operate as part of a mental health system, which means that if we are working with somebody about whom we're concerned, then we would work with their treating team, including their general practitioner, to identify what other supports could be brought to bear. So it's very much a team approach, and that's consistent with our clinical governance framework, which ensures that there are appropriate escalation pathways when there is a deterioration in the presentation of the client, but also to ensure that our clinicians are well supported in their decision making.
Thank you. When you say clinicians, do you mean qualified psychologists, or might you?
Our clinicians include psychologists, mental health accredited social workers, as well as mental health nurses and mental health occupational therapists.
Thank you. Thank you. Now, if I might move then to. If I might now move to another topic, and that is back to returning to the question of policy and the overarching policy of open arms. Might you display, please, operator exp.0010.0286? Yes, so this is the 102.04 policy management procedure. I understand that the parent policy to this procedure is the continuous quality improvement policy we've just addressed. Is that correct? And might you explain to the Commission, and I believe you're nodding again, so I might ask you to say yes, I'm sorry, to each of you.
Yes.
Thank you. Might I ask you to explain to the Commissioners the scope and purpose of this policy? And you can see there's a reference at 1.1.
Thank you for enlarging that.
Ms. Cameron, is it correct to say that this policy is the way in which Open Arms ensures that its policies remain current and they're consistent with best practice, and you ensure that the relevant activities that are undertaken pursuant to the overarching framework of Open Arms are in fact conducted appropriately and in accordance with that best practice?
That's the intent.
Thank you. And then I just want to explore the policy review procedure. If I may take you to page 287 of that policy document, and particular clause 2.3, you'll see there when it comes up. See if I can help the operator. So we're at exp.007.0010.0286, and I think we're still on that page at 0287. We seem to be having a technical problem for a moment. It might be an appropriate time to take a very short adjournment of 5 minutes.
Yes, certainly we can do that. Just before we break though, Ms Nolan, please forgive me if I've got this wrong, but you're unable to comment at the moment about the waiting times of people who have applied but not yet been gotten to for Open Arms counselling?
Excuse me, Mr Curtis, but I'm not sure what you mean by unable to comment.
You were asked a little bit earlier, I just haven't gone back to it, about if you're able to comment on how long the waiting period is for people to be served, to be attended to. And I think you took that on notice?
No, the comment, I thought the question was more in relation to the distribution of the waiting list across the region, so in which states there were higher waiting lists.
Okay. Are you able to comment generally about the waiting times that people have to wait?
Yes. So it will depend upon the service that the client is wishing or is appropriate for, what the service is that is appropriate for the client. So in relation to individual counselling, that's probably the most readily available service that we have, because we can control that. We have over 493 staff, we have in-centre counsellors, and we have over 1,100 outreach program counsellors in the community, with additional services that we can access through our contractual arrangements with Relationships Australia, Centre Care and Bupa. Individual counselling is relatively accessible, but bearing in mind that the average waiting time in the general community is approximately 6 months to access counselling services or psychological services. So if it's individual counselling, we can manage that within our current resourcing because we have that control. If the individual is seeking relationship counselling, there is a distinct lack of availability of people with specialist skills in relationship counselling in the community at the moment. So that would incur a greater waiting period. And one of the things that I would be keen to do is to look to see how we can better resource some of those skills deficits that we have, both in terms of our own ability to deliver that, but also in establishing those pathways into the community. The other area where there is a dearth of services available is access to psychiatry. Again, waiting lists in the general community are usually around 6 months to see a psychiatrist. And then specialist services such as ADHD, diagnostics, and paediatric services. Again, there are extensive waiting lists in the community, so that the waiting list is divided up into those people who may be on the waiting list because they wish to see the counsellor whom they saw previously or a specific counsellor and they're willing to wait the time. It may be that they wish to see somebody in their local area, depending upon where they're based, and this is most material to the Northern Territory, where again there is a lack of availability of counsellors in the regions. So if the individual is identified that they wish to see somebody face-to-face rather than access telehealth, they may be willing to wait that period. But part of what we do is then ensure that we're managing their risk and attempting to alleviate their distress whilst they're on that waiting list.
Ms Nolan, thank you for the information, but that still doesn't tell me how long people have to wait.
And I'm sorry for not answering the question clearly. It depends upon what they're
I actually object to
waiting.
that because the witness wasn't asked that question. So if you're going to criticise...
I'll ask the question now, Mr Fordham.
Thank you.
Can you tell me how long people have to wait to be served?
It depends, and I'm sorry I don't wish to appear to be prevaricating, but it depends upon what they're waiting for. So as I mentioned, the average waiting time for people to be seen by a counsellor is 14 days.
And that's across the various services.
That's right, but it will differ depending upon the type of service that the individual is seeking, and I'm unable to provide that information now, but I could take that on notice.
Thank you. Are we still having technical difficulties?
I believe we are. Perhaps a 5-minute adjournment will be appropriate.
Okay, we'll just take a short break for 5 minutes until that's resolved. Thank you.
Thank you.
All rise. The Royal Commission is adjourned for 5 minutes. The Royal Commission into Defence and Veterans Suicide is resumed. Please be seated.
Thank you, Commissioners. I trust that the technical issue has been resolved, and we can turn now to EXP.007.0010.0286 at 0287. Thank you. And you can see, 0286, my apologies. If you go to 0286, you'll see there at clause 2.3, and in fact the first of the bullet points, it's correct to say, isn't it, that Open Arms reviews every policy and its related procedures and instructions, so not just policies, at least every 2 years, and that is for compliance, relevance and currency. Is that correct?
That's the intent, yes.
Yeah, thank you. And so you said that that's the intention, but is that something that is done through a committee?
I cannot confirm that it has been done as regularly as that all the time.
I see. In relation to this policy, if you might turn now to 0292, and that is the last page. You'll see that this is version 1 of that policy, and the version was instituted on the 1st of July 2020. And it's the only version thus far that has been produced. And further, there is an annotation to this policy, just in the box directly above that, cleared by the National Manager. Might you explain to the Commissioners what this means and what is involved in the process here? Perhaps Ms. Cameron.
That indicates, I believe, that this policy was to go out to comment and consultation, probably internally in Open Arms, and that any issues, concerns or suggestions arising from that would then be approved by the National Manager, and an updated version of the policy, or a final version of the policy, would be released in January 2021.
Yes, thank you. And it says there, cleared by the National Manager as a comment draft, obviously enough, given the timing on the 15th of September 2020, the National Manager wasn't new, Ms. Nolan. This was before your time. But it's apparent from this that this is merely a draft document, isn't it?
That's exactly what that would indicate, yes.
Yes, so this is the policy by which policies are reviewed and ensure that they are up to date and current in accordance with best practice, and yet we find that the very procedure is itself more than a 2-year-old draft. Is that correct?
That's correct.
Do you see any, I might address this to you, Ms. Nolan, do you see any difficulty with this?
Yes, I do.
Might I ask you to comment?
I think so.
Sorry, can you hear me? Can you hear me?
No, not clearly. Might ask somebody to assist you with the microphone.
Can you hear me now?
Yes, yes, most certainly.
It's not, and I'm sorry, could you repeat the question, Ms. Rubigotti?
So the very procedure that outlines a process by which Open Arms ensures that its policies remain current, relevant, effective and consistent with best practice is itself more than a 2-year-old draft. Would you regard this as acceptable?
No.
Or somewhat of an absurdity, really?
Indeed.
Might I ask you to comment on the processes or generally in relation to this, having regard to your position in connection with continuous quality improvement policy?
One of the challenges for me in taking on this role has been to ensure that we do have the right settings in place in relation to evaluation, quality and safety, which includes continuous quality improvement, ensuring that our policies, which are largely more procedures than policies per se, reflect current evidence-based practices in relation to mental health services is something that I am undertaking, but that is very much a work in progress. One of the other challenges for us is to ensure that we have alignment in our documents that govern open arms with the broader department, and that has been part of the intent of the establishment of the new division under our First Assistant Secretary, Leanne Cameron, and that is a work in progress.
And are you able to indicate what has been done so far?
My focus in the last few months since I began in July has been to identify a model of care which clearly stipulates what we do, what we don't do, so that there's that clarity of contract with the veteran and family community about what they can expect from open arms, to also situate open arms in the context of service delivery as part of a broader mental health service, which includes establishing referral pathways into the mental health sector across the states and territories, as well as with general practitioners as part of that primary care focus, as well as to ensure that we have the right network of providers to address those scarcities which we're experiencing, which contribute to the wait list.
Thank you. We will explore that a little bit further, but I wish to do that through another document. Might DVA.5023.0001.0399 be displayed, please? Thank you. And that's the care coordination procedure. And it's correct to say that this procedure sits under the Open Arms Care Policy. That's correct, isn't it?
Yes.
And it's part of the overarching frame within which Open Arms mental health care is provided to the Australian veteran community. That's correct, isn't it?
Yes.
Thank you. And do you agree that care coordination is a service offered by Open Arms to address what is the multiple issues impacting mental health for clients with complex needs?
I'm sorry, Miss, would you repeat the question?
Yes, certainly. Does care coordination involve the offering of services to address multiple issues that impact mental health, and that's for clients with complex needs?
Yes.
Yes. And might you explain to the Commissioners the notion of complex needs?
Complex needs are usually those needs which may touch upon a range of psychosocial factors, including things like homelessness, financial distress, alcohol and drug use, or people who may not be help-seeking.
Thank you. And it's correct to say generally those with complex needs are a more vulnerable cohort.
I would agree with that, yes, generally speaking.
And Commissioners, Dr Maguire, in an earlier session, in an earlier hearing block, also addressed the topic of complex needs and the difficulties in care management associated with patients with complex needs. Now, might I refer you please to page 400401 of this document. And you'll see there that there's a topic of extended care support. That's marked as under development. Might you explain, please, what the notion of extended care support is?
The role of the care coordinator, the clinical care coordinator, is usually time limited and short term, but there is a cohort of clients who require longer term extended care support, and that's what this refers to. And that may include the engagement of peers in the delivery of that coordinated care support, as well as ensuring that we engage with the rest of the treatment team, including the general practitioner.
Thank you. And if you can turn now to page 0404. Again, this is the last page of the document. You'll see that it's a version from 1 July 2020. It hasn't been updated from that date. That's correct, isn't it?
That doesn't necessarily mean it hasn't been updated. There may have been no updates required, but it certainly hasn't been changed since that date.
I understand. But in any event, and certainly if there have been no changes or it's lean in this form since that date, yes, and that aspect of extended care coordination hasn't changed, might I now just take you to the box directly above this. Again, you can see that it's a comment draft. So in Do you agree with that?
Yes.
Yes, thank you. And in circumstances here where we're dealing with the provision of care for clients with complex needs, would you agree that, again, it is unacceptable that the relevant policy is in draft?
Yes.
Thank you. Now, there are a range of other policies that are in draft. I'm not going to take you to each and every one because there's only so much time, but if I might, just for the purposes of bringing them to your notice and for your assistance, identify those relevant policies by reference to the tender list number. The first is item 8 on the Open Arms DVA tender list, and that concerns reporting data usage, storage and disposal procedures. The next is item 11 in the Open Arm tender list, and that's a consent discussion guideline. We then come to item number 12 on the Open Arms tender list, and that's clients' rights and responsibilities procedure. Item 25 on the tender list, we have the carer engagement procedure. That's 25, yes. Item 28 on the tender list, we have the clinical assessment and treating planning procedure. And then item number 30 on the tender list is the referral and allocation procedure. And just to confirm, that referral and allocation procedure, is that connected with the notion of allocation to people to services and the wait lists that we were discussing a moment ago?
Yes.
Thank you. So you may assume from the Commissioner that those documents are in draft. And yet you've each confirmed, and rightly so, that the fundamental role that policy plays in effective governance, risk management and organisational improvement. Might I ask you to comment, please, on what the State of Open Arms policy says about the State of Open Arms service delivery?
May I make one comment before I answer your question? Is that
Certainly.
okay, Mr. Ribrati? We have undergone an audit in the past couple of years, prior to when I started, but certainly in the recent history, looking at policy and procedures, and a number of recommendations were made as to several open arms policies which were unnecessary because they were actually replicating DVA policies. Noting that would not apply to clinical policies, but it certainly does apply to some of the other enabling sort of policies. I would like to check which of those have actually been superseded and are no longer active, but were provided as they were documents that were relevant at a point in time.
Certainly. But would you agree that out-of-date policy making can give rise to a systemic risk of adverse events?
I certainly do agree that adequate policies that are well understood, that reflect practice and that are up to date are essential to a proper governance system.
And is that because they impact and guide staff in the delivery of their services?
That's correct.
So they know how to behave and what to do on a consistent basis?
That's correct.
And would you agree too that in those circumstances, out-of-date policy can adversely affect or impact a client because the staff may not necessarily know how to implement the relevant policy?
It certainly has the potential to do that.
Thank you. And given the services that Open Arms provides, as we know, to the most vulnerable in the veteran community, as you've indicated, do you agree that out-of-date policy making is capable of giving rise to a systemic risk of adverse mental health outcomes?
It has the potential for that.
Thank you. And would you even say to suicidality and attempted suicide and suicide?
Suicidality is so multifactorial that it has the potential to do that, yes.
Contribute to that. And then in those circumstances, do you think that this raises a real issue as to Open Arms' acknowledged accountability to the veteran community?
Yes.
And is there an issue then too as to whether veterans can have confidence in Open Arms when its governance policies may not be up to date?
I think that in any area where we need to make improvement, making that improvement would certainly lead to increased confidence in the service. I do point to the outcomes that Open Arms is achieving, despite the fact that our policies are out of date in some instances.
I appreciate that. Are you able to indicate, though, what, if anything, Open Arms is doing to address the policy issue with a degree of specificity?
Of course. When Ms Nolan started, the team that is responsible for the oversight of the policy documentation, we moved that in under Ms Noland so that she has direct ability to influence, update and change, and that will take place, as she indicated, whilst when the model of care is better defined and articulated. So we've actually moved the oversight of these policies closer to the source and the people who are using them.
Thank you. And Ms Nolan, do you have any comments to make regarding Ms Cameron's evidence?
I think, as my colleague described, from my perspective, we need to have our defined model of care first as the overarching framework under which the policies and procedures will then sit, to be informed very much by the evidence base for the provision of services to address the needs of the different cohorts, and then to ensure that our policies and procedures reflect that.
Could I make one further comment, Ms Rubigotti?
Certainly.
Sorry. And that is that Open Arms, and we were talking earlier about its history and where it was located within the department. Open Arms has not enjoyed as close a relationship with our actual policy division in the past as we are fostering now. I look at these policies and procedures and I say they are more procedures than policies, and we actually need to ensure that as a department, the policies surrounding Open Arms nest within the departmental aims and policies. So there is work to be done. The documentation that you have shown today are more procedurally based and moving that closer to Ms Nolan, but also moving Open Arms closer to the department in terms of sitting in this division will enable greater oversight at both the policy and procedure level.
Thank you. But nonetheless, you would accept the procedures are important and indeed fundamental, but their capacity to guide staff.
Absolutely accept that. I just want
also,
to reassure.
Listen, and the impact that can be had on staff, adverse impact on staff as well as clients, if policies and procedures in particular are not up to date and they don't know how to behave, particularly when dealing with clients who often have quite complex, as you say, complex needs or difficult mental health problems. Is that correct?
Consistency and certainty.
About 3 propositions within that question.
Ms Rubigotti, do you wish to respond? If
yes,
it's easily enough remedied.
Let me see if I can rephrase that. And you would accept that up-to-date policies are essential first in guiding staff?
Consistency and certainty for staff is very important.
And it's particularly important in circumstances where staff are dealing with clients who have complex needs, including complex mental health needs.
Agree.
Thank you. Might I now turn to the topic of clinical incident reviews? But prior to that, I will ask you one question. Now, you mentioned the model of care. Are you able to give me some indication, please, of the milestones, what is intended, when that will be produced?
So we are modelling our model of care, sorry for that repetition, on models of care that are used in the mental health sector, and we're particularly looking at the model of care that has been developed in the ACT. That seems to have quite a degree of utility and consumer support. We have developed an initial framework for that, and we are subjecting that to consultation with our leadership team at this point in time. And as I mentioned, hoping to have something which we can then take to our community probably late January.
Late January, thank you. I will now turn to the clinical incident reviews. Now, are you able, Ms Cameron perhaps, to inform the commissioners about what the term clinical incident, what it means? What does that term mean?
I might actually leave that to Ms Nolan, if that's all right.
Certainly.
May I provide some context before I answer that?
Certainly.
In my role in CCSB, in the Coordinated Client Support Branch, I was asked to develop a trial in relation to the introduction of a root cause analysis methodology, which has since become centred in the adverse events analysis program, which sits under mental and social health programs under our First Assistant Secretary. At the same time, Open Arms was seeking to introduce the same capability, and they had also referred to their program as an adverse events analysis program. Because, sorry.
I'll let you finish. I don't want to cut.
Okay, sorry. Because the remit of Open Arms is very much clinical, whereas the remit of the adverse events analysis is much more across the department, there was a decision made by the then National Manager to rename that the Clinical Incident Review to reflect that the material that was to be reviewed was clinical in nature rather than across the department, including interaction with other branches and so forth. So it was renamed to reflect the closer remit of that process, or the closer scope of that process in relation to focusing on clinical incidents. And a clinical incident, if I may continue, which I think was your original question, sorry,
Yes.
but I did want to provide that context, refers to a death by suicide of a client or an attempted suicide. And the clinical incident review process is usually enacted when the client has had relatively recent contact with Open Arms, which is usually within a 12-month period.
Thank you. And I understand there are two policies I would draw that there is a procedure and instruction that relates to the clinical incident review. If they might be displayed, as to the procedure, that is DVA.5023.002.0076. Thank you. And then this, if we can have that readily to hand, there's one more procedure, and that's an instruction, and that's DVA.5023.0001.0056. And then we have the instruction. And you accept that these are the fundamental documents relevant to managing systemic risk factors insofar as they pertain to suicide or attempted suicide of veterans who are clients or former clients of Open Arms.
Yes.
And these two guide the process, staff, analysis and accountability, and certainly willingness to learn and continuous improvement. You would accept that?
Yes.
Thank you. And might you expand a little on the nature of these procedures and how they relate to clinical incident reviews?
Ms. Rubigotti, may I ask for clarification as to exactly what do you refer to?
I'll start first with the clinical incident review procedure. Let me ask another question. Are you familiar with the concept of restorative just culture?
Yes.
Yes. Commissioners, we heard from Dr. Catherine Turner about the importance of such a culture in the Brisbane hearing block on the 7th of December 2021. And we have also heard from Professor Anthony Pisani on the 10th of March 2022 in connection with that topic. Might I ask, are the clinical incident review procedure and the clinical incident review instruction an aspect of the implementation of that restorative just culture?
I would actually position restorative just culture as informing how we enact a clinical incident review.
I see. And might I ask what your understanding of restorative just culture is?
In relation to the clinical incident reviews, it is about having a no-blame culture, understanding the impact of suicide on all parties involved, which includes families as well as staff, and ensuring that people are supported from a trauma-informed perspective in understanding the factors that may have contributed to the clinical incident, but also ensuring that individuals are supported themselves.
Thank you. And is that Open Arms' commitment and practice around such a culture when it comes to suicide and attempted suicide?
Yes.
Thank you. As to the clinical incident reviews and the purpose, is it correct to say that the chief purpose of the review procedure is to develop recommendations for service improvements?
I would probably, and this is my view, to say that the principal purpose is to identify systemic issues which are within the remit of Open Arms to affect, to ensure that we reduce the risk of suicide.
I see. Thank you. Thank you. And so that then is, as we've said, part of the continuous quality improvement process. Is that correct?
Yes.
Yes. And it's a fundamental part of that process.
Yes.
And you've indicated that suicide or attempted suicide of a current or former client, that's a clinical incident?
I'm sorry, could you say that again?
Yes, certainly. Suicide or attempted suicide of a current or former client is a clinical incident, that's correct?
Correct.
And so the proper performance of clinical incident reviews is part of Open Arms' suicide prevention strategy, as you've indicated.
Accepting the multifactorial nature of suicide and the purpose of the clinical incident reviews to identify those systemic issues, yes, it is an important part of the overarching strategy in relation to suicide prevention.
I see. And measuring Open Arms' performance when it comes to dealing with clients. Is that correct?
I'm having to think about that question because, as I mentioned earlier, our performance measures are not necessarily in place in a way that assists us in managing our population as a whole. And the clinical incident reviews are based on individual cases, so there may be some inferential value from that, which would then assist us in identifying those systemic issues to improve quality performance. But I just needed to put that step in because it's not as straightforward as it may appear.
I see. And might there be value if you see issues reappearing after you've got each individual incident, and if you see a repetition of a problem, that can inform practice and relate to a systemic issue?
Absolutely.
Thank you. Tell me, is a clinical incident review of each and every client and former client who dies by suicide mandatory?
I would ask what you mean by mandatory.
Is there a requirement that a review be undertaken?
There are, so if I may step back and provide some context. So the clinical incident review comprises 3 stages, as it were.
Yes.
The first stage is a hot issues brief, which is part of an initial reporting up of the notification of a death by suicide or possible suicide. The next stage is the production of a client summary, which gives us information about what are the factors at a first look, as it were. The HIBs are done within an hour of notification, generally speaking. The client summaries are done routinely, so I just wasn't sure about the term mandatory, but this is a routine process for clients where we've been notified of a death, as I mentioned, by suicide or possible suicide. And then the third stage of a clinical incident review, which is looking at a deep dive, as it were, to align it with the adverse events analysis process, but a desktop review will then be conducted if there is sufficient evidence on the basis of the client's summary to warrant that further investigation. And then the final stage of investigation is the panel review, which involves the care team being interviewed and providing that greater degree of evidence and qualitative information.
I see. Thank you very much. And might I just ask too, we'll go here to DVA.5023.0002.0076. And I might turn to, it will be page 7.7, I believe, at 5.21. Yes. The previous page. Thank you very much. The 5.21 there. The clinical incident review procedure emphasises the need to offer immediate support at 5.21 and refer the family to appropriate postvention supports at 5.25. Can you talk a little bit about how appropriate support might be identified and how appropriate postvention supports are identified in the context of the different review stages? So if a review doesn't proceed to a panel review, how is the appropriate support ascertained?
So I might engage my colleague Leanne as well, because we do this across the division as a whole.
Certainly.
So I might. Thank you.
When the department is notified of a death by suspected suicide or misadventure, our service coordination team take the lead in providing support to the families and the surviving partner, etc. They work with Open Arms initially to determine on the basis of circumstances whether an outreach from Open Arms is the first contact or whether in fact a service coordination team make first contact. If the surviving partner is known to Open Arms, it's often better for Open Arms to make that contact because they are familiar with the family and the family is familiar with Open Arms. If we are talking about a serving member who also might be a client of DVA and Open Arms or Open Arms, the Defence Member and Family Support Service actually take the lead there, and we wait until they indicate that the family is ready to engage with us.
Thank you. And I see there, you can see in the first two bullet points of 5.21, there are different means of contacting. So if a client was not a current client, by which I understand they hadn't received services from Open Arms for at least 12 months, is that correct?
That's in terms of the clinical incident policy.
Yes. The client assists us to make that contact, is that right?
Yes, so in terms of that's our 24-hour service,
Yes.
which is telephonic.
Yes.
So in terms of that current procedure, that would be the case.
Right. And then, but if a client is or if the deceased was considered a current client of Open Arms, the relevant regional director was to make that contact. Is that correct?
Indeed.
Might you explain to the Commission why there is this tiered approach to contact in the context of postvention?
If the client was not known to Open Arms and there is a reach out required, and I have to say, if I may, this policy does not reflect the interaction that we have with the Coordinated Client Support Branch, as Leanne was just describing. So we have a very much a team approach to this in terms of who is best placed to contact the family, and that is usually on the advice of our service coordination team in the Coordinated Client Support Branch. The client's family or the client may not have had any contact with Open Arms, but they may have had contact with the department. And this is one of the benefits of Open Arms coming into the division and being more closely aligned with DVA, is that we can ensure that the right level of contact is made by the part of the business which is closest to the client, as it were. If the client is unknown to Open Arms or DVA, then because we employ clinicians as clinicians, we are best placed in Open Arms to make that telephone call. But if the client is known to DVA but not Open Arms, there is a decision point and a discussion point about is it better to have a clinician make that call, or bearing in mind that CCSB, the Coordinated Client Support Branch, also employs clinicians, whether they would be better placed. So there's a decision point about what is most appropriate, and we're guided very much by the Defence Members and Family Services, by the ex-service organisations who may be in touch with the client's family to take advice about what is the most appropriate reach out, because the last thing we want to do is cause further distress.
Thank you.
Ms. Rubigotti, may I add something to that?
yes,
Ms. Nolan did refer earlier to some work that we are doing on a post-vention framework, and that will actually supersede this, and it will provide a much broader overview of how this process works across the department.
Thank you. Thank you. Might I explore the idea of clinical incident reviews in the context of attempted suicide? Do you undertake clinical incident reviews when there are suicide attempts or known suicide attempts?
I'm sorry, I didn't quite hear the last part of that
Yeah.
question.
Undertake clinical incident reviews in respect of known suicide attempts.
At the moment, we are in the process of looking at how we determine what constitutes a suicide attempt. And I think it's fair to say our focus has been on suicides that have been reported to us or possible suicides. The review undertaken in relation to suicide attempts is usually done not necessarily under the aegis of the formal clinical incident review process, but at a local level as part of our usual clinical governance and clinical review process, whereby the counsellor would discuss the issue with their clinical supervisor as well as with their relevant assistant director to identify what factors, if any, we could have acted upon to prevent that attempted suicide, and also to ensure that we are delivering the right package of care for the individual if they have been admitted to hospital, for example, as a result of that attempted suicide.
Thank you. And I believe we need to take a short adjournment now.
Yeah, we're going to need to take just a 5-minute adjournment to attend to a matter that was set down for 11 o'clock. So we'll just adjourn for about 5-10 minutes.
Thank you.
Rise. The Royal Commission is adjourned. The Royal Commission into Defence and Veterans Suicide is resumed. Please be seated.
Thank you, Ms Ribagotti.
Thank you, Commissioner. Ms Nolan, I think by your last question you've indicated that you don't presently undertake clinical incident reviews for attempted suicides. Yes.
May I continue? Yes, thank you. Not formally, but a review is undertaken, as I mentioned, at the local level as part of our normal clinical governance, where the case would be reviewed by the counsellor in conjunction with their clinical supervisor, with their assistant director, and with anybody else who they may need to bring in, which would include some of the avenues we have for clinical advice and support through agencies such as Phoenix with the Practitioner Support Service, as well as through our psychiatrist who we have on staff now.
Thank you. And consistently with the notion that what is known, that a previous suicide attempt is a risk factor for suicide.
Indeed.
Thank you. Might you display, please, operator DVA.5023.002.076. You'll see there, Ms Cameron and Ms Nolan, at the scope again, there are some aspects of this procedure that are under development. They relate both to the commission of serious violence by or to a client as being a clinical incident, and then the advent of a serious clinical error that detrimentally affects a client. Are you able to indicate to what extent what development has taken place?
I may refer to my colleague because this also is part of our broader divisional approach.
Certainly.
In my previous evidence, I did talk about our adverse events analysis program of work. The framework for that has been endorsed in principle now by our Executive Management Board. And we have looked at one particular case as a test case to make sure that we have the settings correct, and we are in fact following up on a few aspects of privacy to make sure that we are able to adequately address protections under the Privacy Act for the clients, their family, health practitioners, as well as our staff. So that will be picked up as part of that process once we've landed and finalised the settings.
Thank you. And tell me, is there a document that records those outcomes? Has that been developed, or is that still under development?
What do you mean by records those outcomes?
The framework that has been endorsed, you have that framework documented?
Yes, we do.
Excellent. And that is a framework that you can provide to this Commission?
It's in draft because it's endorsed in principle, but whilst we work through these remaining concerns.
Yes.
But I think we can provide a draft.
Thank you. And when do you anticipate that it might be finalised?
I am ever hopeful that it will be finalised tomorrow, but realistically dealing with privacy issues, it's taking a little longer than any of us involved would have liked to have seen, but we are working very hard to make sure it's correct rather than quick.
Thank you. Thank you very much. Now, having looked at the policy that governs the reviews and the procedure, and to an extent the procedure by which the reviews are undertaken as indicated by Ms Nolan, we might turn Commissioners to the reviews themselves. Now, by way of introduction, by a notice to give to Open Arms dated 7 September 2022, this Royal Commission sought certain information pertaining to, among other things, Open Arms clients who had died by suicide, and that's whether suspected, possible or verified, and that's between 1 January 2013 and the date of the notice. Now, I don't want this document displayed, but I will just refer to it. It's ntg.opa.003.001. Now, and then we also sought the information sought included information concerning reviews. Now, Open Arms produced an Excel spreadsheet that contained information that pertained to Open Arms clients and former clients who died by suicide, and that Excel spreadsheet appears in the tender list at item 8, and that's a confidential document that ought not be displayed as a consequence. As you would expect, Commissioners, that contains highly sensitive information. I should mention that spreadsheet, and I might ask Ms Nolan, Ms Cameron to confirm this, that has now been updated in light of a more recent death by suicide. Is that correct?
It's in the process of being updated, yes.
Thank you. And an updated version has been provided to this commission. Now, in addition to that spreadsheet, certain clinical reviews were provided upon the Commission's consideration of that spreadsheet, and more than 180 were provided. Now, we do not propose to consider the reviews individually, but instead we wish to explore themes emerging from the recommendations and the manner in which certain reviews were undertaken, in particular by way of a summary. And I believe that Ms Veach may have addressed some of those reviews during her events yesterday. And those reviews relate to clinical incidents that are recorded in the Clinical Incidents Register. Among the additional documents produced by Open Arms was that register. It appears at the tender listed item 13 as a confidential document for obvious reasons, and it will not be displayed. It produces an Excel workbook that contains information that pertains to Open Arms clients and former clients who have been the subject of clinical incidents, and they include, but they're not limited to, attempted suicide and suicide. Again, that contains highly sensitive personal information. It also contains some demographic information which we'll be exploring at a later date, at a later hearing. The Clinical Incident Register is addressed by Open Arms in its consolidated response to the notice to give. It's NTG-OPA-003 at paragraphs 720 to 721. I might ask for the document to be displayed. It is DVA.999.0024.0001. And once that is brought up, if we can go please to pages 8 and 9, that's 0008 and 0009. I'm sorry, Ms Cameron's on, and you can see that there's quite a bit of detailed information here. I might take you, if I may, to paragraph 720, if we could focus on that, and then later on 721. Give you an opportunity to look at that.
Could we possibly have the question that's asked in relation to those paragraphs as well, just above it? Thank you.
Thank you. So to assist the Commission, especially those observing the hearing, might you briefly tell us what VERA is, VMIS, and the digitised client records, just for context?
So VERA is the case management system that we use at the moment. VMIS was the previous case management system, the one that VERA replaced, and digitised client clinical records was when we were keeping paper records, but they have now been scanned and stored digitally.
Thank you. So might I ask, once a clinical incident becomes to the attention of Open Arms, is information concerning the client extracted and included in the clinical incident register?
I'm sorry, could you repeat the question, please?
So once a clinical incident comes to the attention of Open Arms, is information automatically extracted concerning the client and included in the clinical incident register? Is it a routine procedure?
It's a routine procedure and it's a manual extraction.
I see, thank you. And how is there policy that guides the inclusion of information in that clinical incident register? How is it undertaken?
I would have to take that on notice, but then, yeah.
I was going to ask for clarification, but I think it's probably best to take it on notice because...
Certainly. If you go to paragraph 721, you'll see there that there is a reference to certain summary reviews or a summary analysis there of all clinical incident reviews. Now, as I understand it, 3 different types of reviews have been undertaken. Operator, if you please go to pages 0009 to 0010. and in particular paragraphs 8.1, 8.2 and 8.3. What's 0009, ready? And what you'll see there, Ms Cameron and Ms Nolan, are a reference to two different types of analysis that is undertaken. And I just want to understand the nature of that analysis, and I'll give you an opportunity to read that. And then if we go over now, please, operator, to the next page, which is 8.7, 8.8, 8.9 and 8.10. I wonder if we can make that a little bit bigger for the witnesses. 8.7, 8.8, 8.9 and 8.10, thank you. And I'll give you an opportunity briefly to read that. Now, I understand, is it the clinical incident review team that undertakes the reviews?
That's right.
Yeah.
Correct, yes.
Thank you. And when was this team formed?
The team has been there in one iteration or another for several years. I believe the team in its current form is about 2 years old.
I see. Are you able to indicate what the impetus was for its formation?
That predates me. I'd have to take that on notice and find that out for you.
Ms Nolan, are you able to?
I was just going to comment. I think it actually was established as part of the process that I mentioned earlier in relation to the RCA methodology being implemented in trialed and then implemented in DVA. That's my understanding, but that may not be correct.
Okay, I think we should take it on notice because there's actually two teams that one that does the clinical incident review and one that does adverse events analyses, and I'd hate to confuse the matter.
I see, thank you. Now, I just want to look at the different types of summary analysis that are undertaken. It appears that the summary analysis indicated 8.7A and 8.7B are of the same type but relate to different periods referable to the client's date of death. Is that correct?
Correct.
Yes.
And then at 8.7C, and it might be more helpful, in fact, if I take you down to 8.8, 8.9 and 8.10, it appears that this is a different sort of analysis and it covers a longer time frame from 1 January 1986. Are you able, I'll give you an opportunity to read that. Do you agree with that?
Yes.
Yes.
First, what is, are you able to indicate the difference in the type of analysis? What is being looked at?
Point C actually refers to analysis that was undertaken on all of the names from the AIHW list that had been clients of Open Arms. So it goes back a long way, and it's necessarily different because it is looking backwards, but also accessing a lot of digitised records, records from VMIS, not just records that are current.
I see, thank you. And tell me, is Open Arms proposing to undertake the type of summary analysis identified in 8.7A and B in respect of records earlier than January 2019? Or not at this stage?
Not at this stage. The idea of the clinical incident review, along with the adverse events analysis reviews that we're implementing, is to look at the heuristic value in actually being able to identify where we can make a difference, change and improvements. Looking back that far might not elicit anything that we haven't already addressed, if you see what I mean, but certainly looking at that demographic level, looking for clusters, trends, etc., we can gain value from that because that enables us to target services.
Thank you. And tell me, has there been any change at any point in the level of detail or granularity in the nature of the information, the subject of the review or the recommendations or any other criterion?
Sorry, I'm not quite sure I understand what you're asking.
as to the level of detail that one might see in a clinical incident review, has there been a change in the amount of information or the nature of the information that is that is explored and is reported on?
I'm not sure that I could say there has been a difference, but there definitely will be a difference because the adverse events analysis will sit across the whole department. The clinical incident reviews from Open Arms will feed up into that process, so it will only be a component of the broader information that we look at.
I see, thank you. And as to the clinical incident reviews, do the reviewers receive any particular training to undertake that review? Might you comment on that and their level of skill and experience?
Can I comment at the adverse events analysis level first?
Yes, certainly you may.
Yep. So we do have a team stood up, and they are being or have received training in root cause analysis and how to undertake a root cause analysis. Trauma-informed care training, a number of other important pieces of for their kit in order to be able to undertake this service, or this function rather. In terms of the clinical incident reviews themselves and what is undertaken within Open Arms, I might ask Ms Nolan to answer that bit.
Thank you.
Sorry. Yes. Okay. So the same training has applied. So the initial core team had undertaken root cause analysis training that was provided through Queensland Health, and subsequent clinicians involved in this process have received training consistent with what our colleagues in mental and social health programs have had.
Thank you. Commissioners, we will now turn to look at the findings from the summary reviews concerning, in particular, the suicides from January 2019. And it's particularly interested in these given their currency and thus their aptness, I think the witnesses would agree, to identify continuing systemic issues. Would you agree with that notion?
Yes.
Thank you. So might I go to OPA.0003.001.0541? So you can see here, this is the final summary adverse event review, suspected suicide from January 2019 to June 2020. Might you focus, please, operator, on the scope of the summary, which appears at 0542, the next page. And you can see there the reference to facilitating ongoing improvement, as we've indicated. And we might look now at what needs to be improved. So let's turn, shall we, to 0543. And here is an indication of the findings. And operator, might I ask you, please? Thank you so much. So you can see here that there's a table 1. It outlines the number of reviews of adverse events, clinical incidents that involved a suspected suicide. The number of reviews are completed with 30. And then reviews where Open Arms issues are identified, the number is indicated as being 25. So that's 83%. Now, do you have any comment on that? Because it does seem like an extraordinarily high number. I might ask each of you to comment as you see fit.
I'm happy to comment first. The very nature of this process is to look for issues.
Yes.
So if we did not identify many issues through this process, my response would have been to ask them to look a bit harder.
Yes, thank you. Ms Nolan, do you have a comment to that?
Similarly, there are always opportunities for improvement, and the purpose of this is to take that, if I may say, forensic approach, as it were, to understanding what variables have impacted upon the suicide and what we could have done to reduce the risk.
It might be helpful perhaps to elucidate this number by reference to the themes identified. So if we could turn please to 0544. And you see at the bottom there, no, at the very bottom, thank you very much, operator, themes relating to, perfect, thank you. So 3 main themes that are identified: problems with documentations, problem with processes, and problems with client-facing activities. And if I might explore each of them briefly. Firstly, as to documentation, The review identified numerous problems with documentation. There were significant absences in documents. There were low quality entries, and there was poor organisation. In addition, identified was retrospective modification of CMS records without indication of why or what was modified, and a lack of consistency in the documentation of the postvention activities undertaken after the death of the client. Might I invite you to comment on that, and whilst you do so, I'll bring up the page that identifies those very issues I've mentioned. And I believe, operator, if you turn to the next page. So you see there, in table 3, if you can focus on documentation. Thank you.
Yes, the documentation findings, particularly of note for me, was the retrospective change of documents. I have explored that with the team that conducted these reviews. We have identified not only and acted upon learnings for clinicians in terms of the quality of their documentation, the completeness of the records that they are taking, etc., but also some system issues which we are exploring. The advice that we have received is that the system we have can identify when someone has gone into a record at a date but can't clearly identify what has been changed for us, which is a concern to me. Also, best practice would indicate that once a client has died, their record would be locked down, and then anything that needed to be added post, if that was about postvention supports or any additional information that needed to be appended, should be appended to the record rather than entered into the record itself. So there's some process issues there as well that we need to look at. In terms of the what was being changed. As I understand it, most of what was happening there was the late entry of notes that were added post-death that should have been added a lot sooner after the actual clinical session.
Thank you. And you'd accept, wouldn't you, that there are transparency issues that arise here, and among others?
Yes, absolutely, and that is the objective of actually doing these sorts of reviews is so that these issues get surfaced and we can deal with them.
And are you able to indicate any time frame or timeline for the dealing with this issue?
So we did undertake a gap analysis on all of the themes that are identified here to have a look at what things were already in train, what things remained outstanding, and then the things that were outstanding were actioned.
Right, and that a gap analysis is available in a written document that
should be, yes.
Thank you. You'll see there's a reference to postvention. And now, as to postvention, we know that those who are exposed to suicide are at a higher risk of suicide themselves and have a more vulnerable cohort. Might you comment on what is said there about the provision of services, postvention services, and in particular, the lack of clear documentation on the conduct and nature of those follow-ups?
So this I touched on this as well. Part of this is going to not only training and support for our staff, but also giving them a clear framework. As we mentioned earlier, we are in the process of developing and finalising a postvention framework, but also how we record postvention interactions within our systems, making sure that there is a connection between the documentation recorded for postvention activities with the client record, the client who has died. So there's some procedural things that have taken place in that space as well.
Thank you. And if we drop down now, we see that there are also issues with client-facing activities. They appear for the operator's benefit on this box that is shown, but then also on the next page. I'll give the witnesses an opportunity to read this part and then we can move to the next page. Thank you. And operator, if you can move to the next page, please. And focusing then up the top and the 3 bullet points on the second page shown there. So I'll give you an opportunity to look at that. These are significant issues, are they not?
Yes.
Yes.
Might I ask you to comment on them?
May I comment? I mentioned earlier that part of my focus in introducing a model of care with clearly defined pathways for referral to situate open arms in the context of broader health service delivery as well as mental health services is to address some of these issues in relation to how follow-up is provided, in relation to external service providers, but also external referrers. So establishing clearer rules of engagement, as it were, in terms of how we accept referrals, what response we give to the referring agency or the referring treating practitioner, as well as how we follow up to ensure that the client is well supported from a community perspective, not just through an open arms perspective. And I think there are some challenges in that area that we are seeking to address.
Thank you. And Commissioners, and of course for Ms Cameron and Ms Nolan, you will recall that on Tuesday we heard from the Northern Territory Practitioners Panel in relation to client-facing issues, and in particular the need to engage with other agencies and service, and thus the currency of these matters. Might I inquire whether you heard that evidence and whether you're able to comment upon it?
I did. The regional advisory forums, one of the responsibilities or the terms of reference for those forums is actually to engage at a local level with other services. But I would also like to remind about the testimony from Ms Veach yesterday and the blueprinting project that she is undertaking in conjunction with the model of care work that Ms Nolan mentioned, and the blueprinting of all of our services, their dependencies, the client experience, the staff experience. That will put us in a good position to reach out to people like Dr Mitchell to start to actually map across services.
Thank you. And Ms Nolan, you indicated that there are some challenges. Are you able to identify any challenges with specificity?
I'm trying to think of a particular example at the moment, and some of that is attendant upon the great burden on our mental health services generally across Australia, where there is a lack of available supports for clients who may be perceived not to be sufficiently unwell to receive that support. In establishing referral pathways, I'm hoping that we can build on some of the evidence actually that has been provided previously in relation to how we can better have rules of engagement or MOUs, whatever the relative or relevant instrument would look like, to encourage those pathways to subacute and acute mental health services where that's required, because delivery of those services is beyond the capability and capacity of open arms, but to also then ensure that we also engage more with the treating team, which would include the treating psychiatrist, the assessing psychiatrist, general practitioner, other allied health and so forth.
Thank you. Might we turn now to processes, and I'll ask the operator to focus on that, if I may. So if you close that focus box and you see their process indicated and the lack of demonstrated understanding and the like. So it would seem from this that there are particular issues with processes for engagement with clients, and in particular with clients with complex needs. Would you agree? Do you have any comment to make in relation to this? And just to pick up on a comment made by Chief Commissioner, you see there's a reference to an apparent lack of communication by open arms with clients on waiting lists. So it certainly does appear to be an issue for the clients, something that the clients are experiencing. Might you comment?
A comment? I mentioned the pilot that we've had in some of the regions, ensuring that we are communicating with clients on waiting lists, and that is something that we're seeking to roll out in the next couple of months. And that has been in response to these risks identified here, but also identified by the clinicians themselves in the regions who have said we need to do more for these people who are on the waiting list to ensure that they don't have an increased risk of deterioration, but also to ensure that we're checking in with them to see if they do still require the services that we have them listed for.
Thank you. If I can turn now to suggested improvement. So that appears at page 0547 of this document. And there are a number of them. I won't go through them all, but just a matter of curiosity. I notice these are regarded as suggested improvements. In another summary review, there's a reference to recommendations. Is there any difference in weight, or is it just merely a matter of a choice of language? I understand. So if I can focus, if I may, on risk assessment. Within Table 4, excuse me, you'll see there's a reference to all aspects of risk assessment, and that's the second bullet point in Table 4, with a focus on what constitutes risk and how risk changes over time. Might you tell us why this suggested improvement was made?
I was going to throw to my colleague, but I think I will make some comments if that's all right, and then ask Ms. Nolan to talk about something that we've done. First comment is that these recommendations are not recommendations that are recent. They are back from 1920. So a lot of these things have been addressed. I'd hate for people to think that this list was reflecting now.
Yes.
Yep. Thank you. So in terms of risk assessment, this doesn't just relate to open arms either. It's across the department. We have been working hard to make sure that we have a common language when it comes to risk assessment, right from our frontline staff who are processing claims, etc., all the way through to open arms, so that when we are focusing on risk, we're doing it in a way that if I talk about an at-risk client or a complex client, people understand what I mean. So we've implemented some standard risk assessment processes at the front end of clients interacting with the department, which enables them to quickly articulate and enables them to quickly identify, articulate what they see as the risk, and then escalate that up to our triage and connect team, who then work with that individual to make sure that they are accessing the services and supports that they need. But we have also done a lot of work in the open arms space, specifically about the introduction of a new suicide risk framework.
So in line with that, the new suicide risk framework, which is the Safe Side framework, which was developed by Dr. Tony Pisani, who has given evidence to this Commission previously, undertakes a dynamic approach to risk assessment, partnering alongside the client and ensuring that a range of factors are taken into account rather than more of an intrapsychic approach, which may have been the case previously. So the Safe Side framework encourages clinicians to assess risk, to do so in a systemic way, and to understand the poor predictability of risk assessment in relation to suicide, given the dynamic nature of risk.
Yes.
Sorry.
Might I ask, the open arms risk assessment that I think was introduced in April 2021, is that correct? Is that part of this initiative?
Yes, it is.
Yeah.
And
Thank you. And tell me, when you're looking at clients in a veteran context, a defence context, do you look at specific factors and unique factors to veteran life that might constitute a risk factor? So, for example, medical discharge, involuntary discharge, trauma in service, access to weapons and the like.
Yes, we do, and we also look at the nature of the operations on which the veteran may have been deployed.
Thank you. And how does this differ from the previous risk assessment that was undertaken? What particular improvements have you sought to implement?
In my view, it's taking into account more environmental factors as well as the intrapsychic factors. So understanding, as I mentioned, the fluid and dynamic nature of risk in relation to factors such as psychosocial support, relationships, financial distress, and so forth, all of which play a role in increasing risk for a client.
Thank you. And presumably to homelessness, as we've identified before.
Indeed, the whole range of what we would call well-being factors, which are psychosocial risk factors.
Thank you. And have you been able to undertake any assessments or measurements of the Open Arms risk assessment process to see whether there is a measurable difference? Not yet.
Not at this point in time, no.
Now, if I might turn to page 547 again, but maybe not this call-out box. And in particular, what I wish to focus on is the topic of care coordination and complex needs. You'll see there are bullet points 3, 4 and 5 there. Now, you indicated before, Ms Cameron, that some of these matters have been addressed. It may be they have. If so, by all means, I invite you to tell the Commission and in which way. Because certainly poor coordination of care and communication between service providers and a lack of continuity of care can be a risk factor for suicide and attempted suicide. Might you comment on these, the issues indicated there, and tell the Commission how they've been ameliorated?
So there's several things in this, and some of it Ms Noland has already alluded to in terms of complex case management. We also have care coordination and support for clients with complex needs across the division. So it's not just vested in Open Arms to provide the broad support that is required. So having Open Arms in this division along with our coordinated client support team enables us to have closer working relationships which provide the management of complex needs, not just from within Open Arms. They're not on their own in providing that. We've also implemented or just recently brought on a psychiatrist to provide greater clinical governance across, but also in this space. And we have regular meetings between the staff who are supporting clients with complex needs in a case planning and case management scenario. So not just staff involved, but also advisors who are doctors, who are psychiatrists, psychologists, whatever is needed, even pharmacists, depending on the particular case that's being looked at.
Thank you. And what are you able to identify the concrete things that you're doing in order to ensure that clients don't fall between the gaps? So in terms of ensuring that you have a robust working relationship with those other service providers.
Could I comment?
By all means.
Since these reviews have been conducted, we have employed more than 30 clinical care coordinators. We had a role previously which was entitled Complex Needs Coordinator. That was changed to reflect the clinical nature of the work that was being undertaken and the qualifications of the clinical care coordinators. Their specific job is to work collaboratively with multiple health providers to ensure that clients don't fall through the gaps. We also, as part of response to one of the recommendations from the reviews, established what is called the Enhanced Client Outcome Committee, I think it may be, which entails Open Arms working with our colleagues in the Coordinated Client Support Branch to jointly support clients who are clients of both, with the client's permission, of course. And we also have established referral pathways into other programs that are run through DVA, such as the Wellbeing and Support Program.
May I add something, Ms Rubigotti, as well? We've also implemented something called a disability support pathway. So we're not just talking about clients with mental health needs either, we're also talking about clients with catastrophic injury. Rather than having them deal with multiple areas across the department, they now deal with one area in my division so that they have a coordinated interaction with DVA.
Thank you. And when was that implemented?
That was implemented last year.
Excellent. And tell me, have these pathways and approaches been monitored or evaluated in some way?
Some of them, they're definitely being monitored, but some of them have not yet been evaluated because they're only new. But we are definitely going to be evaluating all of our programs on a regular basis.
Thank you. And in connection with that evaluation, will you be seeking, if you haven't already sought, feedback from service providers?
Yes.
Thank you. If I may turn now to the summary review for the suspected suicides from 1 July to 31 December 2020. And that is OPA.0003.001.0537. Thank you. Might ask you, operator, if you may, to focus on issues for discussion. You'll see there, Ms. Cameron, Ms. Nolan, the summary looked at 16 desktop reviews, and I might just ask you, Ms. Nolan, the desktop review, is that the same as the clinical incident review? Can you just remind us how it fits in the schema?
Under the clinical incident review framework, a desktop review follows a client summary. So when we do a client summary, we identify whether or not further investigation is required, and that would then be in the form of a desktop review.
Thank you, thank you. And operator, if I may ask you please to go to 0538. Or it might be 0537, I apologise, 0537 at the bottom of that page under common themes. So you can see there, again, we have similar issues arising. Might you comment on these findings? What is being done to fix it? Is it what you've already indicated, or is there more?
It's what I've already indicated. So these findings were very similar to what we were discussing before, and they were part of that gap analysis to see where we needed to make changes and improvements.
Thank you. And if you turn to the next page, operator, I think you'll see the recommendations. Might you comment on these recommendations, whether they have been implemented, whether they form part of the work that is presently being contemplated?
Yes, they have been addressed. And can I make one comment?
Yes, certainly.
Gotti? They have been addressed, but there are some fundamental things in here about training and documentation that we would not cease to address. So they would be things that we would revisit in an ongoing way to reinforce messaging, to make sure that new staff understand, etc. So I don't want people to think it's also just point in time and then we've set and forget.
So what is proposed is a continuous process of education, as it were.
Yeah,
all the staff.
We've actually nearly finalised our workforce management plan, and what will fall out of that is a training framework. There's a lot of frameworks I'm mentioning today, but a training framework that will articulate exactly what training our staff, no matter what role they're in, should be receiving in the first, say, 3 months, 6 months, ongoing and repetitive.
Thank you, thank you. And you can see there where there's a reference at bullet point 1, number 1.3, appropriate closure of cases. Is that a reference back to what you were saying, I think, Ms. Nolan, before, about ensuring that after the death of a client, the file is closed? What does that mean, appropriate closure of cases?
That is more in relation to the model of care than I described earlier, ensuring that we provide the requisite number of sessions to support the client's needs, but that we also don't make the clinical error of providing ongoing counselling where that's not required, which would foster dependency.
Thank you. And tell me, as to the changes that have been implemented and are being implemented, of any of these, are you in a position to demonstrate that practice has changed? Can you point to particular markers or things to show that?
May I comment?
Yeah.
I think, as I mentioned, we have engaged clinical care coordinators specifically for the management and support of clients with complex needs, and we have around 30 of those across Australia at the moment. I think it's fair to say that that is an ever-growing need and is not normally or necessarily part of a counselling service per se, but it certainly is part of a mental health service, and I think that that is something that we need to increase in terms of that care coordination capability. In relation to the open arms processes that prevent clients with complex needs from receiving both individual and couple counselling at the same time, that practice was based on previous risk assessments in relation to the risks to the couple, to the partner, if there were indicators of family and domestic violence. And we, in our model of care, we will be identifying how to manage those risks so that an individual who requires counselling to manage their anger, for example, isn't then necessarily on a routine basis refused access to couple counselling, because it does depend upon individual risk assessments.
Thank you. Thank you. And then, as you'll see there's a reference to post-vention, the development of specific options and pathways for post-vention activities. Are you seeking feedback from clients and friends and family about ways to improve that?
We are. One of the design principles for everything that we are doing is co-design, human-centred design. So we will absolutely be seeking feedback once we have a draft to talk about from not only the consumers of our service, but also the providers, our stakeholders, etc.
Thank you. Now, on this page, perhaps not in this box, there is, you can see that there's a reference in bullet point 2 to an audit of timelines. So we return here to the issue of wait times. And now, as to this audit, has it taken place?
The data I was referring to earlier, did you?
No.
Reflects that audit, and that is looking at the waiting period. So, as I mentioned, 50% of people are seen within 14 days of having entered our system. We are looking at, and we can identify the gap between allocation, which is where the client comes into our system and is allocated to a counsellor, and then the gap between the client being allocated and then actually seeing the counsellor. But that gap between being allocated, as in being given the counsellor's name, and seeing the counsellor may depend upon a range of variables, including client preference in relation to their availability as well as counsellor availability. And we, in terms of identifying patterns and frequencies of delays, we do look at that data to tell us where we may have an outreach program counsellor, bearing in mind that the bulk of our clinicians are based in their own practices in the community, may have accepted a referral, but may not then have seen the client for a period which we would deem unacceptable. And some of that work is being undertaken to identify where there are issues, and that's done at the regional level, to then provide feedback to that counsellor about the need to, if they've accepted a referral, they need to see the client within a defined period.
Thank you. And tell me, Ms. Nolan or Ms. Cameron, how is a client's mental health monitored during this period whilst they're waiting from intake to allocation and the like?
This is where the contact with clients on the waiting list is made. The bulk of the waiting times is in relation to, as I mentioned, specialised services such as relationship counselling as well as services for children. And part of the role of the Assistant Director for Clinical Operations is to actually keep touch with the clients on the waiting list to ensure that there is no increased risk, to explore whether there are any other opportunities, whether perhaps they may be willing to accept telehealth, depending upon the nature of the clinical presentation and what's required.
And is that...
Sorry, Ms. Rubicotti.
No.
I just wanted to make sure it was really clear that as part of intake, a risk assessment is done at intake. So clients are not put on a waiting list if they are prioritised as high needs and need to be addressed quickly.
May I comment? And the pathway then is that we would refer those clients who are assessed as at risk or in need of urgent attention, which is usually within 36 hours, that they are actually seen by one of our in-centre clinicians, where we have greater control over case allocation and caseload. For counsellors in the community, we don't control their caseload. They see clients from a range of referrers. We're simply one referrer.
Thank you. And tell me, who is undertaking that intake clinical risk assessment?
Our clinicians who are employed on our 24-hour telephone service.
Thank you. Now, if I can return, please, to the recommendations, and you'll see that there's a reference there to targeted training and all the recommendations that are indicated there. It appears to us that a number of the same recommendations were being made in clinical incident reviews of suicides that took place over a 2-year period. So recommendations were repeated from individual, you would find with an individual clinical incident review, one recommendation will be indicated, and yet again you would see it in another clinical incident review. Does this mean that no action was taken in the period, or what is the reason for the repetition in the identification of the same problem? That appears troubling.
So what happened here with these two documents that you're looking at, they were actually taken in reasonably quick succession. So they were not done, at a considerable time period apart. So they were looked in totality in terms of the recommendation and the gap analysis. So there wasn't a great space of time between the two reviews in terms of when they were conducted.
I see. And conversely, there were a number of recommendations appearing in individual files that then were not repeated. So they were one-off recommendations, as it were, based on the particular facts of the clinical incident review. And I can provide for the benefit of my friends some reference numbers. These ought not be displayed. OPA.0003.001.0517 and OPA.0003.001.0549. Now, where you have individual recommendations made, how do you ensure that they are picked up and analysed and determined whether they present a real systemic problem that needs to be addressed?
So the individual recommendations, my understanding is most of them were addressed with the individuals involved. So individual counsellors, or if it was a process that needed to be looked at. They may be individual, but they're still collected in inverted commas to see whether or not over time there isn't a systemic issue there, if that makes sense. So the way the adverse events analysis framework will work is that we will look at individual cases to learn from those individual cases, but we'll also be looking at aggregated across time. So individual issues need to be addressed quickly. The aggregated or systemic issues build up potentially once we get to look at one or two or more. And that's what you're seeing through these reviews, which actually looked at a number of cases. Thank you.
And tell me, would you accept that where we have recommendations that have been reiterated and not yet implemented, that poses a systemic risk for suicide and attempted suicide and suicidality?
I think it depends on what the risk is. Some of the things that were recommended were around our system and making changes to our system, which will necessarily take time, take resourcing. I do agree that as we've said earlier, any things that need to be fixed, any changes that need to be made in a service such as Open Arms, we absolutely need to ensure that they are fixed so that there is not any risk flow on to our clients. But some of the things behind the scenes in terms of, adapting systems and that sort of thing, the risk to clients would not be as great.
Thank you. And Ms. Nolan, I think you were nodding a little bit earlier. Might you have a comment to say in relation to what Ms. Cameron has said?
No, I just wish to agree, but also to point out that we engage and employ very experienced clinicians who are very passionate and committed to the veteran community and the families. And I just want to ensure that it's clear that we do take that clinical responsibility very seriously, at the same time as we are looking at the back office things such as the systems, as it were, that may not promote opportunities for the best practice.
Thank you. Now I just move to one of our last topics, and that is the summary review concerning the suspected suicides on 31 July 2022. Operator, if you could please display OPA.0003.001.0427. Whilst that's being done, I might ask a question of you just in relation to the clinical incident review process. Are families involved in that?
At this point, there haven't been. The cases where we have done the full review, which again aligned with the adverse events analysis, is that tertiary level of investigation, which is a panel established. we are in the process of working out the privacy considerations in relation to that.
Do you see benefit in involving families in some fashion?
Yes.
Thank you. Now, as to this document here, is this the document referred to, I believe it is, in paragraph 7.21 as a summary analysis of 31 July 2022? I think you're nodding, Ms Cameron.
Yes.
Thank you. Now, this does not appear to be a summary review like those we've already considered, but it's a demographic overview of all suspected deaths by suicide of Open Arms client. Is that an accurate description?
Yes.
Thank you. And what's the purpose of this document?
So this sort of overview, mining of our data is being undertaken within Open Arms and data and within DVA data, and they're necessarily separate because of the privacy considerations around Open Arms, so only certain people have access to that data. So as a department, we are looking at all of the demographic data we have, all of the service data that we have, all of the service usage data that we have, to see whether or not there aren't trends or clusters or themes that we can use to target communications, service change across the department, etc.
Thank you. And finally, on the question of the summary reviews, are you able to indicate when the next summary review of the clinical incidents review will take place? Or is that to be subsumed in some other process?
That will be picked up under the adverse events analysis process.
I see, thank you. Now, moving then just briefly to some topics concerning governance and accountability around the clinical incident review process. It's the case, isn't it, that these reviews are to be completed within 3 months, is that right?
That's the in policy intent, yes.
Yes, and we have noted that in a number of the reviews that time frame was not met. Are you able to comment on that?
There was unfortunate delays for many and various reasons, some of which was to do with resourcing, some of which was to do with priorities at the time. The adverse events analysis framework will provide a much more robust and consistent approach to how we undertake this.
Thank you. And tell me, has your accreditation body commented in any way on the failure to meet timeframes? Is that something that's been the subject of any sort of issue?
That's a good question. I would have to take that on notice. I can't recall.
Thank you. Turning then to the review of the review process, as it were, the review of the clinical incident review system. Is it subject to some sort of monitoring?
In what way? What do you mean?
Is the process of undertaking clinical incident reviews itself monitored and evaluated?
Oh, okay. Yes, and again, that will be further formalised under the adverse events analysis process, where we will have recommendations and responses to those recommendations. We'll actually have oversight within a committee in DVA's formal governance framework.
Thank you. Now, there is the Continuous Quality Improvement Steering Committee. Is that the committee or is it another?
No, it's the Service Performance Committee, which largely consists of all the First Assistant Secretaries from across the department. So we have departmental-wide visibility of service issues, but also of any enabling issues that might be contributing to.
I see, thank you. And the committee to which I just referred, does that have a role in escalating systemic issues that are not addressed under the existing arrangements?
The Continuous Quality Improvement
Steering
Committee?
We now have a quality and safety program across the division. One of the, again, benefits of Open Arms coming into the Mental Health and Wellbeing Services Division and being more closely aligned with DVA is the opportunity for us from a divisional perspective to actually track quality and safety risks to clients across the division, given our shared interest in supporting vulnerable veterans and families. So that previous iteration is currently being subsumed into the overarching quality and safety framework.
Thank you. And then just some final questions. And we observed that on a number of the individual clinical incident reviews, that they bore the statement under the heading Governance Committee comments, a statement to the effect that the Open Arms Committee is non-operational in 2022, awaiting MHWSD safety and quality reporting structure. Are you able to comment on that?
I'm not entirely sure where you're referring to, where you're getting that. So,
this is a statement that appeared on a number of the individual clinical incident reviews. I don't want to display them for obvious reasons.
Yep. Yes. No. Fair enough too. No. As Ms. Nolan indicated, that process is being subsumed into the safety and quality framework that's being developed across the whole of the division. So the oversight of what is being done to review and meet the recommendations to make sure that they are implemented would rest with me whilst that is being put in place.
Do you think that there are any systemic risks or issues in that committee having been suspended in 2022, or were they dealt with in some other fashion?
So it has been suspended, but it is being replaced with a separate body. So it's there will be a slight gap while we move from one to the other, but there will still be oversight.
I see. Thank you. Just one last question for each of you. The Commission has heard that there are a lot of things in train and things being developed and things are happening. I think the Commission would like to know, and probably many members of the public would like to know, when will those things be done? Might you comment on that?
Yep. Thank you. Can I give context as to how I've approached since the division has been formed?
Certainly.
Yep. So I started looking at culture first within the division. There is a saying that culture eats strategy for breakfast. I do think culture eats everything for breakfast. So we started with culture and engaged our staff very early on in what I called a health check. To elicit from them where they were seeing pressure points, issues, suggestions, etc. And we came out with 11 areas in which to focus, and staff volunteered to sit on working groups, and we have 11 action plans now to follow through on that. At the same time, we were looking at some of the underpinning processes, the governance arrangements, the accountabilities, the compliance arrangements, so that we had a common and solid language and understanding of what our responsibilities are across the division, and so that we had a nice solid framework on which we could make improvements and changes. Whilst that was also going on, we were looking at some of our programs. Some of the programs have not been reviewed in quite some considerable time. They are now undergoing a review. We started to lift up issues like quality and safety to a divisional level. We started, as I said, looking at our workforce management, at our strategic property, and then our training framework. So there is a lot under development. What my vision is that will all culminate at the same time or thereabouts with the project that Jennifer, Ms. Veach was talking about yesterday, so that we have our culture, our scaffolding or our underpinning frameworks, our programs and our future possibilities all coming together to actually articulate a clear way forward. It is a big and very complex division. It is taking time to work through this, but that's the direction that we're taking.
Thank you. Ms. Nolan, did you have anything to say in relation to that?
Only that, referring to Ms. Cameron's comment earlier, that Open Arms is the only mental health service delivery agency in the Commonwealth, I think that there are opportunities for us in terms of aligning ourselves more in that context of a mental health service similar to what the states and territories have enacted in relation to governance, outcomes monitoring, quality and safety. And because of my background, that is something that I'm able to bring to that role. And I think it is something that I would like to have in place sooner rather than later, but it is something which, with the benefit of fresh eyes coming in, I can see there are some opportunities where we could make our system more robust and provide. We do provide excellent services, I have to say, but there are always opportunities to improve. And I think part of that is aligning ourselves much more in that mental health context.
Thank you. I think the key question is when, but I will leave that with you and invite the commissioners to ask questions.
Thank you. I'm conscious of the time. We'll try and keep this short. We're going to break for lunch late, obviously, and we will start slightly later. Commissioner Douglas.
I only have a couple of questions related to the homelessness issue, which was touched on earlier. You spoke about, for example, sending a homeless veteran to a hotel for temporary accommodation. Do you liaise with the state or territory-based social housing operations as well?
Very much so, yes. So we have established relationships in each of the regions, and through our colleagues in our policy space, in the Veterans and Families Policy Division, we have that at an overarching level as well with the peak body, which is the Community Housing Industry Association.
Is there any liaison with other services, including state-based services, to inform your veterans who may be homeless? I'm thinking of, say, police or charities such as the Salvation Army or the St Vincent de Paul Society.
So part of bearing in mind that we are community-based, in each of the regions we have relationships with those key stakeholders, which would include relationships for us to refer to them, but also for them to refer to us. But there is more that we could do.
Because we have come across, I think it was the Salvation Army, which had an operation trying to assist homeless veterans, and with the facilities that you have, it would be certainly good to see that sort of liaison being implemented. Thank you.
Just two very quick questions, perhaps for Ms Cameron. We've received information that the DVA is recent, and my question goes to firstly policy and then communication of new policies to your stakeholders. But we've received information which I'm not certain is correct, that DVA has ceased payments for physiotherapy and exercise physiologists, providers of those services, to non-liability white card holders. Are you aware of that? And if so, are you able to comment on what communication may have taken place with stakeholders before it was implemented? And that's really the thing I want to get to. It's the communication with stakeholders, both the service providers and the clients.
So perhaps I can just talk about the exercise physiology comment first, and then go to communications generally, if that would be helpful. Non-liability healthcare relates to mental health services. There was quite a lot of exercise physiology being claimed under non-liability healthcare arrangements. My understanding is they were not part of what non-liability healthcare was meant to cover. So we haven't ceased providing exercise physiology, but we are ensuring that it is appropriate in terms of the legislation and the entitlements attached to that. Yep. In terms of communication specifically about that issue, that doesn't sit within my division, exercise physiology as such. I'm not entirely sure what was undertaken at the time, but we can find out.
If you can, I'd be grateful. Thank you.
Would you? Oh, I was going to offer anything general about communications with providers, if that would help.
Certainly. Yep.
So we have a provider engagement team that is attached to our Chief Health Officer. They engage with the peak bodies of all the health professions on a regular basis through a forum. But the Chief Health Officer also has a number of initiatives underway. One of particular interest is where she's working with the primary healthcare networks to make sure that veteran-specific information about services is available, so that particularly GPs at a local level have easy, quick information in a form that they are used to, and in a method of getting that information that they're used to, i.e. not having to trawl through DVA's website, is available to them, and they can support their clients, and also focusing on making sure that they are asking, have you served, so that they can be supported by DVA.
Thank you. Just one last question. You mentioned earlier, Ms Cameron, that you described the DVA as being primarily a funder, not a service provider, obviously, which is clear. If you were to sum up in one sentence in layman's term the mission statement for DVA, how would you sum it up?
So the mission statement is to commemorate, care and provide support for those who have served.
Thank you. Commissioner Brown?
Thank you. I, as always, have a million questions and have no time to ask them, but can I just follow up on that response about the exercise physiology? I hear what you said, that you're kind of putting a stay on it while you're looking at it further, but I would just offer the comment that my observation would be exercise physiology has had an increasing place in mental health service delivery over the last 5 years or so. So it's interesting to hear that perhaps that's not the direction you're going, but...
My comment relates more to the legislative eligibility associated with non-liability healthcare.
Yep. Can I go to a really fundamental question? And I did ask this the other day, but and it's why DVA runs Open Arms. And the answer I got was that it's historical, and we've heard that today, again, the historical kind of origins of Open Arms. But if it is the only service delivery program that's run by the Commonwealth, you have to ask the question, why? Given that you review things all the time, have you actually reviewed whether there is a strong and compelling rationale to maintain this service delivery? And if you have, can you please tell me what that rationale is?
So that has been looked at several times through the years, it being a 40-year-old service. I do fully expect that that is going to come up as part of the work that Ms Veach was talking about yesterday, that will be something that we will need to address again and work through. It is an extremely valuable service to have within the department. The responsiveness and the care and support that Open Arms provides to veterans, I understand why successive secretaries and ministers would want to keep that close. It's not just historical. A conscious decision was made by government in 1982 that it would be administered by the government. However, in the 90s, the department divested ourselves of all of our repatriation general hospitals, our repatriation artificial limb and appliance centres, convalescent hospitals, mental health facilities, but retained Open Arms. I don't have specific visibility of the reasoning that took place at that time, but Open Arms was certainly not on the table to be divested like those other functions.
And I understand what you said, that it's very valuable to the department and that it can be responsive to clients. But I guess the question is an alternative model able to be as responsive or perhaps more responsive than the current model? And in relation to that, I guess I would like to understand whether Open Arms actually has some exclusion criteria in terms of whom it may take on as a client.
So in terms of specific consideration, I am aware that as recently as about 3 years ago, certainly some options were put together about whether Open Arms would remain with DVA or not, and they were considered by the current secretary. But I'm beyond that. It was not something that was in my remit at that time.
So sorry, I don't think that answers my question about the criteria for Open Arms, whether you've got exclusion criteria.
I was going to leave that to Ms Knoll.
Okay.
Thank you. We don't have specific exclusionary criteria, but we have eligibility criteria, which people are required to meet in order to access the service. And if I may expand a little, if we do have people approaching the service who don't satisfy the eligibility criteria, we will provide a brief intervention and referral on service.
Is that achieving an exclusion criteria without writing it down?
Well, we are a service established for veterans and families. We do sometimes have people who are neither veteran nor a family member of a veteran approaching the service.
Yeah, I guess, thank you, that makes sense. I'm more interested in terms of the level of severity or complexity.
Well, this is where we have some benefit over our colleagues in the states and territories, where we have a degree of latitude in accepting people with a range of clinical acuity, as it were. As I mentioned, we provide family and relationship counselling, we provide wellbeing support services, we have our peers to work alongside veterans who may not require a clinical intervention but would benefit from psychosocial support, as well as our counsellors, as well as referral to psychiatrists. So we have quite a broad range in terms of that staged model of care. We don't exclude people on the basis of the severity of their symptoms or non-severity.
I have to say, to some extent, that perhaps is of concern, but I'll perhaps leave that. Can I just ask, in terms of the wait times, and I appreciate you gave us some figures as a kind of general average, and I appreciate there's many subcategories under that you referred to. Can I ask for a breakdown in the kind of broad terms between the wait times for people who are seen by open arms employed staff versus those seen by the outreach?
Yes, we can provide that.
You can't tell me
off the top of my head. I can say that we will, if as I mentioned earlier, if somebody has a high level of risk or an urgent need, then we will prioritise them for our in-centre counsellors, because we can have more control over caseload size and so forth. But I couldn't tell you off the top of my head.
And if I can just explore the process a little in terms of understanding, someone makes contact with Open Arms, is that via the 24/7 telephone service?
Correct, yes.
And again, and I kind of referred to this yesterday, we've heard multiple accounts of people who've made contact, had a brief interaction, told that someone will ring them back. Someone rings them back and takes their administrative data, and then told they'll have to be contacted in a week or so, with details about an appointment, and then they have to actually wait for the appointment itself. Is my understanding of that process correct?
At one level, yes. If I can provide some greater granularity, 40% of the calls that we have through our 1-800 number are administrative in nature, so they're people wishing to change an appointment time, wishing to have access to information about other services and so forth. So we have a huge administrative component to the calls that come in. 28% of calls are of a clinical nature and are transferred directly to a clinician, but because we don't have sufficient numbers, if you like, of clinicians always to take all of the calls, for the 20% are then reliant upon a callback from the clinician. But usually the person taking the demographic data, as it were, or assessing the eligibility criteria would actually be the clinician rather than the administrative operator, to avoid our clients having to tell their story more than twice. We are looking at that at the moment, because there may be some opportunities to further refine that, so that the client assist 24-hour service is more focused on the crisis intervention and allowing the regions to pick some of that up, but we're just looking at what that might look like at the moment. In terms of the delay in contact, it's difficult to comment without knowing the specifics. Part of our triage process is to identify whether the need for service is urgent, or sort of emergency, which is immediate, urgent, which is usually within 36 hours, or non-urgent, which may be within a week, depending. And I would be disappointed to think that people weren't getting a timely service, but it's difficult to comment without knowing more specifics.
So those time frames, so if they don't get a clinician for that first contact and they're on the callback, the callback has to be within what time frame?
12 hours at the most, but it's usually within a couple of hours. It's the same shift usually. So if we have shifts at each different points of the day, and it would be the same shift that would then call the client back.
Do you monitor that?
Yes.
Okay. And then in terms of, you said the 3 categories and the third one being within 7 days.
For non-urgent.
For non-urgent. Is that for an appointment?
That would be for the individual to be contacted and for an appointment for an allocation to be made. So we have a 2-step process, which is the allocation to a counsellor, and then an actual appointment with the counsellor being realised, i.e. the face-to-face contact being made.
And so what's the 7-day target for?
So it's less of a target and more of a time frame depending upon what the client identifies as being their level of need, as well as what the level of risk is that is assessed by the clinician on the telephone.
But sorry, is that for the appointment to be given or for the attendance?
That could be for the appointment to be given. It depends, because the person may be ringing in for a program, for example, a program access. So if they're wishing to participate in one of our group programs, we run those periodically. So it would depend. And it might be better for us to provide that information to you. I can actually provide you with the data.
Thank you. Can I just ask on that, is this data published anywhere?
Not to my knowledge.
Okay, thank you.
Sorry, it's wait time data might be published in the annual report, but I'd check that for you.
Thank you. If you could provide it to us in any event, that would be good. You spoke earlier about the potential for the client coordination support branch, if I've got the right
Coordinated
terminology.
client support. It's all right, we
Coordinated
do it all
client
the time
support.
internally too.
What is their capacity? How many clients can they manage at any point in time?
It varies between the types of teams that we're talking about. So we have it's about 300 staff in that branch, and if you're looking at general case coordination, their caseload can be around 25 to 35. In service coordination, it's higher because it's a very intensive support, but then it's a very long tail of irregular or less frequent contact. When we are talking about some of our transitioning members, it's a smaller caseload because they are quite intensive supports that need to be worked through and put in place. So it does vary, but again, we can get you the data on that too.
Does it meet the need?
We don't have a wait time as such for those services. The triage and connect function, so the doorway into these higher level supports, actually provides a short, sharp intervention, which in 60% of the cases that they're dealing with means that clients don't need to go on to additional supports. We get things sorted for them in the space of a couple of weeks. So having that function in place means that we do have capacity at the back end, and whilst we've seen significant growth in the number of clients that are referred to these services, we've also had commensurate growth in the number of staff.
Do you get feedback from the clients about that service? Because I'm just sitting here trying to reconcile, on that one hand, what I hear from people, and again, as I always try to do, I acknowledge that we are probably hearing from the people who feel somewhat disgruntled, perhaps, rather than the people who feel they've had a great service. But from the people that we've heard from, we hear not so good stories. Things aren't coordinated. They don't feel that there's been timely access. It doesn't feel like there's been connections made with other services, etc., which obviously begs the question about whether you've got the resources to actually match the need as determined by the clients, not by the department.
Sure. I think it's important that I do note that the clients that are supported within CCS represent between 1% and 2% of our clients overall. So they really are the top pointy end of the client triangle demographics. CCS has only really come into being in the last probably 4 years at the most. We have had case coordination, which started in response to the Dunt report in 2009, but it was very specifically about the claims process, and it was extremely limited in numbers, the number of case coordinators that we had there. So it is a capability that has largely come into being in the last 4 years only. So it's potentially there are people that have interacted with DVA before that, but it is a service that has been made available to only a small number of our clients at any given point.
So that 1% to 2% represents the percentage of your clients who have needs for coordination?
Based on the referrals that are being made to us from our veteran support officers, from our claims delegates, from our frontline telephones staff, they all come through and are assessed. So yes, would be my long-winded answer. Sorry.
Again, I would really, to better understand that, need to see your criteria for
Of course.
the cut-off as to who qualifies and who doesn't.
Very happy to.
To understand whether it actually is meeting the need the clients might identify versus the need, well, the categories that the department.
Very happy to provide that, and we can also provide feedback data as well on that.
Yeah, that would be good. Thank you. I think in the interest of time, I might leave my questions there and perhaps put the others on notice in writing.
Thank you. Ms Chalmers, any questions? Okay, thank you. Mr Fraser, any questions?
No, thank you, Commissioner.
Thank you. Mr Fordham, any questions?
No, thank you.
Ms Ribagotti, are there any matters arising?
No, just releasing the witnesses from their summons.
Okay. Thank you for your evidence today. It is much appreciated. We're obviously running way behind time. We'll just take a short break, unfortunately, for lunch and come back at past. Thank you.
Thank you.
All rise. The Royal Commission is adjourned to 1:30. The Royal Commission into Defence and Veteran Suicide is resumed. Please be seated.
Good afternoon, Ms Bridget.
May it please the Commission. Commissioners, the next witness is Wing Commander Martin Parker, Commanding Officer 75 Squadron 81 Wing, RAF Base Tyndall, who is present in the hearing room. But before we commence, as a matter of housekeeping, Commissioner, if the previous two witnesses, Leonie Nolan and Leanne Cameron, can please be released from their summons.
Yeah, my apologies. We neglected to do that before lunch. They're released from their summons.
As the Commission pleases. Commissioners, as you heard last week, RAF Base Tyndall is located approximately 17 kilometres southeast of Katherine and approximately 320 kilometres southeast of Darwin. Katherine is the closest town to Tyndall and the fourth largest town in the Northern Territory. The airfield at RAF Base Tyndall was established in 1942, was originally called Carson's Airfield. It was declared an operational Air Force base in 1984. RAF Base Tyndall is the Air Force's major operational base in the Northern Territory. The base supports the flying operations of Air Combat Group's No. 75 Squadron, operating F-35A fighter aircraft. The base is also home to Combat Support Group's No. 17 Squadron, which provides and coordinates support at the base to 75 Squadron. Last week, Commissioners, you heard evidence from a panel of defence witnesses, one witness from 17 Squadron, a witness from the Health Centre, a senior chaplain and a base warrant officer. This afternoon, it is anticipated that you will hear evidence about 75 Squadron, and as it relates to the well-being of the aviators within that squadron. Associate Wing Commander Martin Parker can now be affirmed.
Wing Commander Martin Parker, do you solemnly declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth?
Thank you.
Can you please tell the Commissioners your full name?
It's Martin Thomas Parker.
And did you prepare a statement in response to a notice to give a statement issued to you on the 15th of September 2022?
I did.
And operator, please display DEF quadruple 9 0031 0053 _R. Wing Commander Parker, you produced two statements, a redacted and an unredacted statement, is that correct?
That's correct.
And do you recognise this as the first page of your statement?
I do.
And the statement is dated the 4th of October 2022, is that correct?
That's correct.
And it's 96 pages with an Annexure A, is that correct?
That's correct.
And are the contents of your statement true and correct?
Yes.
Would you like to make any corrections, Wing
Yes.
Commander? You would. And what corrections would you like to make?
I believe you've been submitted a couple of amendments we can cover off on.
Yes. So to assist you, Wing Commander, I will hand you a document. Do you recognise this document?
Yeah, that is correct. That is the amendment.
And the amendment is the amendment to Table 4.5 in your statement, is that correct?
That's correct.
Commissioners, I tender the correction. I tender the document with the correction. My apologies.
Thank you. Will be accepted on that basis and allocated the next consecutive number.
And Wing Commander, would you like to make a correction to Annexure A?
I would.
And what correction would you like to make?
the ACG headquarters is located at Williamtown rather than Amberley.
And Commissioners, I tender that document.
Thank you, that's accepted.
Wing Commander, so I'll ask you the question again, noting those corrections. Are the contents of your statement true and correct?
Yeah, my apologies. There is one more correction, which is to paragraph 338, question 37, which is on the reverse side of the previously submitted table.
Wing Commander, did you say paragraph 338?
Correct.
And what was the correction?
The correction is an addition that I'm also aware of an incident in 2022 which meets the criteria identified in the question. So that is one additional incident in 2022.
Thank you. And on that basis, are the contents of your statement true and correct?
They are.
Thank you, Wing Commander.
Thank you, that's noted and accepted.
Commissioners, the tender bundle list, which I'll ask the operator to display, is comprised of 94 documents. The list also comprises a list of previously tendered documents. Items 2, 3, 19, 70, 84, 85, 86, 89, 90 and 94 are tendered on a confidential basis. Some of them are the subject of continuing discussions with the Commonwealth, and if appropriate, redacted versions will be tendered as public exhibits in due course. Item 86, Commissioners, is one that may receive particular attention in this examination and is the snapshot survey results for 75 Squadron. The survey is aimed to assist unit leaders to understand and respond to a range of issues that may be impacting the health, safety and performance of that unit, and asks about workplace issues. The Commonwealth's claim in respect of that document is based on concern about whether or not individuals might be identified from some parts of the document, and the claim is being considered. Although the document is tendered at this stage as a wholly confidential document, on that basis, those assisting you and acting for the Commonwealth have agreed to some provisional redactions of document 86 for the purposes of this examination. In saying that, I do not intend to show that document during the examination, and we will deal with those matters after the hearing, Commissioners. On that basis, I tender the documents on the list.
Thank you, they're accepted on that basis and they'll be allocated the next lot of consecutive numbers.
I'm grateful, Commissioners. Wing Commander, this examination is set down for 3 hours. I expect the whole time will be taken. I have a number of questions, and I wish to state at the outset that my questions are not intended to cast aspersions or criticise you, even though the questions may appear that way. I have to ask these questions in order to assist the Commissioners in their task with respect to the Royal Commission's terms of reference. At any point you do not understand a question that I've asked or you haven't heard it, I will do my best to either repeat it or rephrase it for you, and please do just let me know. And if you would like to take a break at any time outside of the allocated adjournment set down for this afternoon, please do let me know. And I will also mention now, as I have just stated, that the Commission has heard evidence last week from other defence witnesses at Tyndall Base. I may refer to that evidence from time to time, time permitting. In terms of, I'm now going to just ask you some questions about your qualifications and your service history. You joined the Royal Australian Air Force in 1998 after graduating from the Australian Defence Force Academy in 2000, is that correct?
That's correct. That is correct.
Thank you. And in 2002, you graduated from the pilot's course 190. Wing Commander, is that correct?
That's correct.
And can I ask you what inspired you to become a pilot?
Top Gun version 1, US aircraft carrier calling to port in the city of Perth that I went on, and some general aviation experience as a young teenager.
Thank you, Wing Commander. Do you expect to see an increase in recruitment following Top Gun Maverick?
One can hope.
In 2004, you graduated from the F/A-18 operational conversion, is that correct?
That's correct.
And 2011, you became a fighter combat instructor. Had you always wanted to be an instructor, or was that a Top Gun inspiration as well?
A little bit of inspiration, but it's as a junior fighter pilot, you quickly learn that is the pinnacle professional path within that mustering, and so that was the inspiration.
Thank you. I might get you to just, yes, it was difficult because I couldn't hear you before, but now I think it's kind of popping a little bit. But and in 2021, you converted to the F-35A Lightning II. Is it correct that plane is a high-performance aeroplane?
That's correct.
And they're the planes that you oversee in terms of the operation at Tyndall Base?
That's true.
And you hold a Bachelor of Science in Physics from the University of New South Wales and a Master of Military and Defence Studies from the Australian National University?
Correct.
And in terms of your service history, between 2005 and 2007, you completed your first operational tour with 75 Squadron?
Correct.
And between 2008 to 2018, you served at all of the Williamtown fighter squadrons of number 81 Wing. Is that correct? And during this period, you also served in 81 Wing headquarters as the standardisation officer from 2014 to 2016, and then as the executive officer in 2018.
Correct.
And during this same period, you deployed on the first rotation of Australian Air Task Group 63 within the Middle East region, and for which you were awarded the Chief of Joint Operations Commendation in 2015. Is that correct?
Air Task Group 630, that's correct.
Thank you. And in 2016, you redeployed on Operation Okra as the executive officer for 3 Squadron and flew a total of 26 combat missions over Iraq.
That's correct.
And in 2020 and 2021, you served as the Air Combat and Weapons Requirements Officer within Air Force Headquarters in Canberra.
Correct.
And in December 2021, you were posted to RAF Tyndall as a commanding officer of 75 Squadron, and you are currently in that post. Is that correct?
That's correct.
Wing Commander, before this Royal Commission commenced its public hearings in November 2021, how would you describe your level of knowledge about mental health, suicide and suicidality within the Royal Australian Air Force, which from now on I'll just refer to as RAF? How would you describe your knowledge of mental health, suicide and suicidality within RAF before the Royal Commission commenced?
I make no delineation between the Royal Commission having commenced for my knowledge. The main knowledge step change for me was taking command of 75 Squadron. Prior to taking command, I had a fairly basic understanding of mental health, suicide, suicidality, had some experience around some isolated events, but not to which I was responsible for the management of. But since taking command and with the responsibility and welfare of a large number of ADF members, then my knowledge has increased as a result of that.
In terms of your knowledge before you took on, you were appointed, if I can say that, as commanding officer, how did you obtain your basic knowledge?
So prior to taking command, my basic knowledge came through, I guess, a couple of different mechanisms, formal training or mandatory training, includes suicide awareness within Air Force and I believe within the broader Defence Force. That happens on an annual basis. So that's formal training through other mechanisms such as safety days. We would receive presentations from medical officers, personnel capability officers that discuss suicide in the workplace. Prior to taking command, undertake notification officer training, which is a course designed to give you the qualification to advise a next of kin in the event of a death or serious illness, to which suicide was covered as part of that training. They were the main mechanisms that come to mind as a part of, I guess, core business.
Thank you. And since becoming commanding officer, you said that your knowledge has increased. Is that a fair characterisation of what you said earlier?
That is, yep.
And how has that knowledge increased? In what ways?
And prior to taking command, Air Force provides commanders to be a commanders seminar where we focus on a variety of legal, administrative and other welfare matters that will affect the people under one's command, and that includes those topics. And we receive presentations from professionals in those areas designed to upskill us with the latest information to prepare us for command. And then, of course, there's nothing like doing the job and working through those instances as you go to learn, and that is the greatest learning tool. In that regard, I lean heavily on some of the experts that are both internal and external to my unit that provide me advice on those matters. And through that process, through the discourse associated with their expertise, my knowledge has increased.
In terms of the seminar and the professional lectures or discussions or workshops, whatever they were, in what format they were, how long what was the duration of those? And I'm more interested about how long the duration on the specific information sharing or training on mental health, suicide and suicidality in that commander's course, if I can call it that.
The commander's seminar, from my recollection, was 2 or 3 days, and we might spend 2 or 3 hours on any particular one of those topics. I don't recall the exact duration.
Thank you. And what do you see and what do you understand to be the factors that contribute to suicide and suicidality for RAF members? And if you want to focus on 75, you can without disclosing any details. But the question really is to ask you what you see or understand to be risk factors of suicide and suicidality and even poor mental health, if you like, for RAF members.
I understand, and it's been my experience in command, that suicidality is an extremely complex issue, and one that even the health professionals have not necessarily fully understood the factors. So I think it's hard to characterise it in total. But if I understand your question correctly, you'd like me to discuss what factors related to the individuals at 75 Squadron might influence suicidality. Is that correct?
Yes, or what might contribute. And you can draw on any knowledge that you have, whether it be during your service in terms of your observations or what you're seeing at 75. But my question really is for me to understand what your knowledge is about risk factors.
Sure.
Sorry, can I just ask this be kept at a very general and high level, given that we're dealing with suicide and suicidality and there are individuals who may identify?
I accept that, Commissioners. I'm happy to frame the question in just a general term in terms of what your understanding is generally around what you think are the risk factors contributing to suicide and suicidality.
Thanks.
If I could just, before you answer, Wing Commander, it's probably remiss of us not to have mentioned earlier, if anyone is struggling either watching this here or watching this at home via live streaming, we do offer counselling and support for anyone who is struggling with this very difficult topic. I'd urge you, if you're uncomfortable or we feel a little bit distressed by what's being discussed, please, if you're here, contact our staff. They are all here and we have counselling available. Or if you're at home, you can certainly arrange through the website to speak to someone to receive counselling. We're happy to assist in any way we can if anyone is distressed.
Thank you, Commissioner. It was also remiss of me to not mention or state a warning prior to this examination. I'm grateful, Commissioner. Wing Commander, unless you need me to repeat the question, I'm happy for you to answer it.
I guess I would restate the complexity of the issue, but a couple of things come to mind. One is trauma. So an individual who's experienced trauma in their life through whatever experience has created that, then I understand trauma to be a factor. Isolation is something, whether that's physical isolation or mental isolation, then that can be a contributing factor to suicide. Support networks or an absence of them, which I guess in part links with isolation. Health and well-being generally. So satisfaction in profession, satisfaction in health, satisfaction financially, the various life stressors, if you like, depending on how well life is going for you, would be another area that contributes to your mental health.
Are you aware of any demographics that might place people at a higher risk, for example, age, gender, sexuality, relationship status? And it's okay if you don't, Wing Commander, it's not a test, but are you aware of any of those demographics that may be a risk factor?
My understanding is that suicidality crosses age, gender, ethnicity, and so no, I'm not aware of any specifics there.
So would it surprise you to read or hear that for women leaving the ADF there is a much higher rate of suicide than in the general population?
Yeah, I was unaware of that.
Thank you, Wing Commander. And the Royal Commission is also obviously interested in protective factors. What do you see or understand as factors that might prevent suicide or suicidality? And again, please, just in a general sense, and just drawing on your experience and observations, what do you think could be some, what we refer to as protective factors for ADF members?
I think I think there's a few factors involved in prevention or aiding the prevention. The first is the discussion, so the education across a squadron or across the Air Force, across the ADF, to raise the awareness. I've seen a significant increase in the awareness training and the general discussion around suicidality over the course of my career. I think having those elements or that knowledge front of mind enables both the individual to be armed with a sense for what they are going through and be better prepared to respond to that, to speak up and to seek help. More broadly, I think the peer networks, the leaders and managers at every level are better armed to respond or to see that someone's welfare might not be going right. You might see a performance drop in their work and ask if someone's okay. Are you okay? Seek support or advice from the various experts, chaplaincies, medical officers, leaders, to do a better job at looking out for your mates. So I think the education and as a byproduct of that education, the knowledge and access to support services is a big risk mitigator to suicidality.
And do you think the way that an ADF member, or in your situation, a RAF member, is treated by the organisation could potentially be a risk or a protective factor depending on that treatment?
I think someone's experience in life, including their experience in the Air Force or in any organisation, is a factor for any aspect of their life, including mental health.
Thank you, Wing Commander. And Tyndall is, and I'll just refer to it as Tyndall if that's okay, is one of the largest remote ADF bases in Australia, is that correct?
That's correct.
And operator, please display DEF quadruple 9 0031 0053. And actually, operator, no need to display that because I've just tendered the footprint. And do you have that in front of you? Wonderful. And Commissioners, do you have a copy of that as well? This is the RAF-based Tyndall unit footprint, which is Annexure A, the corrected version of Annexure A in your statement. Is that correct?
That's correct.
And can you just explain to the Commissioners, just briefly, your chain of command and where the chain of command of 17 meet, if you like?
Sure. As you outlined at the start, there is 17 Squadron, which is the base squadron at Tyndall, and 75 Squadron. 75 Squadron is part of Air Combat Group, and you can see the path through 81 Wing to Air Combat Group and then up to Air Command. And then 17 Squadron, including 2EHS and the security forces elements, work through their respective wings through Combat Support Group, CSG, and then both CSG and ACG meet at Air Command.
Thank you. And operator, if you can now display that same document that I called a moment ago and display page 0063. Hopefully it will come up on your screen in a moment. That is a table of ADF members posted to the base by year. So that's 0063, operator. Do you have that in front of you? Not as yet. Oh, I'll just wait so that you have it, Wing Commander.
I've got it.
And you can see there on the table the numbers in 2022. And I'll just refer to 17 and 75 because they're the biggest there. So 205 for 17 Squadron and 75, 186. And I know on the table, for the next table on the next page of 064, but operator, please just stay on this document at the moment, that we've got more recent data on Q3 of this year, which is 205 for 17 and 191 for 75. In your statement, you say that 17 is the largest, but these numbers indicate they're fairly close. So did you want to just briefly state why you think 17 is the largest, or do you think it's not the largest looking at these numbers?
I think it's largest in terms of its footprint across the base. They are the base squadron and they run all the facilities, and so they are spread to every corner of the base. 75 Squadron is fairly well contained in one section of the base. If you are looking at it from a population point of view, they're fairly relative, with 17 being a little bit larger.
So similar numbers, but in terms of responsibilities, 17 is larger.
Responsibilities on the base and footprint across the base.
Thank you for clarifying that, Wing Commander. And I do notice that Norforce is mentioned on table 4.1. Do you know what the role is of Norforce on Tyndall?
I understand they're a small detachment. They carry out the duties that Norforce are responsible for. I don't have any personal interaction with Norforce. That's the extent of my knowledge.
Thank you. And operator, on that same document, if you can please display 0057. Wing Commander, this is a list of your primary responsibilities, and they extend from oversight of defence contractors to operational preparedness of 75 Squadron, to the maintenance of good order and discipline of 75 Squadron members, to the management of all 75 Squadron members' welfare. With respect to that last point about welfare, do you view that as including physical and mental health wellbeing?
I do.
And that's your responsibility, is that correct?
I'm accountable.
And do you also view it as practical and emotional matters, such as housing, finances, relationships, family? Those, I think you referred to them before, could be stressors. Do you see that as part of the welfare of the aviators at 75?
Where it affects their welfare, then absolutely.
And out of these 8 responsibilities listed at paragraph 15, which one would you say takes most of your time?
It's really hard to pin down any one of those. I bounce across all of them depending on the circumstances at any particular one point in time, and I rely heavily on the team that work for and with me for us collectively to be across all of them.
Are there any there that you would like to be able to spend more time on than others, that you feel a little bit divided? You are one person and there's a lot of responsibilities there.
I would like to spend more time on each and every one of them. That's not the reality I find myself in, but I have absolute faith that the team that work with and around me are actively and successfully working on all of those topics. I rely on their feedback as to where they need me to lean in on any particular area based on the circumstances of the time.
And is it Directive 1/2022 that sets out your responsibilities as commanding officer?
That's correct.
And in the interest of time, I won't ask for it to be displayed, but it states in paragraph 4, I encourage you to support your workforce where policy allows. What do you do in a situation where you would like to be able to, for example, support one of the aviators at 75, but the policy does not allow it, or there is no policy?
It has not been my experience in command to date that I've had a welfare situation where I've wanted to implement something that the policy has not supported in one fashion or another.
And I know this is hypothetical. If that were to occur, what would you do in that situation in terms of either, or I'll just ask you, what would you do?
If there's a welfare situation which is complex, and that sounds like it could be the case in what you're describing, i.e. there's a welfare issue that is clashing with policy, then that is complicated by its nature. And so I would initiate an individual welfare board, which would bring in together the specialists from likely policy in that case, and any other welfare relevant individuals, so that we could collectively discuss the welfare issue, the challenges, the options available for me to decide on an appropriate course of action in that instance.
Would you advocate in some way for policy to be changed or reformed or implemented if there was no policy?
I guess it's dependent on the circumstance. If the welfare of an individual is being negatively affected by the policy, then yes, I would advocate for a policy change if I thought that was a reasonable outcome.
And how would you go about doing that?
I would engage with the policy owner on that matter.
And if there was no policy, would you go up your chain of command to speak to somebody in the authority to do that? Or?
Yeah, I'd likely do both. If I was looking for a change in policy, I'd likely be explaining that to my chain of command for their information. Depending on the matter, I would even seek their counsel on, how to solve this, and then in parallel work with the policy owner on the issue.
And are you accountable for, and I'm going to list 3 things, and if you want me to do them each one, let me know, but are you accountable? I'll do them in each one. Are you accountable for creating a positive and supportive squadron culture?
I am.
And are you accountable for preventing unacceptable behaviour?
I am.
And are you accountable for preventing suicide?
I am.
And how do you demonstrate accountability and leadership in regards to those matters?
It's a multifaceted approach in covering off on those areas. I consider the conduct of my actions across the areas of command, leadership and management. Through command, I'm responsible for the legal administrative frameworks that we operate under, which includes governance functions, things as simple as ensuring mandatory training is conducted, the expectations or indeed the requirements of higher headquarters or policy, ensuring that is delivered to my squadron.
Apologies, I didn't realise you weren't finished.
So that's command. In leadership, then it is my approach to set a squadron culture that is inclusive, that is motivated, that understands its purpose and its meaning deeply, that is collaborative, and importantly that it is inclusive, and that the communications up and down the chain of command and at every level are open, so that we understand each other across any matter, including those that you've described. And then finally across management, then it's important that me and the team create an environment that can carve out the appropriate amount of time to enable individuals to do things that aren't just their core business work. Welfare matters, that they have time to do professional development, that they have time to do physical training if they have a minor or major health crisis themselves or within their family, that we provide them the opportunity to address those so that they are free from those mental loads and they can execute their core duties to the best of their ability.
Thank you. And you say that one of your primary responsibilities is to foster a cooperative relationship with Air Command wings and units, in particular 17 Squadron. Does this mean that you have a close working relationship with Wing Commander Smith, who is the commanding officer of 17?
I do.
And how do you foster that close working relationship?
Through the normal mechanisms. We chat, we pick up the phone, we talk to each other if there's something going on. We meet routinely over a coffee. We meet socially at social events. We discuss what's going on, how they're going, how he's going. He asks me the same. So it's just open and free discussion.
And how would you describe your style of command?
I'm pretty collaborative, pretty passionate. I'm very focused on purpose, and I feel my duty is to digest the myriad of factors that are at play in the world, and to channel the energy of the squadron in the right direction based on my interpretation of those factors.
Thank you, Wing Commander. And given the location of the base, does it assist you, because it's fairly isolated, so everybody's close together? Does that help in terms of getting to know members on the base?
Yeah, I think that is our greatest strength.
And does it assist you in getting to know their concerns?
Yeah, absolutely.
And does it help you in terms of monitoring the mental health of your members?
Yes.
And how do you do that?
Monitor the mental health of 75 personnel through a few different mechanisms. The first is to trust that and empower the leaders at every level within the squadron to monitor the mental health of the individuals around them, to have conversation with individuals if they feel the need or they're concerned, to raise those concerns. So that's a conversation that ripples through the squadron. But it starts with me, and it's important that I know the workforce to the extent that I can, and I look to trust the leaders and managers at every level, but verify personally, or if not through me, then through the executive team and the senior members of the squadron, that we verify members' welfare by just chatting with people as we go about our daily business and checking in on their welfare.
And have you done mental health first aid training of some sort?
I've not done specific mental health first aid training. I have done annual suicide awareness courses and mental health awareness courses that are associated with that.
And were they done online or face-to-face?
A combination of both.
Would you like to do more mental health first aid training if you had the opportunity?
I think it would be arrogant to ever think that you know it all with respect to mental health. There's always more to learn. I do seek to increase my knowledge on that area, and I do take those opportunities when they present.
And I ask that question because I know you also mentioned in your statement the importance of dialogue, and you've spoken then about your style and about conversations. And I was asking that question in terms of trying to understand if you would be able to have the skills to be able to know what questions to ask in those situations if someone was presenting, or to be able to identify it. That was the purpose of that question. Do you think you could do with a little bit more skills in that area?
I think I'm pretty well versed in having the conversations with my members over my experience in the military. I've built up my own personal style on engaging with individuals, checking in with them, understanding how they are going, and I feel pretty comfortable and confident with my ability to do that currently.
And what about some of the junior leaders or the senior non-commissioned officers? Do you think some of them could do with some more training in that respect?
I think it's very much individually specific. Some of the junior leaders have amazing emotional intelligence, experts at a young age at engaging with their peers, and often engaging up the chain of command to identify people that might need some assistance. There are others who have not had that life experience and have only had limited training based on their limited experience in the military. So I think there's always an opportunity to take additional training, but I'm generally satisfied with the training that we're receiving currently.
Thank you, Wing Commander. How crucial is the role of Tyndall chaplains in monitoring wellbeing at Tyndall?
They perform a very important function. They are often the first line of contact for us outside of the unit. If we've got a question or a query, or we want them to help us assess a situation, then they're very important.
And has there, and to your knowledge, and it's okay if you don't know this, but has their role in monitoring wellbeing ever been evaluated at Tyndall?
It's beyond my knowledge, I'm not sure.
Thank you. I'm going to move to a different topic. Or I will just ask you this. In terms of young members who may not have a religious affiliation, do you think they feel comfortable going to the chaplain?
I think that is individual. Some do. Some that do not have a religious affiliation can feel entirely comfortable approaching the chaplains, and the chaplains do, when they speak or they introduce themselves at, say, an introduction day, they're always very clear to the members that they take no bias about religious preference. But I think there will always be people that don't feel comfortable in that manner, and then there are other mechanisms that are available to them. The chaplains are not a one-stop shop in that regard.
And I'll be turning to some of those matters later. I'm going to move to a new topic on unacceptable behaviours and workplace cultures. At paragraph 130 of your statement, you state that you have not issued any specific policy or guidance regarding management of unacceptable behaviour at the unit level at the base. Can you tell the Commissioners why you have decided not to issue any specific policy or guidance?
Yeah, I've not felt the need to add additional policy or guidance. I'm wholly satisfied with the policy and the guidance that I'm provided as a commander. my job, I feel my job, and the team that supports me is to realise that policy and guidance, is to execute it meaningfully at the coalface to achieve the outcomes that are set out by it.
And last week, the Commissioners heard some evidence from Senior Chaplain Knox and Squadron Leader Dews in their statement about the tight-knit community at Tyndall, and I briefly mentioned that. What are your views on how this might impact on reporting of and responding to any complaints of unacceptable behaviour at Tyndall?
In my experience at Tyndall, so I agree that Tyndall is a tight-knit community. I've worked in Tyndall, obviously, and in other locations, and I don't draw a difference between Tyndall and the other locations in the reporting of unacceptable behaviour.
So what do you mean by that?
I don't draw a delineation between the reporting of unacceptable behaviour in Tyndall and the other locations that I've worked in within Air Force. As in, I don't think Tyndall's any different.
In what way? When you're saying different, in what way? Are you saying that people do report or they don't report, or?
I'm saying that.
I'm sorry, the answer was that he didn't see a difference, so the question doesn't follow.
I'll withdraw the question. I'll move on. Thank you, Wing Commander. But I'll go back to the original question. Do you have any views on how having a tight-knit community might impact on reporting of unacceptable behaviour? Or are you saying that everybody's happy to report and there's not an issue?
When it comes to unacceptable behaviour, I am wholly satisfied with the reporting that's occurring at 75 Squadron, that's occurring at Tyndall, and in my experience within Air Force outside of Tyndall.
Thank you, Wing Commander. Operator, please display DEF quadruple 9 0031 0053, page 0086. And in this paragraph, Wing Commander, you state that the current culture at 75 is one where personnel feel relatively comfortable to report unacceptable behaviour. And then you back that up by referring to the Inspector General of the ADF audit report. And I'm going to come to that later. But just for the purposes of this question, the statistics that you refer to in that paragraph are about whether or not the survey respondents believed that coercive action would be taken if an unacceptable behaviour complaint was made, and about the confidence in the chain of command in dealing with the complaints, correct?
I believe corrective action vice coercive action.
Sorry, corrective action.
That's correct.
My error, corrective action. Apologies for that. Whilst those two factors may, or may not, I'm not sure, but may assist members in feeling safe to report, those statistics are not about whether someone feels comfortable or safe enough to report, are they?
No, that I agree.
And have you ever undertaken or considered to even undertake a local anonymous survey within 75 to help you understand the issue about reporting unacceptable behaviours?
The military justice report is just one mechanism that builds my comfort on the reporting behaviours of 75 Squadron members. There are others. The trust in the leaders and managers at every level that reporting is occurring, that there are not instances that are happening that are getting shoved to one side or pushed aside. I trust that the culture is correct, that matters are being reported, if not by the individual, then by the others who become aware of that conduct.
But you would agree, wouldn't you, that you don't know what you don't know, correct?
Correct?
So the Joint Military Police Unit are telling you the reports that are being reported, but they're not telling you who's not reporting, is that correct?
They don't tell me who is not reported, correct?
So in terms of understanding perhaps the culture or the incidence of not reporting, there's no statistics, not in your statement that you provided. What's the mechanism for trying to understand who is not reporting, and not in people in terms of their details, but the occurrence of not reporting? Because we've heard evidence in this commission that not reporting is an issue, and particularly of unacceptable behaviours, and particularly around sexual misconduct and sexual assault. So what mechanism is available to you as a commanding officer to try and understand whether there is an issue about not reporting?
So I agree it's hard to draw statistics on something that you don't know about. And so I take my confidence in the reporting behaviours of 75 Squadron through knowledge of the culture on the unit, and that matters, events, incidents that occur, even of a relatively low nature or a relatively minor incidents, are being raised by either members individually or when they are heard about by others, that is occurring. And so it's a trust in the culture of the leaders and managers at every level, and I see that.
You see it, but how do you know for certain that there isn't a culture of not reporting?
I guess I have not, in my experience to date, I've not come across an incident that that has not, I guess. So there's an expectation that in the event an incident occurs, that is reported in a timely manner. If individuals were trying to hide the incident or tried to hide the unacceptable behaviour, then it's possible that over time it does raise its head and you find out about it 2 weeks after, 4 weeks after, 6 weeks after the event. That would be an indicator to me that people are not reporting when these things occur. My experience is that these events are brought to our attention, or these behaviours, the reporting is occurring in or around an event, and I've not experienced any incident where the reporting has lagged the incident. And so that is a litmus test for me for the culture. I acknowledge that it is plausible that an incident has occurred that has not come to my level.
Because you just wouldn't know about it.
I just wouldn't know about it, but I'm comfortable that the culture exists, that is minimal, if not non-existent.
One way of knowing would be to survey the aviators within 75 and ask them in an anonymous way about reporting and how comfortable they feel about reporting, wouldn't it?
Surveys, yes, and I'm comfortable that the surveys are occurring through multiple survey mechanisms. I don't feel like there would be any additional benefit for me conducting a personal survey.
Thank you. I'll leave it there. In your statement, you referred to sexual assaults occurring at Tyndall, and please, without going into details about that and not even mentioning how many sexual assaults are there, my question is simply this: does it concern you that there are sexual assault complaints being made? Sorry, and I should have said complaints being made at the base?
Absolutely.
And what do you do about preventing or reducing or eliminating sexual assault within 75 or on the base generally through your discussions with Wing Commander Smith?
I think that there are multiple things that are occurring to prevent sexual assault occurrence. Education, we've talked about that already. Talking to the workforce about what is not okay within Air Force, within Defence. So education's important. Another important mechanism is when allegations are raised, that they are dealt with appropriately in a timely manner, and that the conclusions are transparent and communicated, so that anyone who raises an allegation is confident that it will be investigated thoroughly and appropriately.
And in the event, given that it is a small location and everybody probably knows everybody, it's about 500, isn't it? About 500 on
It's
the...
about 500 members and
Yes.
about another 700 dependents in the community.
Yes, that's right. And you have contractors as
Correct.
well. So it's still fairly small over a period of time. Most people will get to know each other. In the event where there is a complaint around a sexual assault, have you got something in place to be able to kind of either remove the alleged perpetrator or remove the complainant if the complainant asks to be removed?
Yeah, absolutely, those options exist.
And you also refer to bullying and harassment, and again, without going into details, does that concern you as the commanding officer that those complaints are being made?
Absolutely.
And from your experience to date, it's December 2021, is that right, that you commenced there? Are there any particular risk factors at 75 that may result in bullying or harassment, or are you giving some thought to why this is happening and what you can do about it?
I've not come up with any significant risk factors that are specific to 75 Squadron or to Tyndall.
Do you give this thought about bullying and harassment and sexual assaults and what you can do about it?
Yeah, I absolutely consider every allegation and the circumstances behind that, not just the event itself, not just the consequence for it, but the cause. So that's on a specific case-by-case basis. I also consider and discuss with both internally, my executive team, and externally with the leadership of 17 Squadron, the results of or looking for trend lines, either on the unit or at the base, trend lines that are identified either through some of the surveys and the findings associated with those surveys, or maybe even just through discussion, just through informal discussion, that there's been an increase in a particular type of behaviour, what's going on. So yes, that is something that we consider.
Are there any aspects regarding culture at 75 that you would say require some improvement?
Cultural aspects?
Yeah, or just the culture, or is there anything that you would say, look, we're doing really well here, 80, 90%, we've got a great culture, people are happy to report. But in terms of that maybe 20 to 10 or 10 to 20%, are there anything particular about 75 that you think, as in your role as commanding, I want to fix this, or I want this to improve for the aviators at 75?
I'm wholly satisfied with the culture of 75, but it would be arrogant of me to think that there was not room for improvement. And I think that's true of 75 as it is for Air Force, as it is for Australian society. I take the approach that Tyndall, a posting to 75, which is a posting to Tyndall, is an opportunity to integrate into an area of Australia that most people don't get the opportunity to, just through geography. So I'm actively encouraging members, and in particular through the Indigenous Liaison Officer Network and through some government connections, trying to get 75 Squadron personnel out to some of the remote communities within the Northern Territory to get them to see and understand the traditional owner networks. So that's an area of active community engagement, not just the remote communities, but the Katherine community as well. I feel that the relative size of Tyndall to the Katherine community provides both opportunity, and we have a responsibility to be good citizens in the community, and we have enough size to make a meaningful difference to Katherine. And so some members will rightfully raise concerns around the remoteness of Katherine, the services that are available. But I think that we can make a meaningful contribution to improve the lifestyle and well-being of the community, including the civil community in Katherine. So there's specific areas that we've been working on.
Thank you, Wing Commander. I'm going to show you, I'll show you a document. Associate. This document, Wing Commander, is subject to a confidentiality claim, and I tendered it as a wholly confidential document. And Associate, I have copies for the commissioners. Thank you. For the record, it's DEF.1097.0003.0018, and it will not be displayed. This is the snapshot survey, and it's a snapshot survey for 75 Squadron. Is that correct?
That's correct.
And you heard me characterise the survey earlier. It's to assist leaders like yourself to understand the issues of health and safety and well-being in the workplace.
Yeah, it's specifically designed for commanders.
For commanders, thank you for clarifying that. I'm only going to take you to a couple of, if I can call them workplace issues or workplace topics, and if you could turn to page 2, which is on the left, the page number's on the left bottom corner there. The item there, which is the question, and it's not the full question, but it's just paraphrased or at least part of it. We do not have the equipment that we need to do our job. And the overall percentage was 72% felt they didn't, and I'll just say that 144 completed the survey, which is quite a significant amount, isn't it, Wing Commander?
Yeah, that's about 3/4 of our squadron.
Yes, so doing well there to get them to complete the survey. And 72% feel that they do not have enough equipment to do their job properly. Does that concern you?
Not specifically. The snapshot survey by its name is a snapshot in time. And so it does not give you the, well, let me put it this way, it's context specific. So what is occurring in the workplace at that particular time is directly reflected in the survey results. And so when considering the results and their implications, you must consider the data and the context around the squadron at that particular time. When this survey was taken, in fact, more broadly, can I say that this year, in 2022, we've introduced a new platform, it being the F-35, into service at 75 Squadron. And so we have a 12-month period where we are transitioning from one aircraft to another aircraft. As a result of that, we are still receiving equipment through the system to support that stand-up. So organisationally, the expectations on 75 Squadron being a complete, ready, operational fighter squadron is true for December 22, but not for January 22. And so through that transition, we continue to build our supplies and equipment and facilities. And so it's not surprising to me at all that some members are dissatisfied that at this particular time they don't have all the equipment they need. That is indeed expected.
Thank you but considering the context, so at that moment in time you have aviators expressing that they don't feel like they have enough equipment to do their job properly.
Mm-hmm.
So I appreciate the context and thank you for clarifying that. But it's a significantly higher number than the average for RAF, which is 49%. And would you agree that if someone feels like they don't have the right equipment to do their job properly, that could have an impact on their job satisfaction, or they're concerned about things like safety or whatever it might be?
I don't draw the I do not draw the line between equipment shortfalls and job satisfaction with safety. I do draw the line between equipment shortfalls and job satisfaction. Absolutely. The men and women of 75 are passionate individuals. They want to carry out their job to the best of their ability, and they need the equipment to do that. But it was an expectation and one that we absolutely discussed with our workforce, that we were going to have to spend a significant portion of this year training non-qualified F-35 people up to be qualified and working with what we had while the equipment came in. So that the statistic does not concern me in that regard, and I have not experienced any incidents of equipment shortfalls leading to safety outcomes.
And in terms of spending more time on paperwork than our real jobs, 77% have said that's the case, and the average there is 60%, and it's a little bit up from the last year of when the snapshot was done, and I'm not sure whether that's done at the same time of the year, but it just says 2021. Is that your experience, that people do feel like they're doing more paperwork than their real jobs?
Yeah, absolutely.
Does that concern you, or is that just part and parcel of being a RAF member?
I think that is normal. It's my own experience. What we would like to be doing is doing our core duties, walking the floor, talking to people, and I think all of us in some fashion or another have a gravitational pull to the documentation associated with defence business. And so, yeah, that is a dissatisfaction for people, and I think that's fairly common. That specific result does not concern me.
Thank you. And the last one that I'll take you to is covering for underperforming colleagues. 59% said that they feel like they have to cover for underperforming colleagues. The average there for the snapshot for RAF is 45, and at 75 it's 59. Is that any cause of concern for you?
Again, I think it's important to draw the outcomes in the context of a workforce that was partially trained at that moment in time. So we absolutely had members of 75 that were pulling not only their own weight, but the weight of more than them, pulling their output was higher than it would normally be in any other period of time, as we were training up others to do that. And so it is not surprising to me that some of them were dissatisfied that that the entire workforce was not pulling the same weight.
And have there been any staffing issues in terms of, I know I asked the question earlier about recruitment, have you been facing any of that? Could you do with some more people there at Tyndall, or do you feel like that's not an issue?
Workforce strain is a problem for us. That's not a 75 squadron issue specifically. That workforce strain across the maintenance workforce, the pilot workforce, is being felt in 81 Wing across F-35, and based on the conversations I've had with various sectors of Air Force, I see that strain across the entirety of Air Force. 75 Squadron specifically, I would suggest that we're doing pretty well relative to some of the other squadrons. We have been, the organisation, the Directorate of Personnel, the leadership that are deciding who and how many to send at Tyndall, understand the remoteness of Tyndall and the implications of getting it wrong. And so I've actually been very satisfied with the workforce numbers and quality of individuals that have been posted to 75. Notwithstanding, we do feel that broader workforce pressure on capability output versus a resource.
Has that got the potential to increase pressure for aviators?
Yes.
Operator, please display DEF.1097.0003.0029. This is another snapshot report. I believe it's sort of more like a high level, if I can call it that. And please go to 0032. In terms of unacceptable behaviours, you can see there that Tyndall, in a moment of time, is actually doing well compared to the last year's results. So last year's results was 6% in terms of experiencing unacceptable behaviour. It's now 2%, as you say, it's a point in time. But that's quite a significant improvement. The Royal Commission's interested to know what's working well as well. And I know you've touched on some of this, but is there anything you'd just like to say as to why you think that it has improved in terms of that less people are experiencing bullying or harassment or sexual misconduct or sexual assaults?
I have no knowledge as to why the improvement. The only thing I would add is that the turnover of personnel between 2021 to 2022 was pretty significant, larger than normal because of that platform change. At 75 Squadron, we would normally, in a typical end-of-year posting cycle, turn over about 1/3 of our workforce, one quarter to 1/3, and between 2021 and 2022, we turned over about 50% of our personnel.
The one next to it, reporting and management, is not as great in terms of improvement. In fact, last year, 12% felt that reports were managed adequately, but only 6% were managed adequately. And we are going to go to the IGADF reports at some point, Wing Commander, but...
So I'm not entirely sure that's how that
it's the
should be
opposite.
read.
Oh, it's the opposite. That's right. Sorry, my apologies. I've read that the other way. So obviously you're doing a good job, so I'll just withdraw that for the record. You're doing a better job on people feeling that it's being adequately addressed. And we'll go to the IGADF report later, and hopefully time permitting, I'll ask you why you think that has improved, because the Commission's interested in that. But underneath there, in terms of the impact on family, 18%. Would you like to just say anything, just briefly, about some of the impacts on family from getting a posting at Tyndall, from your experience for aviators in 75?
I'd describe a Tyndall experience as amplifying the impacts on your life. So if work is going well, if life is going well, then in Tyndall it's amplified and it's going really well. If life is not going so well for you, at home, for example, if you've got health issues in the house, or you have health issues personally, or maybe there's an extended family challenge with family members located on the East Coast where it requires travel, then the impacts of that are amplified. And so that is harder. It's harder in Tyndall if things aren't going well.
And 10% said that it's difficult to ask other colleagues for help. The snapshot average was 16, so that's better than the average, but it's still 10%. And you've referred to that before, Wing Commander, about help seeking. Is help seeking an important issue in terms of factors to try and prevent suicide from occurring, or suicidality from occurring?
Yeah, it's critical.
Why do you say that?
Whilst I acknowledge the complexity of suicidal behaviours, I understand that one of the most important circuit breakers, if you like, to stopping a suicidal ideation turning into a suicide attempt is through asking for help in whatever form is available and the individual is comfortable in taking.
Thank you. And just next to it, this is the last question on this document, management of workplace hazards. You can see there's been a slight increase in fatigue, or people reporting that they're experiencing fatigue. Does that concern you?
Fatigue and fatigue management is a constant stressor in our workplace. It's something that we keep an eye on. It's not consistent across the squadron at any particular one point in time. Depending on the context, different people are working harder and are getting more tired at any one particular point in time. I accept that as reality. My focus is to ensure that those who are getting fatigued are doing it, are discussing that, are talking about that is known and accepted by the leaders and managers that they work for, but most importantly that they get the respite to return to a normal, healthy state in the right period of time, and that if the fatigue for any reason is becoming too much in their life, either at a particular moment in time or as built up fatigue, that they raise their hand so that we can manage that.
And what are some of the practical supports that might be in place if someone's fatigued? Do they get put on leave? Do they get offered leave? How do you deal with fatigue?
I guess fatigue is a spectrum. Some people just need to go home and take a day or two, and that's something that's employed regularly. Chronic fatigue at the other end of the spectrum is a whole nother matter. And so in between, I encourage leaders and managers to do what they need to listen to the individuals who are fatigued, to hear what they need, and to respond appropriately to that. Stepping back a little bit from the case by case, what I feel one of my leadership strategies in this regard is to ensure that no single individual is critical in themselves to the output of our capability. And so what I mean by that is that no one feels like they can't raise their hand because the business will stop as a result if they do. And so if we can make each and every one of us, and I include myself in this regard, redundant to an extent, or at least for a period of time, then that enables us the comfort to raise our hand and say that we're too tired with that knowledge.
Thank you. With respect to training, you mention you give evidence at paragraph 60 in your statement about certain courses, mental health courses, suicide awareness courses, all around the 3-hour mark in terms of those courses. Do you know, and they're delivered by ADF Centre for Mental Health in Northern Territory, is that correct?
Yes.
And they're based at Robertson Barracks, is that right?
That's correct.
How often in a year do the staff from the centre travel to Tyndall? Do they travel to Tyndall?
They do travel to Tyndall.
How often do they do that in a year?
I don't have that information off the top of my head.
You can take that on notice if you like, Wing Commander. Would you like to take that on notice?
Sure.
And in terms of and again, if you don't know this, please say so and you can take it on notice, is a member's participation and the knowledge that they gain from those courses evaluated?
I'm not sure. I would have to take that on notice.
Thank you. And you say that Tyndall is a frontline fighter base. It's not a place for initial employment training. So does that mean that some of the aviators who come to 75 are coming straight out of initial employment training to Tyndall?
Yes. And
do you receive any information or have any conversations with those aviators about their experiences in recruit school and IET, initial employment training?
I don't specifically, no.
Do any of your junior leaders have those conversations or receive information about, for example, someone who may have made a complaint about how they were treated in recruit school or during their initial employment training? Does that information get transferred over to you as a unit leader or somebody else in your unit so that they can know what this person's been through when they come to you?
My understanding is that matters which are resolved prior to transfer to the unit would not get, those matters would not get transferred formally. Unresolved matters, and that we have had cases where matters are unresolved and that is effectively a handoff to the gaining unit to resolve the matter. Outside of that, I expect and I know that the leaders and managers at all levels at 75 have a conversation one-on-one as part of their welcome to the workplace. How are you doing? How are you set up in Tyndall? What are your circumstances? what are the factors, for your success and well-being on the squadron. That's an informal mechanism, I acknowledge, and that would rely on the member coming in, disclosing any of those stressors from a previous unit.
You may not know this because it might happen behind closed doors between those two people, but do you know whether in those conversations someone would feel, okay, the junior leader, whoever's having that conversation, to say, did you have any negative experiences at the recruitment school? Do you think it'd go that deep, or do you think it would just be about welcome, how you doing? This is, if you need anything, talk to us. Do you think that someone would ever expressly say, did you experience any bullying, harassment, or were you sexually assaulted during your recruitment training?
I'm not sure. I leave that up to individuals to design their own conversation. That's a very specific question, and I doubt that would be raised as such. I think the conversation would be more around, how are you? How was your experience? What's your state of mind? Which would open the invitation for that conversation, but would not specifically interrogate that.
Thank you, Wing Commander. Would it be helpful if one of the aviators at 75 who's just coming over and had a negative experience from recruitment, would it be helpful to know that information in terms of having, if the aviator consented to the initial employment training school or the recruit school to say, yep, I'm happy for that information to be transferred over, would it be helpful in terms of understanding where they're at when they come to you?
Potentially, yes.
Thank you. I'm going to move to a new topic on injury prevention. Just excuse me for one moment. Thank you. In your experience as a RAF officer, as well as your experience in as a commanding officer, do you accept that there's a relationship between physical injuries and mental health issues, so that the physical injury can impact on someone's mental health?
Yes, I do.
And does the data that you have to hand on the incidence of physical injuries accurately, do you think, and do you have a view on this? I'm asking you whether it is and whether you've got a view on it. Does it accurately reflect what is the reality on the ground or in the air, as it may be the case?
Data that draws a correlation between physical and mental health?
No, data on the incidence of physical injuries. So the data says we have 5 aviators, they've got these kind of injuries. Do you think that data accurately reflects the actual reality? So, for example, there could be 20 people with physical injuries, but your data only says 10 or 5.
Can I just clarify, is my learned friend referring to 75 per se, or the Air Force more generally? It's just not clear to me.
75.
Thank you.
Can I ask the data that you're referring to?
Well, let me start this way then, perhaps, Wing Commander. Do you have data on the incidence of physical injuries at 75?
I do not.
Why do you not have that data?
I haven't asked for that data from the medical professionals, and it's not something that I've seen come across my desk passively.
Do you think that data would be helpful in terms of the management of the welfare of aviators at 75?
I don't feel I need that personally, unless there was significant trend lines that were occurring across the squadron. As an individual in any section of the squadron is injured, I'd expect their manager to, well, if that injury is going to affect their work performance or role or their duties in any regard, then the manager would know about that. The manager would implement whatever measures that they thought were appropriate to both give the member the time and space to deal with that injury, to turn up back to work fighting fit, or employ them in other duties while they work through that. If there was enough members in one particular area where that capability, that sections output, that trade, as an example, was subject to risk because of numerous members being unavailable, then that would start to elevate that conversation within the squadron. But tracking individual injuries across the squadron is not something I feel I need to do.
When you say manager, and excuse my ignorance for the chain of command, so can you just explain what you mean by, so say it's an aviator, they've got a physical injury, so who within your unit would know that?
So when I say manager, I mean one up, who you're reporting to. I probably interchangeably use leaders and managers. You have a leadership function and a management function as a one-up, but your boss, on the squadron, I would expect them to know about that injury. If an injury was, I guess, depending on the severity of the injury, then it might be known at higher levels, including myself.
You refer to the Fighter Fit program conducted at 75, and without disclosing operationally sensitive information, can you tell the commissioners what this program aims to do?
Yeah, absolutely. Fighter Fit is not specific to 75 Squadron. Fighter Fit is a program that was designed back in 2016 to specifically focused on fast jet aircrew, and it moves the effort and focus on medical treatment to, well, let me start with the risk. So the risk to fighter aircrew is that due to the environment in the cockpit, high G-forces, there's a risk to musculoskeletal injury. And that risk was determined to be high across the lifetime of a fighter aircrew member. And so to put in a prevention measure, the Fighter Fit program was put into being. It focuses on both strength and conditioning and physiotherapy as a preventative treatment and a immediate reactive treatment for low-level ailments, and 75 Squadron conducts that.
And how long has the Fighter Fit program been running at 75?
At 75 specifically, I don't know, at least this year and last year. When it was introduced exactly, I'm not sure. And
do you know how many RAF bases across the country have implemented this program?
Fighter Fit for the fighter squadrons is across the 3 fighter bases, Tyndall, Williamtown and Amberley.
And do you know why the program was commenced? I know you said what the aim is, but do you know why the program was commenced? Was there high rates of physical injuries, the neck and back injury?
Yes, high rates, and as Air Force conducted, or Air Combat Group conducted a risk assessment in 2016 as to the likelihood and consequence, then that risk assessment resulted in high, and so Fighter Fit was the program that was developed to treat that risk.
And you say you give evidence in your statement that there are no specific Fighter Fit injury statistics for 75. Is that correct?
I have not seen statistics that are specific to 75, that's correct.
Operator, please display DEF.1073.0001.0942. Wing Commander, I've asked the operator to display the Physical Conditioning and Injury Management Program Fighter Fit instruction. Are you familiar with this document?
I am.
And operator, please display 0946. And Wing Commander, take a moment to read that paragraph.
Which number, sorry?
39.
Yeah.
For the record, it says that the fighter fit team will track the ACG, the Air Combat Group Plan's 6-monthly program and email squadron participation statistics to unit COs, that's commanding officers, 8 weeks prior to high MSKI, musculoskeletal injury, risk flying activities. Do you receive those statistics?
I do not.
Why not?
I think that paragraph was written based on an assumption that the squadron plans, the squadron programs, were fairly static and included very well known high risk periods. Very predictable high-risk periods. That has not been the reality for 75 Squadron, at least this year, whereby partly due to the nature of the change of platform to F-35 and the other variables that are influencing our programs, that it is far less predictable when our high-risk MSKI periods are occurring.
Would you like to see the statistics of the program in terms of, I understand that the participants are surveyed every 6 months or so. Would you, as the commanding officer, like to see those statistics?
They would be of interest to me, but for context, I have 10 pilots on the squadron. I know each of them very well. I have a good sense for their current condition. And so that data, whilst interesting, I don't believe would meaningfully change my understanding of our current situation.
And operator, or if I could just ask off that, if you were in charge of a bigger squadron, would you find those statistics helpful?
Potentially.
And operator, please display 0942 of that document. And paragraph 3 there, Wing Commander says that reference B, and you can see reference B at the top of that document, which is a safety risk assessments for neck and back injury in 2017, that there'd been a total of 117 Sentinel reports for neck and back injury from 2017 to early 2017, though air crew injury occurrences are historically noted as being chronically underreported. Is that your experience as a RAF officer generally?
It is.
And how do you understand that underreporting? Why do you think that underreporting happens?
I think there's a mistrust between fighter aircrew and the medical system, which I can expand on if you like.
Please.
Fighter pilots, fighter aircrew are very passionate individuals about their job. They live, breathe, sleep fighter operations. That's what they do. And when they have some injury or some ailment, they're also very good at self-awareness on their ability to fly or not. Historically, through the bigger medical system, the broad medical system, with some notable exceptions, I think the experience has been a risk-adverse or a conservative approach to treating those injuries, and the experience for a lot of aircrew is being downgraded and being told that they cannot fly. And so as a result of that, the aircrew will not want to present to medical because they'll get told they can't fly when they know that they can fly, or they self-assess that they can fly.
But isn't it the reality that that is potentially the consequence of reporting the injury, that they will be downgraded and they won't be able to fly?
That's their concern, yeah, absolutely.
But the question was, is it not the reality?
That they will be downgraded,
I mean,
or that they should be downgraded.
or that they could be downgraded?
That is the reality.
So it's not a misperception or a trust issue. It's, in fact, the reality is that if you report it, then it possibly could mean that you could be downgraded.
It's the reason they don't present is a trust issue. The fighter aircrew know the environment. They know whether they are capable of flying the aeroplane or not, more or less. And if they're seeing a medical officer who doesn't know that environment, who doesn't understand, then there's the potential and I think what has been the experience through the broad medical system, there are notable exceptions, that they'll take a risk-adverse approach and downgrade the aircrew. So it's trust in the aircrew's mind that prevents them from reporting.
And is there anything that you can or have been doing to try and build a bridge in that situation so that pilots feel that they can seek help for their injury, but at the same time overcome that fear that they may, lose their job, or they may not be able to fly, or there might be stigma, or there might be judgment, whatever the negative consequence is? Is there anything you can do or have been doing to try and alleviate that?
Yeah, absolutely. So there are medical officers that are specifically aviation trained, they're aviation medical officers or AVMOs. They receive that training, which is an important step into knowing and understanding the environment. Then in some cases, they will maintain or gain and maintain close connections with a particular squadron doctor, if you like, where they learn to understand more intimately what's occurring in that workforce. They build a relationship, they build trust, they work out where the line is, if you like, for what is fit to fly and what is not. And then those relationships build over time. And so in my career, there has always been particular medical officers within the health system that aircrews seek out specifically by name because they know and trust that individual will take an appropriate approach to getting them the medical treatment they need.
And at Tyndall, where are those medical officers based?
They are at Tyndall. So Tyndall is well placed in this regard because it's a close-knit community, and the AVMOs, the aviation medical officers, have a close relationship with the aircrew. Then the trust is pretty good at Tyndall. In fact, Tyndall is probably the exemplar in that regard, and those issues that we've been discussing are more characteristic of the larger bases.
How many medical officers do you have there at Tyndall?
We have 2 aviation medical officers.
And are they full-time or part-time?
They are full-time.
Thank you, Wing Commander. And in that same paragraph, it says more concerning is the potential for aircraft to self-medicate by seeking professional support through the medical system. So self-medicating, is that been an issue that you've observed for pilots?
Can I just clarify something? In my friend cross-examining on this document, I think needs to take into account that the introduction refers to statistics drawn from a point in time in the past as opposed to what's happening now. And the questions are being framed in the present.
Yes, Ms. Bridget.
Apologies, Commissioner. I was speaking with my friend. I didn't hear the objection. Apologies if...
His objection is that the document which you have put up has historical evidence where you're examining, the argument is, on the basis of current figures. That's it, isn't it, Mr. Fordham?
Yes, it is, because when one reads the document, what you draw from it is that it was what was happening historically that in fact led to the introduction of the Fighter Fit program. That is not to say certain things may or may not be occurring now, but it's not correct to cross-examine on the statistics here as if they are current.
Commissioner, I'll withdraw it and I'll just rephrase it.
Okay, thank you.
Wing Commander, from your experience as an officer and just generally, have you observed that pilots do self-medicate as opposed to seek professional help?
And if that question's going to be asked, that also has to be time-specific.
I press that, Commissioners. I'm not sure why it needs to be time-specific. I'm simply asking the Wing Commander, from his experience as an officer, has he observed that pilots may self-medicate as opposed to seek professional help for their injuries?
I think the question is legitimate, Mr. Fordham. If you wish to, you can re-examine and limit it or see if it is limited to particular periods.
I fully accept what you say, Commissioner. The difficulty I have is this, is that with the examination to date, we have mixed past and present, and in that question framed in that form, it's one to say, have you observed? But,
yes, but
the question has within it two sections of phrasing that means, are you still observing, if I can put it that way?
Not necessarily. I mean, typically one might ask that as an open question and then, depending on the result, seek to pinpoint it to particular periods or not.
I accept Your Honour's ruling.
Thank you.
Wing Commander, do you need me to ask the question again? Thank you.
No, in my experience, I have become aware of aircrew that have, in certain instances, specifically when they've not had the trusted medical officer support available to them that we've described, that they have self-medicated. In my tenure in command, I have not observed that behaviour.
Is it possible, just a possibility, that it could be quite hidden?
We're a pretty small group. It's possible, but unlikely.
Thank you. And in that same paragraph, you can see the initials TMUFF, and they stand for temporarily medically unfit for flying. Can you tell the Commissioners what that is and what your experience has been around that?
That means to be grounded, but to be grounded temporarily. So it's not a removal of your category. It's just not a suspension as such, but that you are unfit to fly medically for a short period of time.
And it's saying there it's to manage injuries. So why do you think, I'm trying to understand, why is that a concern? Why is it an issue in this instruction? Can you shed any light on that?
Yes. The issue is that an aircrew member who might have a minor injury, let's just say, for example, from one of these high manoeuvring events, some sort of muscle strain in the neck, that they would seek a small level of physiotherapy help in quick time to treat that, to help them prevent a longer term problem, but they are still fit to fly. The concern is that they would present to medical, the medical officer would downgrade them for a week or 2 weeks, seek out the physiotherapy assistance, which can be slow in the big system, all for something that was manageable in the short term.
Thank you, Wing Commander. Commissioners, I note the time.
We're due to have a short break. We'll take one now. And we also need to break for 2 hours for the transcribing. So we'll just have a very short break, back shortly.
All rise. The Royal Commission is adjourned. The Royal Commission into Defence and Veterans Suicide is resumed. Please be seated.
Ms Bridget? No.
Thank you, Commissioners. Wing Commander, just before the adjournment, I asked you a question about the temporarily medically unfit to fight, is it?
Unfit to fly.
To fly, thank you. And you said that the issue is that an aircrew member who might have a minor injury, and then you went on to say why they're concerning in terms of that, you know, the injury is just temporarily dealt with. And you know, there might be a longer term injury, like it might, you know, that the temporary fix doesn't fix it completely, and then they're back flying and there's still a problem with the injury. Is it the case that it's also if there's a major injury that aircrew might be using the temporary medically unfit to fly for those purposes too?
So TMUF, that instrument, that's a medical instrument whereby without removing your category, which is a much more serious and longer term consideration, that for a brief period of time that you are not permitted to undertake flying duties. So it's a medical mechanism. So aircrew don't necessarily seek TMUF. They can make a TMUF assessment for themselves in some circumstances, like a little cold, but mostly it's a medical instrument.
Yeah. So in that assessment, they might have a major injury, but they're just using that so that it doesn't take them down the other path.
Yeah, again, they don't necessarily use that. If they have a major injury, then I would expect they would present to medical. Medical would determine the treatment path ahead for them, and as part of that, they would be TMUF'd, if you like, and they would be unable to undertake flying duties until that restriction was removed.
I see. So it could be used for both. Is that right?
It can be used for minor and major injuries.
Thank you.
Correct.
And operator, please display DEF, the last document that you were displaying, 1073 0001 0884, and please display page 0942, apologies, 44, paragraph 20. Wing Commander, while the operator is displaying that, it's a question about the sentence in that paragraph which says, and it's about reporting of injuries, knowing that this document says that it's chronically underreported, that physical injuries are chronically underreported. And it says there that while reference A, and that's the study that was done in 2016, is circa 2016, there is still no discernible improvement in sentinel reporting. Do you have any comments on that?
I do not have any comments with respect to that. That's not something that I've considered with respect to Sentinel. What I can say and what I do know is that reporting generally, so reporting through the providers of the Fighter Fit program is not just much better, it is completely satisfactory. So the Fighter Fit program puts the specialists in the squadron, and so minor ailments, if you like, pre or post flight are reported immediately to the specialists who undertake the care immediately, and then those specialists onwards report through to the health command system.
And it's almost a question, as I posed before, about that you don't know what you don't know. So how are you tracking the non-reporting of injuries, or are you not attempting to kind of track that?
I'm not attempting to track that because I'm wholly satisfied that the Fighter Fit program is providing the conditions and the environment for aircrew to seek the treatment that they need, and that there would be no reason that I can think of that they would not utilise that mechanism.
And you're satisfied in what way, given you don't get any statistics about the program?
I'm satisfied because it's a very small group. I know their performance standards. I know that if they were carrying injuries, they would not perform where I would expect them to. And because of the nature of musculoskeletal injuries, it would become very apparent very quickly that they were carrying something that they didn't report.
Do you accept that if they were self-medicating, which would include pain relief, that you may not see that?
Yes, as for self-medication, then that is something that they could seek and I would not be aware of it.
Thank you. And the instruction talks about having access to Fighter Fit physiotherapists. How many physiotherapists are at Tyndall Health Centre?
There's a delineation between, so at Tyndall Health Centre, I am tracking that there is one, but they are not a Fighter Fit physiotherapist. That's a separate person.
I see. And so where are the Fighter Fit physiotherapists based?
In the squadron.
In the squadron itself. And how many of those do you have?
There is one. Currently, we're in between providers. So right now, today, there is 0. We're having some fly in and out to help in that regard. We've just had one person leave and we're just about to get a new person. Normally, there is one.
You're in transition.
Correct.
Thank you. And I know you've said that you don't get statistics about injuries, but how do you plan or prepare or put in place something for injury prevention if you don't have those statistics, or do you not? You don't see that as your role around injury prevention?
I have a
Can
role.
my friend break that up? There's actually two quite separate
I'm happy to
questions.
do that, Commissioners. So we've heard that, and it's your evidence that you don't receive statistics on injuries for 75, is that correct?
That's correct.
Do you see it as your role to oversee, as part of welfare, if you like, injury management and injury prevention for aviators at 75?
Correct.
So what do you do in that regard, and I'll just ask you that, what do you do in that regard?
To prevent injuries at 75 Squadron?
Yes.
Command, leadership and management are the broad categories. I like to foster a culture of raising your hand, whether it's injury related, physical or mental, whether it's some other stressor in your life, family or personal or extended family, that the lines of communication are established within the squadron so that people feel comfortable in doing that. When that happens in an injury sense, that the leaders and managers provide individuals the opportunity to go and deal with that so that they're not under any undue pressure to perform their duties whilst carrying even a minor injury. In Tyndall, this is exacerbated because it can take some time to seek the services that you need to treat those injuries and may indeed require some significant travel. And so any time that we on the unit would prevent someone from seeking those services is going to amplify the problem for them. So we're always looking to provide people the time and space to be able to seek those treatments and to foster a culture to have people raise their hands to say that they need to do so.
Do you agree that education about injury prevention is an important strategy for injury prevention? Education about injuries and how to prevent it is important as part of a prevention strategy.
Yes.
And do you agree that knowing the kind of injuries that are happening at 75 would help you to put together bespoke or specific training about particular injuries as part of an injury prevention strategy?
Yes.
So would those statistics around physical injuries not assist you in the management of the welfare of aviators so that you can know what injury prevention training you should be offering there at Tyndall?
There is the potential, but I am satisfied that between the Fighter Fit program, which focuses on the aircrew specifics, and the broader physical training instructor interaction with the 75 squadron members through strength and conditioning exercises, they come down to our workplace, they assess what people are doing physically so that they understand our environment, that those conversations are happening, and that the training, physical training, is being adapted for that purpose. Statistics might help, but I'm confident that that line of effort is already in place.
Do you personally go and speak to aviators and ask them about, or have a discussion yourself about injury prevention, or do you leave that to the chain of command?
I think both of those things occur. I will typically speak to someone about their physical injury where it has around an individual welfare board or some sort of more significant stress that's putting on them. If that's come to my attention, then I seek to have that conversation with someone. But more broadly, I rely on the leaders and managers within 75 to do that.
And I think you say in your statement that you do heavily rely on chain of command. Is that right?
Mm-hmm. That's correct.
And you're confident, are you, at the moment, that you can rely on the chain of command?
Yes, I do. I also rely on external resources. The Fighter Fit is one example. The PTIs, the physical training instructors, are another example. Medical officers are another example. And I'm confident that at 75 and more broadly at Tyndall, that if there were trend lines that were occurring around injuries, that we would be having those conversations. The only trend line that I am aware of is in the aircrew, is in the pilot space around MSKI, and I'm wholly satisfied that the treatment that we have in place for that.
And the musculoskeletal injuries are a result of G-force when flying those planes, is that right?
Correct.
And in terms of rehabilitation, at paragraph 83 of your statement, you refer to some of the challenges there, or a couple of the challenges with rehabilitation, remoteness, access to services. Are there any other challenges for rehabilitation for the aviators at 75?
The two that you covered was remoteness and...
It's remoteness, and you state improvement in service delivery, noting the inherent geographical challenges associated with achieving that. I think they're sort of related.
Yeah.
Remoteness and that would be very welcome, is what you say in your words. Is that a call to action for you in terms that you feel like you do need better, or that the service delivery needs to be improved in terms of rehabilitation?
So they are the challenges as I can best identify them. Remoteness and access to service. And you're correct that they are inherently, they are tied. the ADF provides a level of service delivery in Tyndall. We rely on service delivery beyond that in Katherine and in Darwin, and quite often that does require service provision from Darwin, and that is a challenge.
And so you would welcome more services on the ground with rehabilitation for aviators?
In particular areas, yes, I would.
And what areas would they be?
I'm generally satisfied with the service delivery, but in the areas of medical officer, in the area of physio, in the area of mental health support, specifically psychologist access, if those services were available at Tyndall, I believe that would make a meaningful difference to our aviators.
Thank you, Wing Commander. In terms of stigma with rehabilitation, your observations on that, is there some stigma for aviators in engaging in rehabilitation for injuries?
Generally, I'm impressed by the willingness of aviators to seek mental health support. I think there is, in some individuals, a stigma. And sorry, the question wasn't just mental health related, it was rehabilitation.
But you can answer both if you like, right. Wing Commander. So in terms of rehabilitation for physical injuries, do you think there is some stigma around that? And then please feel free to also ask about mental health.
Sure. I think the answer is the same across both of them. Generally, I'm satisfied that people are willing to raise their hand, seek support and seek the rehabilitation that they need, generally. But I accept and observe that there is, to an extent, a reluctance to do so with some individuals as a byproduct of their passion for their duties and their inherent desire to be deployable in their role with the rest of the squadron. And so we talk about someone's medical category, their medical employment category, their MEC code. And so if you are and that's on a scale of 1 to 5, and if you're a 1, that means you are fully deployable. If you are 2, you are deployable with some caveats or with some waivers. If you are 3, you are not deployable. And so there is a reluctance for some people to seek rehabilitation or treatment because they don't want to go onto a 3 code, and that would prevent them from doing their duties with the rest of the squadron.
What are the potential consequences for that aviator for not getting the correct MEC code?
Getting an inaccurate code?
Yeah, yes.
That would be emotionally stressful, I think. Sorry, is your question that they are maintaining a deployability code when they should not be?
Yes.
Right. I think that what are the consequences? So from a discipline point of view, or can you please rephrase?
From a health point of view.
From a health point of view, then that is obviously a concern. If someone should be non-deployable for their health condition and they have not been recategorised, then it's likely that, or it's possible that they haven't sought the treatment that they need. So it would be a case-by-case basis, but that's not a state of being that we would like someone to be at.
Thank you. And in responding to the question that you were asked in your notice to give the statement on stigma with respect to rehabilitation, you say that trust and communication is a a part of alleviating that statement. Do you accept that that's just one aspect of alleviating stigma, but not all?
Yes.
Do you accept that the MEC code itself can be stigmatising?
Yes.
And do you accept that individual welfare boards can be stigmatising?
That has not been my experience, no.
Do you have a view on the term individual welfare board? Do you think that it sounds slightly an archaic term to be using the word board?
It could be perceived in that manner, but I've not had that raised as a concern.
Thank you. I'm going to move to another topic. I referred before about the Inspector General, the Australian Defence Force report, and 75 has had an audit completed earlier this year and a supplementary audit, is that correct?
That's correct.
And operator, please display IGD.0003.0001.0635. And please go to 0646 and expand paragraph 39. Wing Commander, it was a suggestion, it's suggestion 9, to establish a suicide episode or suicide episodes file on objective, and that's objective to maintain all records associated with suicidal episodes to ensure documents maintained for future reference. Can you tell the Commissioners why that was suggested and perhaps what objective is?
Objective is an information structure. It's a filing cabinet electronically, if you like, for all of our records. If you just give me a second to read the suggestion. I believe the suggestion was made because we did not have a suicidal episodes file on objective, and that is one of the requirements associated with our records management.
And has that been implemented now, to your knowledge?
I understand it has, yes.
Have you seen it?
Not personally.
Should you see it?
No.
Why is that?
It's a records management function. It's not something I personally need to oversee.
Does it not record suicidal episodes?
Absolutely.
And did you not say earlier that you're accountable for suicide prevention?
I did.
So how would that data, wouldn't that data be helpful?
So I absolutely need to be across the data, and I'm across every single suicidal episode that occurs at 75 Squadron. But the implementation of that file and the record keeping is not something I do personally.
So perhaps I framed my question not well, but do you look at that data? Do you look at the record and see what's written in it?
So I'm intimately involved in any suicidal episode, and I review the documentation. I don't necessarily access it from that location.
I see. The supplementary report, the IGADF supplementary report, noted that seniors felt empowered by the commanding officer's clear direction, that's your direction, and are confident to handle discipline matters. How do you empower senior ranks?
To do
Well, they
what,
feel
sorry?
empowered, according to this audit report.
Mm-hmm.
What do you think you're doing to make to make them feel empowered, so that they're saying, "Well, I feel empowered"?
I think it's a function of trust. I think most aviators at 75 Squadron are doing great work and seek to do great work. They, like most of us, don't like to be micromanaged, and so where one gives clear guidance and direction but allows the workforce to execute towards that with best effort, then that is empowering.
And in fact, operator, please display MAR.1001.002.0074, paragraph 16 to A to D, and it says that morale is up by 22%. This was in the supplementary report. That's quite impressive, Wing Commander, that morale has increased that much. What do you think has accounted for how, why do you think that's occurred?
I think I explained before that 75 Squadron's been in transition from one platform to another platform, from F-18 to F-35. I think as a byproduct of that platform transition, there is an excitement in the air. It's a new start, new beginning, an opportunity to build foundations, to take the opportunity to rebuild processes, to jettison or to get rid of the things that you didn't like about the way business was done previously, and to implement new and innovative ideas, to take the opportunity to reflect on the current strategic environment, the roles and tasks upon us. It's a once-in-a-generation opportunity to rethink how we do business, and we did that. I think that provides an environment which is exciting, and that is reflected in the morale of 75 Squadron members.
And in terms of the data around, and this is survey data from the focus group discussions, or individual discussions, that was done as part of the audit around discipline training. There was concern around the adequate discipline training, and aviators being aware of their rights and obligations under the discipline system. Have you done anything in regard to those two issues? And I can pull it up for you if you like. IGD, it's that same document, operator 0636. Would you agree that it's important for aviators to know their rights and obligations under the discipline system?
I do.
And have you done anything in particular to address that issue?
Yes. Specifically on that issue, I believe the 75 Squadron Personnel Capability Officer, or PCO, ran an education campaign through the section heads in response to that, to ensure that our members did understand the military justice system and their rights within it. More broadly, I understand we implemented every audit outcome and recommendation from this report within a month or two of receiving it.
That you implemented, was that the 12 recommendations and the 9 suggestions? That was from the original audit report 2022. You're saying that you implemented all of those within a month. Sorry, did I hear you correctly?
Yeah, my understanding is within a month or two of receiving that report,
Yep.
we'd implemented all of those recommendations.
And is it correct that did you prepare a report in response to that audit report to the IGADF?
No report. What we responded was an acknowledgement of the report, and once the recommendations had been implemented, that we advised them that we had done that.
So simply telling them that you had implemented it the recommendations and the suggestions. Did the IGADF just accept that because you said that they had been implemented?
Yeah, I believe the IGADF trusted that if we said we'd implemented it, then we had. Obviously, we're subject to future audits, and if we had not done so, then I imagine that would be found.
And in terms of complaints and accountability, the supplementary report reported that some people, and not all, just who they spoke with, so I accept that, but some people felt that they would get into trouble if they went outside their chain of command to make a complaint, and assuming perhaps that that person who's their chain of command is the person who is the alleged perpetrator or the person that they're having difficulty with, you would then go outside of your chain of command. And there's a perception that it's not, seems to be a perception that it's not okay to go outside of the command. What have you done to rectify that, if anything?
To my knowledge, that has not been a widespread issue. For the most part, I'm generally comfortable that individuals are willing to report either in or around the chain of command as they see fit. Obviously, the fact that some individuals are uncomfortable is a concern, and is something that we need to and do address when we have a conversation with the squadron, be that a conversation with all of the squadron, or more importantly, through smaller forums, section forums, etc. So that's a continuing conversation. I think it's a continuing education. I'm not sure that you ever complete that task. I feel like that's something that we'll always work towards a complete and satisfactory understanding and comfort in reporting outside of the chain of command. But we're obviously not there 100% yet.
Thank you. And with respect to unacceptable behaviours and sexual misconduct, and this is the supplementary report as well, there is a comment that says most believe probably that not all unacceptable behaviours are reported due to fear and embarrassment. And I've asked you some questions before about under-reporting or not reporting, and you don't know what you don't know. It says confronting people about it can be daunting. Does it surprise you to read that?
For a start, I'm not sure he's got the opportunity to read it, and we're trying to find the reference in the document.
I'm happy to pull that up, Commissioners. And can I check?
Yes, that'll be useful.
Wing Commander, can I check you've read the supplementary report?
I have.
Thank you. MAR.1001.0002.0080. Apologies, Wing Commander, I didn't pull that up for you in front there. You can trust me that I'm reading it out correctly. Most people believe that not all unacceptable behaviours are reported due to fear and embarrassment. Confronting people about it can be daunting. Does that concern you?
It is a concern, absolutely. We seek that every single aviator is comfortable in reporting any UB that they either experience themselves or that they hear about, either anecdotally or that they observe. Any one of those should be a trigger to report, and we encourage individuals to do so. That statement is a concern and something that we'll continue to strive to improve upon.
Thank you. And on a more positive note, there's been an increase in the confidence in the chain of command to resolve complaints. What do you think has happened for aviators to feel like they can have more confidence in the chain of command? to resolve the complaints?
I think that is through action. So when unacceptable behaviour reports or complaints are raised, then it's what we do about it, it's what the squadron does about it, it's what I do about it, to satisfy that we do follow due process, we do consult individuals as they pertain to that particular event. We keep the complainant informed as to the both the conduct of the investigation and the outcomes, or the finding, and then the outcomes that are applied. And so confidence from the workforce that we are doing that, I think builds their trust in us in that regard.
Thank you. And in terms of diversity and equality, is that something that you take seriously at 75?
Absolutely.
And do you know the statistics for the numbers at 75 for the numbers of women, the numbers of Aboriginal and Torres Strait Islander members who identify as LGBTIQA+, and members of culturally and linguistically diverse backgrounds? Do you know those statistics?
Off the top of my head, I do not.
If you were to get them, where would you get them from for your unit?
I would likely ask my personnel capability officer to source those numbers for me, and I'm not sure where she would get them, but I imagine they would be readily available.
The Commission has heard evidence about priority populations, what that means is that there are certain groups of people in society and in defence that are in the general population, let me put it to there, that in defence, that there are certain groups that are at high risk of suicide, and I've mentioned women, and young people are also a priority population. So would it be helpful for you to sort of understand the statistics at 75 so you can turn your mind to that while you're in the role of commanding officer about who might be in those at-risk groups?
I think it's important for me to understand the people at 75 Squadron, to understand who they are and what their background is. It's important to note, I believe, that I don't get to choose who is posted to 75 Squadron. It's my job to build the team, the unity, the inclusivity of that team, whoever that is that's provided to me. In terms of steering the diversity on the squadron, that's outside of my influence. I work with the team I have, and I ensure and take the approach that a squadron identity is extremely important, and that everyone on the squadron, no matter their race, religion, ethnicity, background or sex, feels included in that unity of purpose. And so that has been my approach.
Thank you, Wing Commander, and the aspiration is welcomed, but my question was, do you know the breakdown, if you like, of the demographics at 75? Do you know how many are within the age bracket of 16-24? Do you know how many are women? Do you know how many are Aboriginal and Torres Strait Islander? Do you know how many people are from culturally and linguistically diverse backgrounds?
I do not have those statistics in my head.
Thank you. And have you prepared a response to the supplementary audit? Have you prepared a response to the supplementary audit at this stage of the IGADF audit?
No, so a response, yes. So we responded acknowledging the audit findings and advised that we had implemented the recommendations, and that was the extent of our action or correspondence, I should say, with respect to the IGADF team.
Thank you. And I'm just going to move to a new topic. I note the time, Commissioners. I'm leaving some time short for your questions, but I'm just wondering if I could just seek some extra time just to finish the last topic.
That's fine. Go ahead.
Thank you for that indulgence. I'm going to move to the topic around mental health, and I've already asked you some questions around that earlier on. Do you think that Defence has a responsibility to ensure mental health and healthcare services are available to members and families at 75?
Absolutely.
And that there should be timely access to those services?
Absolutely.
And there should be sufficient services?
Yes.
And at the moment, you mentioned before, and I was going to ask this of you anyway, there's no psychologist, is there, at the moment at Tyndall?
Correct.
And this mental health support seems to be limited to in this way, and not minimising the importance of these, but this is what it seems to from your statement, and correct me if I'm wrong. There's an 1800 I'm sick phone support number, which I understand is 24 hours. Is that correct?
That's correct.
Are you aware of any evaluation that's been done for your members, well, not your members, but the members at 75, in terms of the effectiveness of the and utility of that number?
I'm not aware of any evaluation in that regard, no.
And you've not instigated or initiated any local surveys to just ask about their experiences with those services?
No.
Would that be helpful to do?
I think there's a broad array of mechanisms that are designed to join individuals with mental health support that they need. The 1-800 I'm sick is just one of those paths. I think a holistic survey that covered all of them would be useful. Choosing any particular one would be less so.
A local survey that says, have you used these services? What was your experience? Did it help? Did it hinder? That would be helpful in terms of managing the welfare of the aviators at 75. Is that what you're saying?
If it was holistic across the various pathways to seeking support, then I think that would be useful.
Is that something you can initiate?
I could initiate it for 75 squadron personnel, yes.
Thank you. And operator, please display DEF quadruple 9.0031.0053, page .0108, and please expand paragraph 221. And come on, I'm just going to ask you some questions about these tables in your statement so that I can check that I'm understanding them correctly. You have a table there in 221, and that's for the number of mental health intake assessments provided by mental health professionals at Tyndall. Is that correct?
That's correct.
And I can see there that there were 45 in 2021. There were 20 in a 6-month period in 2022. And then underneath there's the Joint Health Command, Central Australia. The numbers there are 607 and 1,703. Now, are those numbers members at Tyndall that go and access the health centre at Central Australia, or do those numbers include other people in, say, Robertson Barracks or Coonawarra accessing them, or do you not know?
So the table and the data within it was provided to me by Joint Health Command. My understanding of that data is that it is based on intake numbers at those two centres, not where those people have come from. So it is likely that most, if not all, of the Tyndall Health Centre numbers are Tyndall personnel, and it's likely that the Joint Health Unit Central Australia numbers come from all around the Northern Territory.
And we might seek some clarification on that at some point, Wing Commander. And then similarly in 222, paragraph 222, that's the number, if we can have that displayed, please, operator, They're the numbers for comprehensive mental health assessments, is that correct?
That's correct.
And in 2021, there were, and noting what is written in paragraph 222 there, where it's difficult to separate comprehensive mental health assessments from treatment sessions, but there were 326 comprehensive mental health assessments done in 2021. Is that your reading of that table?
That's my understanding reading that table.
And they were self-referrals.
That's correct.
Does that seem to be a high number for the population at Tyndall?
The number seems high to me. I can't explain that.
That's fine, Wing Commander. I understand that you're not, from the health centre. Have you seen these tables before you asked them from the Joint Health Command in preparing this statement? Had you seen these tables before?
No.
Would information about numbers accessing Tyndall for mental health assessments or support be helpful in your task or your responsibility of managing the welfare of aviators at 75?
Yes.
Sorry, I don't wish to cause issues, but I'm not sure it's individual people as opposed to numbers of sessions when you read the text.
Commissioners,
It may not matter, but the questioning is suggesting one thing and I think the document is suggesting another.
I think I qualified that by saying that in the paragraph that it's difficult to separate comprehensive mental health assessments by treatment sessions.
It seems to refer to the total number of mental health sessions. If you look at the second last line of
Yes, mental health
paragraph
sessions.
222.
Yes. I'm happy to ask the question again. I'm also happy not to press it, Commissioners, given what the answer what Wing Commander has said. And the second question, Commissioners, I submit is more important, which is the question I asked about whether the Wing Commander gets this data and had he got it before preparing this statement, which the answer was no. So I'm happy to leave it at there, Commissioners.
Okay, thank you.
You mentioned open arms, and that reminds me that you also mentioned DVA when it came to rehabilitation. So I might just go back to that question as I remember it. And you say in your statement that it's important for those transitioning to be able to hand over their rehabilitation to DVA as they transition when they leave the ADF. Have you been to the DVA office yourself in Darwin?
I have not.
And in terms of open arms, have you personally visited open arms in Darwin?
I have not.
And have you asked the aviators or had discussions with them about their experiences with open arms in Darwin?
On transition from the ADF?
No, just in general conversation, because people can access open arms, can't they, without transitioning? So just put transitioning aside for a minute. Someone might be accessing counselling services at open arms while they're within 75, not transitioning.
I have not.
So is it fair to say that you wouldn't be able to, you wouldn't know whether those experiences are positive or negative for the aviators?
That's correct.
You referred to telehealth services at Tyndall. How good is internet reception? How good is phone reception at Tyndall?
If you're with Telstra, it's very good.
That's not an advertisement for Telstra. But if you're not with Telstra, then what's it like?
Yeah, Telstra is the only provider that you have good coverage at Tyndall.
So how can an aviator who might be on another carriage, a telecommunications network, how can they access telehealth services?
So telehealth services would, I actually don't know the answer to that. I know that we provide people spaces to access services remotely. I know the Tyndall Health Centre does that. I believe the chaplains do that. People can also access it from homes. So I expect that we would provide that connectivity, but I don't know the answer to your question specifically.
Are there landlines there?
Landlines have been mostly removed.
And do you know whether video conferencing sessions are offered as part of getting either psychology assistance or even rehab conversations with treating?
That's my understanding.
And what's the internet service like at Tyndall
It's good.
for everybody?
That's my understanding, that the providers are good.
Do you agree with the premise that mental health assessments are best done face-to-face?
I'm sorry, the Wing Commander's expert in a number of things, but I think this is moving beyond.
I don't think it really assists us much,
Yes,
does it?
I'll withdraw that, Commissioners. You refer to the low acuity ward at Robertson Barracks, and that's the Manunda, am I saying that correctly?
Manunda ward.
Manunda ward, thank you. Have you visited that ward?
I have not.
Have you spoken to any aviators who've been admitted to that ward?
I have.
And did you and without telling me what they said, but was the conversation, did you ask them about what their experiences were like there?
We talked about their experience through the entire process of admission and onwards referral, of which and treatment beyond that, of which Manunda Ward was a part of that conversation, but I didn't specifically interrogate Manunda Ward as you've described.
And I don't imply that the questioning would be in an interrogative way, but in a supportive way to find out whether or not it helped or hindered. Do you think that's a useful question to ask?
There are many questions I could ask along the path. My general approach to the questioning is, how was their experience? Was there any concerns about the process? And then I get feedback in that regard. If someone had a particularly positive or an outstandingly positive experience or negative experience through there, then I feel I've invited the opportunity for them to answer through that line of questioning.
And there are also wards at Darwin Hospital, mental health wards there. Have you visited those wards?
I have not.
And do you have a view about whether a member who requires an inpatient admission at a hospital where there's a mental health ward, so for mental health concerns, should have a choice of being transferred to a hospital close to a family member rather than to Darwin or Robertson?
Yeah, I think choice is always good, especially for someone who's under mental health stressors.
And can family members of defence members at Tyndall, can they access the health centre services at Tyndall?
No.
So do they have to travel to Katherine or to Darwin to do that?
That's correct.
And that would be the same for specialist appointments if a parent has a child that needs children specialist services for paediatrics or the like?
That's correct.
Do you think that the current mental health services offered at Tyndall are adequate?
Again, I object to that because it has a question within it that actually requires some sort of expert opinion.
I press that question. The Wing Commander is accountable for the welfare of the members at 75. And I would expect, Commissioners, that he would have some view as to whether or not mental health services would be adequate.
Do you wish to respond to that? I'm inclined to allow the question. He's likely to have a point of view, you'd think.
But what does adequacy mean? Is it
You can
clinically
explore that.
adequate? Is there enough of it? Are there enough people? There's a whole series of different connotations within the word adequate. And I'm concerned that if the evidence is going to help you, then it would have to be actually more specific than that.
Well, that could be arranged.
I'm happy to break it down, Commissioners.
All right. I'll allow the question.
Wing Commander, do you think there are adequate mental health staff, professionals based at Tyndall?
Sorry, I don't want to be overly difficult or pedantic, but is my friend talking about numbers or quality? Because the Wing Commander is not in a position to answer the second question. He may or may not be in a position to answer the first.
I accept that, and I'll ask it this way. In terms of the numbers of staff at Tyndall Health Centre, firstly, I'll ask you this. Do you know how many mental health professionals are based at Tyndall Health Centre?
I do.
And how many are there?
There is one reservist mental health nurse.
And is there anything else in terms of mental health practitioners there?
No, not to my knowledge.
Not to your knowledge. And do you think that one mental health psychiatric nurse, mental health registered nurse is sufficient for the amount of members located at Tyndall?
No.
Thank you. I asked a question before about families and access to services. What do you think are some of the other challenges that families face at Tyndall? And just generally, whatever you think are the challenges for families.
Remoteness is the most obvious one. The environment and the climate can be hard for people to get used to. Access to work opportunities for some spouses that are, Catherine's a relatively small town, and so if your profession does not align with the services that Catherine needs, then you may not have that opportunity. They're the few that come to mind.
Thank you, Wing Commander. And in terms of what is to occur following a suicide, do you have any policies or procedures in place to direct you or to assist you to know what to do in the event of a suicide?
Yes.
And in the event of a suicide, do you contact, and when I say you, someone in at 75, do they contact families or carers in the event of the suicide? Is that contact is made?
The next of kin is notified.
In the event of a suicide attempt, are families, or you say next of kin, or are they contacted in the event of a suicide attempt?
I think the threshold for notification is if someone is gravely ill. So I think it would depend on the nature of the injuries that are associated with the suicide attempt. I'd have to check the policy on that to be sure of where that threshold is.
And you provide some suggestions about how to improve things at paragraph 267 and 269 of your statement. I'll just find my place, Wing Commander. And if the operator can display paragraphs 267 and 268 and 269, thank you. How realistic do you think some of these recommendations are? And if you want to just refer to them individually, How realistic do you think they are? For example, getting a psychologist, is that going to happen?
I'll just take a second to review that.
Yes, of course.
2, 6, 7, 8 and 9.
Yes.
So my recommendation at the end of paragraph 267 is a general statement, and I would encourage any efforts that improve that. More specifically with 268 and 269, I do believe you asked about how realistic it is. I'm not in a position to answer that. I feel there is a need for a psychologist, or there would be benefit in having a psychologist locally available or available on a more regular basis at Tyndall. I'd have to defer to Joint Health Command or others to know the reality of that with the resources that are available. With respect to 269 and Airbridge, as I've stated, that is an ideal. I'm not sure that is achievable with resource or financial constraints, noting that Tyndall has had an Airbridge in the past, linking it to, well, I understand we had an Airbridge that linked Tyndall and Darwin to help support members and their families access medical services more quickly.
Because currently they would have to go into Darwin, would they at times maybe having to take leave to stay overnight?
That's correct. The tyranny of distance means that those services which are at Darwin and will likely remain at Darwin, it is increased time away to access them when it's a 7-hour round trip.
And going back to my question about face-to-face mental health assessments, you said that phone network can be difficult if you're not on if you're with certain providers. If you were able to have face-to-face mental health assessments, face-to-face mental health interaction sessions, that would overcome the issue of relying on technology that just simply may not work. Do you agree?
I'm not sure that the telephone access problem is an issue. My experience is that 75 aviators use telephone communications to access their social networks, and therefore would be able to do so for mental health support. Whether that is adequate or whether face-to-face engagement is the preference, my understanding is that for some individuals, face-to-face is absolutely not just a preference, but is required, at least early on in the treatment. But for others, telehealth may be sufficient. I think that is case by case, and that's the extent of my knowledge with respect to that.
Thank you, Wing Commander. Thank you, Commissioners. I have no further questions at this stage.
Thank you. Commissioner Brown?
Thank you. Could I just ask a couple of questions? First of all, if I heard you correctly, you said you've got 2 aviation medical officers for 75 Squadron. Is that correct?
Not quite, Commissioner. There are 2 aviation medical officers at Tyndall. We have one of those who is assigned as the primary contact for the squadron. We try and have the squadron doctor come to the squadron once a week, but otherwise members are presenting to the health centre to access one of those 2 doctors, 2 aviation medical officers. I believe there's an additional medical officer above and beyond that.
Sorry, I'm just trying to understand because we visited Tyndall and we went to the health centre and there was one GP was what we were advised. And then I was kind of hearing about these 2 aviation medical officers. So is that the totality of the medical staff at Tyndall?
The medical officers, yes, that's my understanding. And the 2 of those medical officers are aviation medicine trained.
So is there 3 doctors that are available to look after the health of the people at Tyndall, the members at Tyndall, and they spend some of their time doing aviation medicine, or is it?
That is my understanding in terms of the numbers and their roles, Commissioner.
Right, okay, thank you. I wanted to ask about families. What communication do you as the CEO for 75 Squadron have with the families of your aviators? And I guess I'm thinking there in terms of families being a source of information about concerns, about health, about injuries, that sort of thing.
Yeah, there's a couple of different mechanisms for that. At the start of a year where our main posting cycle's over the December-January period, so at the start of the year, say in January or February, we will invite all of the members and all of their families to the squadron to show them through what we do, to have a social engagement with them, to get to know one another to the extent that you can with so many people at one particular opportunity, but that's the start, if you like. And then the social activities that are arranged at Tyndall vary, and there are a lot of them, and most of them, or at least the majority of them, the families are invited to attend those activities. And so as a byproduct of the conversations that are occurring during those social settings, that is really informative to understand how a family is doing and if they've got any information or concerns that they're looking to pass. And I must say that I definitely don't seek or rely on me collecting all that information. That is, that human network extends all through the command chain to understand how families are going.
What about for single members, or indeed those who are unaccompanied, where those kind of social events and activities are not going to yield contact with the families? And I guess I'm particularly thinking, and I appreciate it wasn't Tyndall, but we heard from a family who had their son die by suicide earlier this year, and he had been in Darwin 18 months, and they had had no contact with their particular barracks or anyone from Defence. And you, I guess, can see, the challenge that is there for family members who are removed, particularly single members, and you're talking about parents. What's in place for that circumstance, for those families?
Yeah, so when you can't get a health check, if you like, from a family member, then I'm more heavily relying on an individual's peer group or direct managers to be, observing that individual both in the workplace setting and in the social setting. Some social activities, but very few are compulsory. So people can elect not to attend them. So it's possible that you have someone who is not as active socially and is seen more professionally. And I rely on those around those individuals to build that assessment.
Do you have any way of reaching out to the family members of single members at Tyndall under your command?
No.
Do you think there would be any value in having a way of reaching out to them and giving them, I guess, a communication point?
Yes, and I guess there are instances where we have and we do that. We don't do it as a general practice. On deployments, as an example, we would normally run a monthly phone call to family or next of kin just to check in with the family. If someone's having any particular health crises, then the members are invited to bring the family into the conversation. And so that might be another time that we contact the family, but generally it's not something that we've done.
Thank you. And I just wanted to ask about fatigue. You said fatigue is a constant stressor I'm assuming you're talking about 75 Squadron, not necessarily the whole of Tyndall, but, and you said you keep an eye out for them, and you encourage them, they need to raise their hand if they're fatigued. The reality is, if they raise their hand and take that time out, then as I think you indicated, it means more work on those who are remaining, which is going to be a pretty strong disincentive to raising your hand if you're a team player, which means you're probably going to stay and be more fatigued. So relying on the individual to raise their hand doesn't fill me with a great sense of confidence that you haven't got a very fatigued workforce out there. Is there any other way to tackle that problem?
Yeah, so we encourage people to raise their hand if they're overly fatigued. Another fatigue indicator that would make us take action regardless of them raising their hand or not would be a performance indicator. So high levels of fatigue will often, you'll see a performance change, or you'll see different behaviours in the workplace, and then I would absolutely expect those who are managing or leading someone with high fatigue level to recognise that and to do something about that. There can be a reluctance for someone to take time off, and there has been occasions in my command where we have told people that they're going to take leave and go do something different because they are, we're assessing that they are too fatigued and they need to take some time off.
But if fatigue is a constant stressor, does that not say something about the Defence Force, or about, I don't know if this is 75 Squadron Tyndall or RAF or the Defence Force, but
as I look across the squadron of 190 odd personnel, I see fatigue present in some sector or other, in some individuals or other. There is always fatigue on the squadron. Our job in managing people is that at an individual level, that fatigue is not always there. So if the fatigue is always there at an individual level, then I don't think we're doing our job right. But fatigue as a stressor on the workplace is always something that we are watching, observing and looking to manage.
We've certainly heard, I guess, a lot about fatigue, and I'm talking about across our visits across the Defence Force, so it is something that I guess is of interest to me. Can I ask one last question, changing the subject? You talked about an air bridge. I'm assuming that means a plane to take people from one point to another, and you indicated it is available for families, or is it just for members?
There is no air bridge between Tyndall and Darwin.
Oh, okay.
Yep.
So that was what you would like to have?
That ideally, that would be that would reduce the tyranny of distance and provide access to services much more easily. And I understand that at a point in the history of Tyndall that an air bridge existed, given resources, then yeah, that would be ideal.
And when that existed, was it available for families even though they weren't having treatment within the defence medical system?
I understand it was, and currently what we do to support families travel to Darwin to access those services is organising the travel and the accommodation and the meals and incidentals, etc., to help those families access those services. But that doesn't reduce the time associated with doing so.
Okay, thank you very much.
Thanks, Commissioner.
Thank you. Commissioner Douglas.
Thank you, Wing Commander. I'm sure you'll be pleased to hear that I don't have any further questions.
I just have one very quick one, and I am very conscious of the time. Thank you for your patience. We have gone over time. As Commissioner Brown said, and it has shown up in the surveys that we've seen, and we've certainly heard it from the floor, from the rank and file, overwork is an issue with people being fatigued and so on, and it certainly leads to problems. I'm wondering if you, at any point in your working life in the Air Force, have seen a zero-based exercise to assess the work that's required, the number of people required to do it, and therefore making an assessment as to arguing for more staff or different staff or staff in different places. A zero-based assessment, has that, to your knowledge, ever been undertaken?
Commissioner, I'm not entirely tracking what a zero-based assessment is.
It's basically an assessment where you come in and say, green fields, look at what work needs to be done, and then estimate the number of people required and where they're required to be, and then configure what may exist. It doesn't stick, you don't leave it as it is.
Understood. The tasks vary, the output and the objectives for any particular activity can be complicated, and so that activity in itself is challenging. That being said, in my experience within 81 Wing, so one above from me, the 81 Wing headquarters, so the broad F-35 enterprise, there has been an assessment on the workforce numbers that would make us more healthy and sustainable for the output that is requested of us. So those numbers exist within the 81 Wing workforce as a request that has occurred up to the higher levels of the Air Force.
And did you recall how long ago that was? Was it years and years, or?
No, that was last year.
Okay, thank you. I think we'll probably be looking at that.
Thanks.
Thank you. Ms. Chalmers, any questions? No. Thank you. Mr. Fraser, any questions?
No, thank you, Commissioner.
Thank you. Mr. Fordham, any questions?
No, thank you.
Ms. Bridges, are any matters arising?
No matters arising, Commissioner, and the witness can be released from his summons.
Thank you, Wing Commander. We appreciate the evidence today, and we appreciate the amount of effort you've put into your statement and gathering the information for us. Thank you. We need to break for a couple of minutes before we come back to close. Sorry, you were going to say something?
No, Commissioner.
Okay. We'll break very, very briefly and come back to close. Thank you.
All rise. The Royal Commission is adjourned. The Royal Commission into Defence and Veterans Suicide is resumed. Please be seated.
Thank you, Mr. Singleton.
Commissioners, the last duty before the closing is to tender remaining items that came up. I'll ask the operator to bring up the final tender list. Before tendering that material, just in the last session, a number of the documents were tendered on a confidential basis pending resolution of confidentiality claims. We're always working behind the scenes for you, Commissioners. One of those documents is the subject of a resolution, and I can now ask you to receive it as an open exhibit. That was item number 19 on the, what I'll call the Parker tender list, which was DEF.1073.0001.0942. If that could now be received as an open exhibit.
Thank you. It'll be so accepted.
Turning to the list on the screen, there are 11 documents. I ask that they all be received as open exhibits.
Thank you. They'll be accepted and allocated the next lot of consecutive numbers.
Commissioners, we wish to commence our closing remarks for this session by thanking our lived experience witnesses, whose courage we salute and whose evidence reflects many of the themes of this hearing block and this Royal Commission, and is therefore of great value. John and Robin Halloran are the parents of 21-year-old Private Thomas Halloran, who tragically died by suicide on the 26th of April this year. We heard that Private Halloran was a talented, adventurous young man who suffered injuries early in his army career. For some time he did not seek medical support for fear of the impact that would have on his career progression. When he did seek help, little rehabilitation planning or support was provided. Private Halloran began self-medicating, encountered disciplinary issues and experienced bullying, including being called a malingerer. It is notable that this term has featured so often in our inquiries, even though it is not a term commonly used by the general population in ordinary conversation. Mr. Halloran spoke powerfully about the negative impact that this word had on his son and the toll that it took. The evidence draws attention to the fact that the term malingering actually appears in legislation, a matter warranting further consideration. The Hallorans also spoke of the way that they had learned of their son's passing. Their evidence was moving and powerful, courageous and valuable, and gratefully received. Paul Walker, a proud Aboriginal man, was the other witness called on the basis of being lived experience in the sense that we've previously described. He also testified courageously, and we heard of his purpose and pride in service, of his unexpected exposure to a hostile incident, and of the enduring impacts. We heard of a lack of support from his colleagues, and we heard about the minimising, unsupportive and harmful response that Mr. Walker received from officers and peers. His evidence points invaluably to matters that warrant further inquiry, and those matters are receiving attention. This Commission has been seeking to understand relevant issues from many perspectives. The testimony of individual ADF members, serving and former, and their families is one of those perspectives. Academic and expert study is another. Testimony about life on various ADF bases is yet another. The perspective of ADF leaders, of service members' organisations, and of the DVA and others are all being explored. During this hearing block, you heard from a panel of witnesses who are stationed at RAF Base Tyndall and play key roles in the running of that base and supporting those who work there. In the last few hours, you have also heard from the commander of one of the 2 squadrons based at Tyndall. And last week, you heard from the commander of HMAS Coonawarra, a naval base that operates the naval port in Darwin and hosts and supports various other ADF units. You have heard about challenges and benefits specific to those serving at Tyndall and in the top end, including as they affect a younger than average population. They include strong community and better than average morale, but also isolation, a fishbowl life, and scarcity of community services, and not just for service members, but also for their families. Mental health practitioners in the Northern Territory spoke of the pressure on their services and the real gaps that may be left when some, or indeed any of them, retire from working with veterans in the Territory. They spoke of difficulties in providing care as needed, in receiving full information, in handovers from open arms in acute situations, in completing extensive paperwork, and in the DVA healthcare system's reliance in part on service providers' generosity. The evidence canvassed needs to develop the evidence canvassed the need to develop greater military cultural competency for more professionals and the utility of mapping veteran knowledgeable clinicians, psychologists and psychiatrists. Commissioners, you heard from a panel of 4 witnesses concerning recruitment, 2 from Defence, 2 witnesses from Defence and 2 from the private sector. They focused on marketing and advertising in the context of an at-risk population for suicide and suicidality within Defence, and addressed how advertising sells the prospect of a career in the ADF to a target audience that primarily comprises 16 to 24-year-old Australians. How Defence advertises and recruits its members is of significance to this Royal Commission, given that young people are at higher risk of suicide once leaving the ADF. As with all the evidence, we anticipate making submissions at a future time with respect to the evidence the Commission has heard about recruitment. 3 panels discussed deployment issues, respectively critical incidents, waivers and post-deployment processes. On each occasion, we examined the policies, their implementation and any barriers to their practical application. Some of the themes arising from those panels include the absence of a clear definition of critical incident, low numbers of deployed psychologists, that waivers occur on the basis that personnel are mission critical, even when a waiver is not supported by medical staff, the absence of consistent policies, and the inherent tension between a decompression period and a member's desire to return home quickly. Commissioners, we heard from 2 representatives of the Northern Territory Government who candidly reflected upon the Territory's express encouragement to veterans to settle here, the fact that they and their families do have particular needs, and the fact that few veteran-specific measures are in place to meet those needs. They also noted that a new veteran strategy is now in development and gave us some information about the current draft. I cannot capture here and have not captured all the evidence, valuable as it is, that the Commission has heard here in Darwin, but conclude by thanking all those who testified, whether military or civilian officials, professionals and experts, or individuals, such as veteran Justin Huggett and Professor Bradley Murphy, both of whom testified movingly and powerfully. For many, service with Defence is a positive and empowering experience, but the Commission has also heard during this hearing block that for others who experience difficulties in some of the realities and limitations of service life mean difficult situations are compounded and the ability to seek help or early intervention may not always be practicable or available. These and other issues will continue to be examined by those assisting you. Commissioners, the work of those assisting you will continue. Most of our work is not done in the hearing room, but in preparation, research and investigation. I conclude by once again urging all those in the community, in or outside the ADF, who have information that may be relevant, to contact us. All contacts prompt review and research and other appropriate inquiry. Finally, I note that you, Commissioners and senior public officials, have entered into a formal agreement that now gives further protections to those who wish to provide information to the Commission. Strong confidentiality and other protections are in place, and people can be confident that they may engage with us in confidence. Commissioners, we will continue to assist in future hearings.
Thank you, Mr. Singleton. As we wrap up our 7th public hearing, we'd like to thank everyone who has engaged with us during our time here in Darwin, and would also like to announce some details about our hearings next year. This visit to the top end has been extremely valuable, In the past 3 weeks, we've learned a great deal about some of the challenges faced by current and former serving members in the Northern Territory, the intense heat and humidity being one of them. At this time of year, we must offer our utmost respect for those who serve and train under these difficult conditions. During these 7 days of hearing, we've heard evidence about defence recruitment, what happens following critical incidents during deployments, and the service model provided by the DVA's Open Arms Veterans and Families Counselling Service. We also heard about the experience of the men and women posted to HMAS Coonawarra and the RAAF base Tyndall, and we were pleased to hear more First Nations perspectives on ADF service. Excuse me. Public hearings are an extremely useful way to gather evidence. They bring public attention to particular themes and issues being investigated and provide some transparency to the work of the Commission. But taking evidence in a public setting is just one way we gather information. It is important for everyone to understand that what we air in public hearings is only one part of how we are probing organisations, individuals, systems and processes. A key function of the Royal Commission is to gather a wide range of evidence and information in order to make recommendations to the Australian Government. We also gather information by other means, including hosting roundtable discussions with stakeholders, visiting military bases, conducting and commissioning research, holding private sessions with people who have lived experience, reviewing submissions made by members of the public, consulting with local communities and experts, and by using our special powers to issue compulsory notices requiring the production of documents or information. We have issued around 490 notices to produce and notices to give. Analysis of that information gathered continues out of public view, but is critical to inform our various lines of inquiry. In the lead up to the Darwin hearing, we conducted 16 private sessions and hosted a roundtable discussion about the crucial role First Nations personnel play in Norforce, the Army Reserve Regiment that conducts surveillance and reconnaissance in remote Northern Australia. We've also met with many defence and veteran organisations, groups and community leaders to listen to their experiences and expertise, to learn about the valuable work they're doing in the community, and to ensure we're hitting the mark with our inquiry. We also visited Larrakia Defence Precinct, including HMAS Coonawarra, RAAF Base Tyndall and Robertson Barracks, where we spoke with serving personnel and gained further insight into life on those bases. All this information can often be more revealing than what we hear during hearings, but no matter the material or how it's received, it equally informs the work of the Royal Commission. As stated by Council Assisting, and as always, the lived experience of Defence members, veterans, their families and friends sits at the core of this Royal Commission and continues to be of critical importance to our inquiry. We thank those with lived experience who bravely told their stories to the Commission in Darwin, both publicly and privately. We'll continue to offer counselling and other support to them, and indeed to anyone who may be affected by this hearing over the weeks and months ahead. Pleasingly, we've received 93 submissions since this Darwin hearing began, including 26 from current serving members. I want to again encourage anyone who has lived experience of the military to please make a submission. Each story matters and will help inform our final recommendations to Government. The Chief of Defence Force has given public and private reassurances that no serving member will be penalised for speaking to the Royal Commission, and there are protections in place for people who wish to engage with us. As Council Assisting mentioned, we Commissioners have now entered into a formal agreement with senior public officials that give further protections for those who wish to provide information to the Commission. As we have previously announced, our next public hearing, Hearing Block 8, will be held in Wagga from the 28th of November. Our public hearing schedule has changed slightly. We'll now be visiting Perth in the first half of 2023 and Melbourne and Adelaide, along with other major cities in the second half of that year. Exact dates will be announced closer to that time. To those who have joined us for the last 2 weeks, Ms Chalmers and your team, thank you for being with us. Mr Fordham, we'll meet again, I'm sure. And if there are no other issues, will adjourn now. Thank you, everyone, and safe travels.
All rise. The Royal Commission into Defence and Veterans Suicide is adjourned to Monday, the 28th of November, 2022.